for giving me this great opportunity. Today, I will be presenting a systematic review which we conducted to identify hypertension as a missed modifiable risk factor for diabetic neuropathy. Now, going ahead with it, we will be discussing about the introduction, the aims and objectives, the methodology, the results, and possible pathogenesis on how hypertension affects diabetic neuropathy, and some conclusions and take-home message. So going ahead with it, we all know that the past 2 decades have seen a paradigm shift from the infectious to the non-infectious diseases, with them being the major contributor to mortality and morbidity now. Diabetes and hypertension stand among the top non-infectious diseases, affecting around 34.2 million and 1.28 billion people respectively. The literature on impacts of diabetes on hypertension and vice versa is growing over the past few years, and now the growing body of evidence identifies hypertension as a risk factor for diabetic neuropathy. With this systematic review, we tried to compile the literature establishing relevance of hypertension as a risk factor for diabetic neuropathy, derive some possible pathogenic mechanisms which could contribute to it, and describe evidence-based, precise, individualized management for diabetic neuropathy, which covers the same. Going about the methodology, just like any other systematic review, this was planned according to the PRISMA guidelines. We went ahead and found literature on PubMed, Scopus, and Embase. A total of 56,698 entries were found out. We went ahead with our search terms and defined inclusion and exclusion criteria, and came down to a final of 24 articles, excluding the articles which were not directly concluding, had ambiguous conclusions, or the articles which were in other languages than English. The results were very staggering. Hypertension poses to be the leading modifiable risk factor for development of diabetic neuropathy, specifically diabetic peripheral neuropathy, because it has been shown to produce abnormal nerve conduction parameters and increased vibration perception threshold, both in animal and human studies. The most recent addition to this has been a study by Cheng et al., who reported that hypertension is a significant independent risk factor for diabetic peripheral neuropathy with an odds ratio of 1.829. There were 24 studies. Due to the constraint of time, we won't be able to discuss all of them. I've picked the 8 most important ones. In a study by Kimberly Forrest et al., hypertension was shown to have a relative risk of 3.92 with amplifying the effects of hyperglycemia. The proposed mechanism they gave was decreased sodium-potassium ATPase activity and altered polyol pathway. The other study by Tesfaye et al., they described that presence of hypertension was the strongest contributing risk factor to progression and development of diabetic neuropathy. Another study by Elliott et al. Identified that the patients who had hypertension had significantly high number of disturbed vibration perception thresholds. So this was a clear indication of the effect of hypertension on diabetic neuropathy. Another study also describe that hypertension and diabetes, when they come together, they can cause exacerbated nerve blood flow disorders, conduction slowing, and axonal atrophy. Now the other studies by Visser et al., Tesfaye et al. And Cheng et al. Also described that hypertension in a patient of diabetes not only progresses the severity of diabetic neuropathy, but also the chances of getting diabetic neuropathy are increased by up to 2.54 folds. And the odds ratio for the relationship was significantly higher in all the studies. Compiling all the studies, we decided to put up a probable pathogenesis on how both the things correlate and produce the effect. As we all know that diabetes mellitus is known by the phenotype of hyperglycemia. Now that hyperglycemia dysregulates the ETC, increases the NADPH oxidase activity, which increases the reactive oxygen species, leading to the oxidative stress. Now this in turn leads to development of diabetic neuropathy. The other things which contribute are formation of the advanced glycation products, which cause endothelial injury, atherosclerosis, arterial stiffening, and hence contributing to the diabetic neuropathy by affecting the microvasculature. Hypertension, on the other hand, by increased blood pressure and the turbulent blood flow, also causes endothelial injury and thus contributes to this. Various animal model studies have indicated that hypertension in patients of diabetes or in animal models which had diabetes actually increased nerve morphogenic parameters, caused nerve ischemia, increases the MMP, and also caused axonal atrophy. So from this evidence, it's quite evident that hypertension exists in most of the patients of diabetes and significantly contributes to diabetic neuropathy. To a disease like diabetic neuropathy, which not only has a big burden but also contributes significantly to the morbidity, we don't have a FDA-approved treatment yet. We use drugs which are repurposed, but somehow we have missed the very simple thing, hypertension. And controlling that may contribute in ways more than what we can think. Now, just controlling the glycemia and maintaining a good glycemic control, these are the areas we can help with. And if we start antihypertensive treatment and manage the blood pressure more aggressively, then that can contribute at this all levels, decreasing the blood pressure, decreasing endothelial injury, decreasing the arterial stiffening. And this story does not end here. Antihypertensive drugs like ACE inhibitors also act on the RAS pathway and contribute at other areas too. They help decrease the effects of hypertension and also decrease the oxidative stress. So the conclusion is that the results highlight missed role of hypertension as a risk factor for diabetic neuropathy. We therefore advocate that with good glycemic control, we must control the blood pressure as well. Here's the summary, and I'm up for the questions. Thank you.
Thank you, Yashendra. So, thank you for your presentation. You have reviewed almost whatever data is available in the field. What you can think can be the pathophysiology behind it? So, what can be the pathophysiology behind it? How the hypertension is increasing the neuropathy?
Sir, we have tried to devise a possible pathogenesis covering all what we what we could assemble from animal and human studies. As we all know that hyperglycemia is diabetes is known by the phenotype of hyperglycemia, and hyperglycemia contributes to dysregulation in the
hyperglycemia. You have talking about hypertension. So yes, how hypertension is producing more neuropathy?
So actually, as we know that increased blood pressure causes turbulent blood flow, and that turbulent blood flow causes endothelial injury. So that causes decreased blood flow to the nerves as well. And hence, in a patient of diabetes mellitus, when there is the phenotype of hypertension too, there is enhanced progression of diabetic neuropathy.
Okay,
except that, sir, hypertension in animal models has been shown to increase the MMPs. It has been shown to increase axonal atrophy and also disturb the nerve morphogenic parameters.
Thank you, Yashendra. So, coming.
A brief comment about the methodology, because you have not specified how you went ahead with the systematic analysis.
Yes, sir.
And there is a lot of heterogeneity as regards to the studies that you have selected for it, because some are cross-sectional studies. So, yeah. So,
yes, sir.
Yeah.
Thank you for pointing that out, sir. Due to the constraint of time, I could not elaborate much on it. I'll just go ahead and explain it. So there were very limited number of studies on effect of hypertension on diabetic neuropathy. But as you know, there's like a category of literature describing nephropathy and retinopathy, but neuropathy was majorly skipped. There were only a few human studies describing that, and as per the Cochrane methodology of systematic review, we could not have conducted that without having at least 8 studies. So what we did was we decided to include the animal models as well, because recent studies were indicating findings which were not implied to humans yet, and therefore we broaden the scope of this review. To enhance the quality assessment, we used different checklists for particular study design, including the Newcastle Ottawa checklist for cohort studies, the JBI checklist for cross-sectional studies, and we used the circle checklist for animal studies. So each study was analyzed by a particular checklist to ensure that only the top quality studies were included, and the conclusions made can be easily generalized.
Okay, thank you.
Thank you.
So now we'll go with the next one. It is predictors of early mortality and readmission in alcoholic cirrhosis patients presenting with acute decompensation. So Shushrut Ingawale. So is there? Yeah, please do come in. So we can go with the next one? Okay. So Dr. Ingwale has some issues with his laptop. So we'll go with the next one. Effectiveness of triad model approach in rural diabetic patients. Mohammad Mujammal. He's there? Rohit Jacob. Okay. Lohita. Acha, Rohit Jacob. So you're coming? Please do come in.
Those who are present, please load their slides so that they can be quick, because we have too many papers and we need to finish on time. So any next presenter is around, so please load the slides.
Vishwa B. Unakad, he's there. Shishendu Pal, Dr. Shishendu Pal. Yes, sir, please, go ahead.
Sir, your slides are loaded, I think, no? Loaded, great, great. So, sir is going to talk about NSTEMI as a low backache in a patient with diabetes. He's a senior consultant from Kolkata. We welcome you, sir.
At the outset, I'd like to thank everybody for being able to present the paper in Visakhapatnam. Okay. My topic, NSTEMI as low backache in a patient with type 2 diabetes mellitus. Background, we all know STEMI is a common complication of type 2 diabetes. It has higher 1-year mortality and adverse cardiovascular outcomes. It may have a variety of presentations, including silent MI and pain in the upper back. Coming to our presentation, he was our medical superintendent where I had been working, and he was aged 54 years, presented with sudden severe low backache. It was the day of the earthquake, and he was busy coordinating various departments. He was having pain for 2 hours, which was initially mild and then suddenly increased. It was in the evening. We were also very tired. I was feeling very weak and looked pale. He vomited repeatedly and was sweating profusely.
Sir, 1 minute. I think your mic is not working. Because you used the word on the day of earthquake, I think they are giving the background music.
rate 110 per minute, a blood pressure 110 by 80 millimeters of mercury. The respiratory rate was 27 per minute, and he had an oxygen saturation of 97% in room air. Physical examination revealed first sound was normal, second normal, he had a fourth sound, lungs were clear, abdomen soft, and he had peristaltic sounds normal. Investigations, the ECG, the first ECG was normal. We had to go for serial ECGs, but all of them were normal. Troponin I was negative, but repeat troponin I after 6 hours was positive, 0.91 nanogram per ml. His complete blood count, liver function test, kidney function test, amylase, lipase, and ultrasounds were normal. Echo showed inferior wall akinetic segments, reduced ejection fraction. We had also done an MRI, showed this protrusion at L34 and L5S1. There were osteophytes, evidence of nerve compression, and radiculopathy. Unique feature of this case, we all know, female patients do present with upper backache as myocardial infarction. Men with STEMI presenting with low backache is very rare. Only few have been reported so far. And so I would like to share my message that diabetes increases the progression of atherosclerosis. NSTEMI is a common complication of type 2 diabetes, and we should remember this. And besides presenting as silent MI or pain in the upper back, it may also present very rarely with a low backache. Thank you, sir.
Thank you, sir, for that unusual presentation. And any literature research, sir, did you do? How many cases like this, low backache?
So as far as I could go through, there are 3 previous cases. This was the 4th one.
Great.
Great, sir. It was rather we are getting a lot of unusual presentations of chest pain. So it was a great insight. Thank you, sir.
Yes.
Good. Thank you, Dr. Pal.
Thank you, sir.
Dr. Rohit, you are ready now? Please go ahead.
Check one. Hello. Check one. Check one. Check one. Hello.
Hello. A very good morning to one and all present here. The age-old telmisartan still remains the topmost priority of our Indian prescriptions even today. But little do we realize that prescribing a medicine is not just the role of a doctor, but to ensure a 24-hour complete control of blood pressure. This thought led to the foundation of our study, effect of antihypertensive drugs on circadian variation of blood pressure measured by ambulatory BP monitoring in controlled hypertensive individuals. Before we start, it is necessary to understand the circadian pattern of variation of blood pressure. It is characterized by an increase in the early morning hours, which is known as the morning surge, high levels during the daytime with peak values between 10 a.m. and 12 noon, an afternoon fall, and a clear nocturnal dipping. If you look at the blood pressure control, the control lies with the suprachiasmatic nucleus of the anterior hypothalamus, mediating through the release of hormones from the hypothalamus or through efferent neural pathways. The aim of my study is to determine the efficacy of various antihypertensive drugs on circadian variation of blood pressure. Objectives: to determine variations in blood pressure throughout the circadian cycle, to analyze the variation in circadian rhythm due to various antihypertensive drugs. It was a hospital-based cross-sectional study consisting of nearly 310 candidates arriving at the outpatient department of a private hospital. The study duration was nearly 2 years. All office-controlled hypertensive patients attending the medicine OPD at a private hospital were considered for the study. The inclusion criteria was age more than 18 years, hypertension since at least 1 month. Exclusion criteria: pregnant women, shift workers, heavy drinkers, heavy smokers, heavy exercisers, cardiovascular disorders like unstable angina, heart failure, stroke, life-threatening arrhythmia, atrial fibrillation, nephropathy, and morbid obesity. Now, this flowchart suggests how the study was conducted, wherein the patient comes as the first visit to the hospital OPD. We screen the patient and see for how long the patient is having hypertension. If the hypertension is since at least 1 month, then inclusion and exclusion criteria was applied. They were selected as the target population on the basis of the office blood pressure measurement, which was taken as an average of 3 readings, systolic and diastolic blood pressure. Those patients were then subjected to an ambulatory BP recording, which was incidental, and if it was assumed to be less than 130 by 80 millimeters of mercury, they form the selected candidates. And these selected candidates were subjected to ABPM for 24 hours, where the daytime time duration was from 6 a.m. to 10 p.m. and night from 10 p.m. to 6 a.m. So total number of candidates assessed were nearly 310, and mean age of candidates was nearly 49.93 years. Now, before we come to the results, it's important to categorize the patient as per the nocturnal pattern of blood pressure variation, where if the patient is having a normal elevation, nocturnal elevation of less than 10% drop in blood pressure, that is characterized as a surge in blood pressure. If the nighttime dip in blood pressure is more than 10% of the daytime blood pressure, it is considered to be normal. If the nocturnal drop is more than 20% of the daytime blood pressure, it is considered as a dip. Now, if you look at this, every patient we prescribe medications as per a single drug therapy and a combination drug therapy. Now, we have categorized each of these drugs in different categories. Along with that, we have compared it with once a day, twice a day, and thrice a day duration to find out how much surge, normal, and dip pattern was seen. So the surge was seen maximum with ARB, single dose, once a day usage. Calcium channel blockers, where once a day and twice a day dosing suggested a surge pattern. Beta blockers, also once a day dosing, suggested a night surge pattern. And similarly for diuretics, twice a day dosing, surge pattern was observed. The most commonly used antihypertensive drug during our study was amlodipine and telmisartan. Now coming to the combination drug therapy, where AC with ARB, ARB with CCB, and so on and so forth was compared, highlighting one point where ARB and CCB were used as the most common combination drug. Maximum dip, maximum normal pattern, maximum surge was also seen. But however, it's important to realize that the nocturnal dip cannot be finalized on the basis of whether we are prescribing single or combination drug therapy, because various other confounding factors still play a role in it. So on comparing the nocturnal pattern among candidates taking single versus combination, dip was found to be in 31.7% patients on single drug compared to 38.6% patients on combination therapy. To conclude, we have found a less incidence of the dip and surge in patients treated with combination drug therapy compared to the patients of single drug therapy for hypertension. So on a daily practice, it may be difficult for us to use ambulatory BP monitoring for all patients, but patients who have high fluctuations in blood pressure, ambulatory BP monitoring should be a priority, and that is how a time and range control of blood pressure should be evaluated, and that should be targeted. Thank you.
Good study. And so what is your final comment? What is conclusion of the study?
So the conclusion of the study is that whenever we prescribe a combination drug therapy, what we do is a patient comes to the morning OPD, we check the blood pressure, and then after 7 days when he comes, we again check the daytime blood pressure. But we forget to assess whether there is a nighttime dip or a surge, which contributes to various cardiovascular comorbidities. So in patients who are on combination drug therapy, at least once an ambulatory BP monitoring for a 24 hours should be done so that we can find out whether there is a nocturnal dip, surge, or a normal pattern.
Okay, good. But only 24-hour ABPM is not enough. In 24-hour ABPM, the biggest drawback is that the white coat effect is not negated. If you do for 48 hours, then only you will be able to find out. Because a lot of white coat effect is there.
Right.
Good study. Thank you.
Good insights. And I think it is very pertinent that we should be taking over more and more of ambulatory blood pressure monitoring. So it's a good study overall.
Well done, Rohit. It's a very practical, clinical-based study. We appreciate it.
Thank you, sir.
Okay, thank you. So the study is predictors of early mortality and readmission in alcoholic cirrhosis patients presenting with acute decompensation. Over to you, Shushruth.
Somebody should come and help me.
Hello. Yeah, am I audible? Thank you. Good morning, respected judges and fellow audience. I'm Dr. Shushruth Ingavle, here to present my study on predictors of early mortality and readmission in patients with alcohol cirrhosis presenting with acute decompensation. Alcohol is the most common etiology of liver cirrhosis in India. Liver cirrhosis may decompensate at any point of time. It may be either acute decompensation or it can be acute and chronic liver failure. There are more studies available for early mortality in acute and chronic failure, but there are only few studies that focus on early mortality in acute decompensation. So this study was planned with the primary objective to study the clinical characteristics, lab parameters, and outcome in alcoholic cirrhosis patients presenting with acute decompensation, and to determine the predictors of early mortality and readmission. This was a single-center prospective study in the general medicine and GI wards of a tertiary care hospital over a period of 20 months. The sampling was by complete enumeration and it was ethically approved. The sample size was 167. So the inclusion criteria was all patients of alcohol-related liver cirrhosis admitted with first episode of decompensation were screened. The definitions used were significant alcohol for more than 210 for men and more than 140 for women. Liver cirrhosis was diagnosed based on standard clinical, radiological, or endoscopy criteria. These patients were then followed up for mortality or 90 days, whichever is earlier. And exclusion criteria was 15 patients excluded because they lost to follow, 60 patients because they were ACLF, and 43 patients because they had prior decompensation. So we had 167 patients for final analysis. Case record form included this data, and we used the following prognostic scores for analysis. So 167 patients, mean age was 46 with standard deviation of 10 years. 97.6% were males, and most common presentations were ascites, jaundice, GI bleed. 30-day and 90-day mortality was 18.56% and 32.34%. Now, this was something interesting that we found, that patients who present with ascites as the predominant symptom versus patients who present hematemesis as the predominant symptom, when we compared, we found that patients with ascites had more of associated jaundice, cirrhosis, hepatic encephalopathy. Even in the lab parameters, sodium, potassium, albumin were more deranged as compared to patients presenting with hematemesis. The CTP score, MELD sodium score were also worse for patients with ascites, and 90-day mortality was also higher for patients with ascites, and this was statistically significant. When you compare this Kaplan-Meier graph, you also see that green line is the ascites patients presenting with ascites as predominant, have higher deaths compared to patients presenting with hematemesis. We further went ahead and did univariate analysis for predictive factors, and we found these factors to be predictive of early mortality for 90 days, which was age, duration of alcohol intake, hepatic encephalopathy, AKI, hemoglobin, TLC, sodium, creat, albumin, protein, PTINR, and all scores were significant. But then further we wanted to find which score is more indicative. So we did a ORAC for all the scores, and we found that CLIF CAD score had the best discriminatory performance for 90 days mortality. And CLIF CAD score of more than 71.5% being 99% specific for mortality. So patients presenting with ascites versus varicose bleed, the presentations were similar as study found by Shah et al. Patients with ascites had higher 90-day mortality compared to patients presenting with varicose bleed without ascites, as is similar with Ziprich et al. And risk stratification of patients based on clinical stages helps to predict the clinical outcomes and plan further management, as proposed by D'Amico et al. To conclude, decompensation with ascites has a poorer prognosis compared to decompensation with GI bleed. CLIF CAD score is the best predictor of mortality at admission in alcoholic patients presenting with acute decompensation. Prognostic factors can be high age, longer duration of alcohol intake, presence of hepatic encephalopathy, anemia, low sodium, hypoalbuminemia, high CLIF CAD score. There were limitations to my study as well. We only included admitted patients. That is why possibly we missed out the mild patients, mild decompensated patients which were treated on OPD biases. This creates a selection bias which we would like to rectify based on further studies. These were my references. Thank you.
Thank you, Sujit. How do you classify mild and moderate and severe acute decompensation? Just for our knowledge, can you define those?
Sir,
Because you said that's one of your limitation. Mild acute you did not include. So what is the definition?
So what we are trying to say in that is the scores. So when we are using either CTP score, MELD sodium score, or CLIF CAD score. So if we go by CTP score, class A, that will be mild, 5 to 6 score. B will be 7 to 9, and more than 10 or more will be severe. So when I'm saying that most of the patients, because they were endured, were either class B or class C. Class A patients were mostly Thank you, sir.
So next, ये मौजूद है मोहम्मद मुजम्मिल, हाँ? मोहम्मद मुजम्मिल.
Siddharth is there? Dr. Siddharth?
सिद्धार्थ भाई लोहित. Okay. लोहित नहीं आए हैं. विश्व उनादकट.
Just a minute, we will ask who all are there so that we can tick in our this. Lohit is there? Dr. Lohit?
Can you identify yourself instead of your name, ma'am? Poonam Tiwari is here. It's like taking attendance in the college, so. Yeah, next. Lohita?
Lohit Bhavani. Lohita, yes. And Vishwa.
Whoever is ready next can come up on the dais. Who is here on the dais? Acha, he's here. Siddharth is there. Pallavi is around? Pallavi Goel? Mohammad Riaz? Riaz is not there. Siddharth is here.
Mimansa is there?
Tanvi? Tanvi is there? Okay. Daksh is the other last person. Daksh is also there. Good. Fine. We have three people ready. Siddharth. You can proceed.
Good morning, sir. My name is Dr. Siddharth. I'm currently working as senior resident in internal medicine at Kasturba Medical College, Manipal. I'm presenting a paper which I had published during my MD on the role of neutrophil to lymphocyte ratio, lymphocyte to monocyte ratio, platelet to lymphocyte ratio, and prognostic significance in COVID-19, along with mean platelet volume to platelet count ratio as well. This paper was published in Curious Medical Journal in January 2021, has garnered 34 citations, sir. So, neutrophil to lymphocyte ratio is a valuable tool for screening critically ill patients with COVID-19. According to most of the studies, NLR ratio of greater than 4 is a criteria for patients admitted to the intensive care unit, sir. Also, lymphopenia results in delayed clearance of the COVID-19 virus from the body. So, even the lymphocyte to monocyte ratio becomes very important. Also, platelet to lymphocyte ratio becomes very important because when thrombocytopenia occurs, there will be megakaryocyte stimulation, which leads to oxidative stress, thrombosis, and apoptosis of activated platelets, thereby wherein the pulmonary endothelial injury leads to a cytokine storm of a reaction. So even the mean platelet volume to the platelet count ratio becomes very important, sir. So all of these were studied as key prognostic indicators in patients with COVID-19. This was a retrospective cross-sectional hospital-based study of inpatients admitted in the Department of General Medicine at CG Hospital, JJM Medical College, Davangere. 100 patients were taken, sir, over a duration of 2 months. Patients diagnosed with moderate to severe COVID-19, as per the Government of Karnataka guidelines, were included. Patients with febrile illness like dengue, malaria, leptospirosis, and rickettsial fever were excluded from the study, sir. So, after the study was performed and after the analysis of the results, the mean age of survivors was significantly lesser. There were 57 males and 43 females in the study. Mean age was 47 years, and there were 75 survivors and 25 non-survivors. So, this table represents the mean and the spread of the values in the study, along with the median. So, yes, sir. So, the derived neutrophil to lymphocyte ratio, neutrophil to lymphocyte ratio, lymphocyte to monocyte ratio, platelet to lymphocyte ratio, and mean platelet volume to platelet count ratios were taken. So, our study bucked the trend, sir. In our studies, survivors had significantly higher neutrophil lymphocyte ratio, lymphocyte monocyte ratio, and platelet to lymphocyte ratio, sir. So, this was a table which compared the test parameters between the survivors and the non-survivors. So, and non-survivors had a significantly lower neutrophil to lymphocyte ratio, lymphocyte to monocyte ratio, and platelet to lymphocyte ratio. So, we can conclude that these tests show that neutrophil to lymphocyte ratio, lymphocyte to monocyte, and platelet to lymphocyte showed high sensitivity and high negative predictive value in our study, sir. So, that can be used as a predictor of mortality in COVID-19. And this is a ROC curve representing the same statistics. So, our study bucked the trend. As I said, it went against the results of most of the studies, wherein there was significant lower neutrophil to lymphocyte ratio, lymphocyte monocyte, and platelet lymphocyte ratio in the non-survivors. This could be attributed to the fact that the patients presented to us in the initial stage of the disease, sir. And all the CBC tests which were done were performed at the time of admission. So, this study's ROC curve is very good for neutrophil to lymphocyte, lymphocyte to monocyte, and platelet to lymphocyte ratio. They can be used as a screening tool, thus helping us in choosing patients for appropriate treatment modalities in COVID-19 and can categorize the severity of the illness in COVID-19. So, neutrophil to lymphocyte ratio, lymphocyte to monocyte ratio, and platelet to lymphocyte ratio can be used as screening tools as they have high sensitivity and high negative predictive value. And they are widely accessible even in remote areas and resource limited settings. They help in gauging the progression of the disease early in the course, sir. So, these were my references, sir. Thank you, sir.
how we can utilize this study.
Yes, sir. So what we can do is, most of the patients, they were apprehensive on coming back to the hospital after recovery, sir. They were, because of the first wave, what happened. So the serial CBCs can be done to check if really the ratios will help in prognosis, sir. So unfortunately, this was done at the time of admission. So this
That is good. That is good. But you will have to agree
Yes.
that CBC is a very good tool. But
Yes, sir. Yes.
CBC is very sensitive to various drugs.
Yes, sir.
If somebody is taking steroids, CBC
Yes,
is
sir.
going to change.
Correct, sir.
Somebody has taken antibiotics, CBC is
Yes.
going to change.
Yes,
And
yes.
these are the two factors
Correct, sir.
which are very important because most of our Indian patients
Correct.
first take the drug and then go to the doctor.
Correct, sir.
So
Yes,
it
sir.
is very difficult to
Yes, sir. Definitely.
do the
Most of the COVID patients would have received antibiotics and steroids. So definitely that would have this thing influenced the ratios. But because they came to us maybe in the initial stage of the disease, that is why we have got a reverse trend in our studies. Sir. So that could have happened.
But the CBC in beginning
Readily
can
available.
be a very good marker,
Yes, sir.
which is not affected by other drugs.
Yes, sir. Not affected by
Thank
the
you.
drugs. Also, in resource-limited settings with poor infrastructure, it is a very easily available test.
Yes,
So,
thank you,
yes, sir.
thank you, thank you.
Thank you, sir.
So next is whether I will call upon Lohita present. Yeah, please come. Lohita Bhavani Jasti. She will be talking about correlation of red blood cell distribution with severity of coronary artery disease patients on the regimen. Fine. RDW.
Good morning, everyone. Today I'm presenting a paper with correlation of red blood cell distribution with severity of coronary artery disease, a cross-sectional study in a tertiary care center of Eastern India. Coronary artery disease due to atherosclerosis is one of the main leading causes of death all around the world. Atherosclerosis is a chronic inflammatory disorder with long asymptomatic period for years and usually manifests as acute coronary events with occlusion of coronaries. Red blood cell distribution width is a parameter which is nowadays routinely measured in most modern hematology analyzers. RDW is the quotient of standard deviation of red blood cell volume and its mean volume, and it's usually expressed as a percentage. And higher RDW values reflect greater variations in red blood cell volume. In the recent years, there is increased interest in the role of increased RDW as a risk factor of various cardiovascular diseases, especially coronary artery disease. Several studies have already found that elevated RDW values are related to poorer outcomes in these disease groups and a large cohort of unselected outpatients. To the best of our knowledge, there is a limitation in studies showing the relationship between the two in Indian populations. The aim of the study is to correlate the RDW with the severity of coronary artery diseases. And the objectives are to assess the RDW and the severity of the lesion on coronary coronary artery disease by angiography using modified Gensini score, and to correlate the both. The inclusion criteria was patients more than 18 years of age were taken into consideration who came with the provisional diagnosis of acute coronary syndrome, typical angina, atypical angina, and chest pain with Threadmill test positive. And patients with anemia with hemoglobin of less than 12 in males and less than 11 in females, and patients who were previously on blood transfusions or previous history of percutaneous coronary interventions and bypass surgeries, and patients with bleeding disorders and pregnant women were excluded. The sample size collected was 80. The baseline characteristics of all the subjects were recorded, including the age, sex, BMI, diabetes, hypertension, all the risk factors, along with the routine investigations. All the patients who came were divided into two groups, coronary artery disease group and non-coronary artery disease group based on the angiography. And modified Gensini score was used to assess the severity of the coronary artery lesions. Angiographic CAD was defined as the diameter of the stenosis in a vessel reaching more than or equal to 50%, and the severity of the lesion is by modified Gensini score based upon the total added value of the 8 proximal segments of the coronary arterial tree. According to the Gensini score, the maximum score that can be given is 32 and the minimum being 0. And the severity can be classified based on the degree of the stenosis as mild lesions, where 1 to 6 points are allotted, moderate lesions 7 to 13 points, and more than 13 points is a severe lesion. And the RDW-CV and RDW-SD values are then correlated. So a total of 80 patients were taken, and the descriptive analysis was done. Out of the 80 patients, 59 were male and 21 were female, and the average age being 52.92. And the mean hemoglobin value was 12.835, plus or minus 0.68. And the mean RDW-CV was 15.31, plus or minus 0.75, and RDW-SD being 44.71, plus or minus 3.5. So out of the 80, 75% of the patients came under the CAD group and 25% of the patients under the non-CAD group. And when we compare both the groups, the p-value was significant, where the obesity was more prominent in the CAD group, and family history of CAD was also prominent in the CAD group, along with the other risk factors like hypertension, diabetes, alcohol intake, and smoking habits. And when the variables were compared between both the groups, the RDW, CV, and ST was significantly elevated in the CAD group with a p-value of 0.0, which is statistically significant. According to the plot also, there's a positive correlation between the RDW and the severity based on the Gensini score. So RDW showed a positive correlation with increased severity in angiography assessed by MGS score, but when it was compared between the three groups based on the severity, there was statistically no significance based on the severity, but there was comparatively an increased RDW in overall coronary artery disease. The limitations of the study is this is a single tertiary care center study with no follow-up, and only hemoglobin and red blood cell indices were considered, whereas other parameters like iron, folate, B12 were not assessed, and the sample size was relatively small. So to conclude, RDW can be used as an important risk factor for both mortality and cardiovascular events in patients with CAD. It has not yet been determined if anisocytosis is the cause of the poorer prognosis, or if it is simply a marker of multiple pathological states. So RDW is an effective and easily available marker for the assessment of severity of CAD and helps in the risk stratification of CAD patients. Despite the possibility of some publication bias, the results provide evidence for positive associations considering the quality, direction, and magnitude. These are the references that I've used.
Thank you. Thank you. I will ask one question. In your inclusion criteria, you have mentioned patient more than 18 years of age.
Yes.
Why so?
So normally we wanted.
Why 18? Why not 20? Why not 30? Why not 40? Any specific region mentioning 18?
So we were doing the study in adult population. So the patients that are coming to our OPD are usually.
That is, all patients were not of 20 or 25, they may be 30, 40 years. Why you kept 18? Why you want to exclude less than 18? Any reason?
No,
Okay. So what is the impact of a study? Impact of a study for general physicians? What they can learn out of it?
So when a patient comes with angina or chest pain, like by the time we do the angiography and know the severity, it takes some time. So RDW is something that we can get in a very less time when we order a CBC. So there is usually a positive correlation. So if a patient comes and the RDW values are high, so we can stratify them as high risk and start the treatment immediately.
And it would have been better if you have also compared with the level of enzymes.
Yes.
Because they are done at that time.
Yes.
So that would have been a better study, RDW versus the enzymes.
Yes, sir.
like the enzymes which are used for the diagnosis of CAD.
And a correlation doesn't prove that it definitely is an evidence for that. So you can just say that yes, it's a probable cause for
Yes.
that thing. Okay, thank you.
Thank you, sir.
Next, next is Dr. Vishwanath Khat. Dr. Vishwanath Khat, if you are here, I think he's not here. Okay. Mohammad Muzammil. Mohammad Muzammil, you are here? No. Fine. Then Shishendu Pal has already done.
Yes, please do come in. Tanvi Borse.
Good morning. Today I'm presenting a paper titled A Study of Clinical and Laboratory Profile of Patients with Hemophilia in a Tertiary Care Hospital. As we all know, hemophilia is a rare genetic bleeding disorder having two types, type A and type B. The incidence is usually 1 in 5,000 for A and 1 in 25,000 for B, and it usually affects males, and it has factor 8 and 9 deficiency respectively. It commonly presents as muscle and joint bleeds, and this can lead to disabling arthropathies and morbidity. The mainstay of treatment is usually replacement of the deficient factors, but this can be expensive. So, in 2013, the government of Maharashtra announced free factor therapy to be made available. What were the aims of our study? We aimed to study the clinical spectrum of hemophilia patients. That is the type of hemophilia, the kind they presented with clinically, the severity of the disease, and what kind of complications they had. We also wanted to understand the current trends in treatment other than factor therapy, such as what kind of home therapy they used, if they used any other drugs, or even had to undergo surgery. We also assessed their quality of life and the socio-economic burden that was faced by these patients. We conducted a single-center, cross-sectional, observational study at the outpatient and inpatient department in our hospital. Our sample size was 368 patients, which was done over a period of 6 months. This is an example of the case record form that we used. Okay, now coming to the results. Firstly, all our patients that came were male, with a mean age of around 22.5 years, and majority of them were unmarried. Only 3.5% of these patients had developed inhibitors to their factor therapy. Majority of the patients had type A hemophilia, and 80% of them presented with severe form of hemophilia. As we conducted a single center study, most of our patients came from the Mumbai metropolitan region. Now coming to the clinical profile. In joint bleeds, the knee was the most commonly affected joint, followed by the elbow and then the ankle. In muscle and mucosal bleeds, the gum bleeds had a significant proportion. In muscle, the psoas was the most commonly affected muscle, followed by the calf and then the gluteus. Now coming to the complications. So what is a target joint? A target joint is a joint which has been bled into at least 4 times in the last 6 months or has had at least 20 lifetime bleeds. Most of these patients had a single target joint, but a significant number had more than one as well. Of interest was that target joint was significantly correlated with not only the severity of the disease, but also having an annual bleed rate of more than 4. Again, as we saw in the bleeds, the most commonly involved joint was the knee, followed by the elbow and then the ankle. Now on treatment, as I mentioned earlier, the factor therapy was the mainstay of treatment, and most patients on an average began therapy at the age of 10 and were using it on average for at least 13 years. 87% of these patients were still using on-demand factor therapy rather than prophylactic therapy. In addition to factor therapy, 90% patients also used icing and a significant number also used other drugs such as fibrinolytics, painkillers, and a small proportion had to undergo surgery, such as joint replacement surgery. We assessed the quality of life using the Eurocall 5D score, and most of these patients on an average rated their quality of life as 79 on 100. Again, target joints were significantly correlated with each of the subcategories of the Eurocall score. On assessing the socioeconomic burden, we found that 7.23% of these patients were unemployed, and most of them belonged to the lower middle income group. So to conclude, the knee is the most commonly affected joint and the psoas the most commonly affected muscle. 54%, that is more than half of our patients, had a target joint which was significantly correlated with not only the disease severity, but the bleed rate and the quality of life. Most patients were still using factor therapy on demand, and they belong to the lower middle income class group, with 7.23% being unemployed. The limitations of our study was that due to the COVID-19 pandemic, we were not able to assess the degree of the disability and the prevalence of HCV, HIV, and HbA(ag). Also, our unemployment rates could be skewed because majority of the population were in a younger age group and because of the effects of the COVID-19 pandemic. Thank you.
Thank you. So my same question to you again. What is the impact of your this study?
So factor therapy is very expensive. So a lot of patients are not able to access it. So once the factor therapy was made free by Maharashtra, a lot more people were able to get this therapy. So we wanted to measure what was the impact of that after it was made free. So we conducted this epidemiological study. Also, there is a paucity of these epidemiological studies conducted in Maharashtra for hemophilia. So we wanted to do that as well.
Just my one clinical question.
Okay.
Suppose you are getting a patient of hemophilia and factor 8 is not available. Then what you can do?
So initially also before factor therapy, they used to give cryoprecipitate or blood transfusion. So if it is a severe disease.
Whole blood transfusion?
Packed cell transfusions.
Packed cell transfusion.
So if
No. That is not the correct answer. Packed cell are not indicated for hemophilia. No.
they used to give cryoprecipitate and
Cryoprecipitate.
yeah.
That is
So,
the better answer.
Yes. So cryoprecipitate
Because
was,
RBC don't have any clotting factors. And you are going to infuse clotting factor.
Yes.
If clotting factor is not available, cryoprecipitate is a good answer.
Yes.
Thank you.
Thank you.
Thank you.
Thank you.
Now we would like to call upon Poonam Tiwari for her next presentation. Please come on the stage.
A very warm welcome and good morning to respected judges and all the august gathering in the auditorium. My research topic is eating pattern of school-going adolescents of Lucknow city and its impact on hemoglobin levels. We all are well aware of with the established fact that Indian adolescents are suffering with iron deficiency anemia, and for prevention of this, government has taken at various levels very robustly many steps to combat this ravaging problem. National Nutrition Anemia Control Program, Kishori Jan Swasthya Yojana came into existence, in which various iron and folate supplements are being given to adolescent girls free of cost at community levels and school levels. In present study, government set up schools going adolescents irrespective of their gender were included, and their eating pattern, consumption with the help of food frequency method, 24 hours dietary recall, and their blood samples were done so as to find out macro and micronutrient profiling even. So the aim of study is to find out the correlation between the eating patterns of school-going adolescents and their hemoglobin levels. In this methodology, present study, what we did, we took 607 school-going adolescents between 13 and 19 years of age of both genders. the whole Lucknow city was divided into 5 zones, and out of each zone, randomly we selected schools, and from each school we randomly picked up these students. And a structured questionnaire along with food frequency method was also used so as to gather their demographic, nutritional data, biochemical data, and with the help of this data, we tried to find out their consumption pattern. Inclusion criteria was adolescents between 13 to 19 years of age, and exclusion was children suffering with celiac disease, lactose intolerance, type 1 diabetes, thalassemia, or anyone who was not willing to get enrolled in the study. So the facts which came out with the CBC report was that normally 207 girls had a normal range of hemoglobin, 10 to 55 below, and 20 above the range. In case of boys, we had 255 with the normal range, 48 below, and 22 above. This was quite surprising because the intake, the eating pattern which they had was showing that they are not taking proper iron-rich food, and their hemoglobin levels were quite normal. So the food which they were eating were like they were eating momos, kebab paratha, veg roll, and aloo tikki. These kind of food was more because they were of deprived section, and in 10 rupees they were working also. In night shift they were the mechanics, painters. So at the night shift every day they used to go and get these street food from the vendors and were eating. So I tried to find out the iron content of these food events, and it came out like the noodles were having 1.5 mg per 100 gram, momos 0.6 mg, pizza 2.5, kebab paratha was high with 5.4, samosa 0.5, veg roll, pani puri, and I tried to find out what could be the reason. So, like serum hemoglobin levels were normal, food frequency pattern, as I told you, there was very improper balanced diet. They were not having the choice also to eat the proper food. So what could be the reason that their hemoglobin levels were quite within the normal range? That was little surprising for me as a dietitian. So we tried to find out. In PubMed, there had been one study by Britain in which they said that mostly food is cooked. In the cast iron utensils, the iron content significantly increases of this food. And as compared to the normal iron-rich food which we had been advocating till now, like spinach, 100 grams gives only 2.7 mg. And kebab paratha was giving 5.7. I don't say it is right, but yes, we can also look with this factor also. The iron content of these frequently food might be a contributing factor, as I told you in this study. And I tried to find out the other also, like macrocytic anemia. Are there any possibilities for folate deficiency or something? So still that is in process. But with my study, I could find out. And one more thing, my mentor told me that no matter what could be the food content, iron content in the food, one role play into factor is the bioavailability and metabolism of iron food. So that could also be the one factor, and further studies really need to be done, that the correlation between the consumption of these junk food and the hemoglobin levels of the people. Thank you.
Thank you for addressing a very important aspect of nutrition, iron. Because half of my country is having iron deficiency anemia. So again, the same question which I'm asking to everybody, what is impact of your study on physicians? How that study is going to help in day-to-day practice?
Right. Sir, normally what we had been found, we all had been advocating about iron-rich food, and we are strict to only those iron-rich food like iron, roasted chana, jaggery, and spinach, beetroot, anar. But now where the flow is going, where my adolescent population, what they are eating, we need to investigate those food also. It is not that always these foods are wrong. If they are consuming it and if they are getting little bit of benefit, we really need to understand on those lines even, and we need to work upon the food pattern, how we can, improvise it. Suppose if they are having kebab paratha, if they are having noodles and that too in the cast iron, we can always tell them that these noodles could be replaced with atta noodles, but still you can go ahead with it. So this is the impact, like the whole eating pattern. We all are trying our level best to westernize, say we should go back to our traditional eating pattern. If that is not coming, at least a midway can come out where we can improvise the food pattern which they are eating with the fermentation and the regular practices which were followed in the ancient time.
So the impact is that we should not be strict. We can allow anything to eat.
Yes, sir.
But we are not concerned only about iron. When you talk about diet, you are a dietitian, you know it better, that we are concerned about everything, balanced diet, not only iron.
Yes, sir, I agree. My whole study is with the micro and macronutrient profiling and still at the verge of completing it. So till now, I was able to come with the iron as a nutrient. So I presented this, but in near future, I'm working with all the macro and micronutrients. So definitely, I will be able to give some concrete result to the society. I feel so.
My comment is only one, that nutrition cannot be in isolation. So we have to have a complete picture of that.
Definitely,
And we
sir.
cannot promote junk food or such unhealthy eating habits, even if we find something good in that. So I
Yes,
think
sir.
the message should be the other way around.
Yeah, I agree to you, sir. I'm not saying that I'm in the favor of junk food, but I wanted to say that seeing their consumption of junk food and the way their levels are coming up, we also need to see the junk food with a different lens and try to improvise it so as to we can make it a healthy eating pattern also.
But iron content of the food does not mean that iron will go to the cells.
Yes, sir. Yes,
No,
sir. Yes,
because
I
it
agree.
depends on transporters.
Ji, sir.
So Dr. Tiwari said very well that we cannot promote junk food.
Yes, sir. We
And
not.
they may have enough iron. For example, spinach is said to be having a very good source of iron. But if somebody is taking that in vegetables, he will not get any iron because all the ferrous will convert into ferric
Yes, sir.
and he will not get anything. So citrus fruits will provide more iron because of vitamin C, the ferric will
absorption.
convert into ferrous.
Yes, sir. Yes.
Thank you. Thank you very much.
Thank you. Now I would like to call upon Rohit Jacob for speaking on violence experienced by postgraduate resident doctors and interns in a tertiary care center in Aurangabad. Rohit.
A very good morning to one and all present here. At the dawn of 19 June 2019, two doctors in Kolkata were brutally assaulted, following which 800,000 doctors all over the country came upon rising, they rose and they went for a countrywide strike to claim their own rights. This led to the foundation of my research, violence experienced by postgraduate resident doctors and interns in a tertiary care center in Aurangabad. The Indian Medical Association survey reveals that 75% doctors have complained of verbal abuse and 12% of physical violence. In a country like India with paucity of doctors, violence against doctors would exponentially increase the magnitude of the health crisis. The aim and objectives of my study were to determine the percentage of postgraduate medical students experiencing violence in a tertiary care center in Aurangabad, to assess the type of violence experienced by postgraduate resident doctors in a tertiary care center in Aurangabad, to evaluate the factors contributing towards this violence against postgraduate resident doctors and interns, to assess the consequences of this violence on postgraduate resident doctors. So the study was initiated after obtaining permission from the Institutional Ethics Committee with a hospital-based cross-sectional descriptive study consisting of 100 candidates conducted at the Medical College and Hospital Aurangabad with a duration of 6 months. All postgraduate resident doctors and interns working in different sections of the hospital were considered for the study. Of 100 respondents included in the study, 64.3% were males, 35.7% were females, mostly belonging to the age group of 25 to 40 years. Out of which, as you see here, 55% belonged mostly to the second year junior residents. Now, if you compare the departmental stratification of doctors facing violence, you can see nearly 21.9% belong to the Department of Medicine, 18.7% surgery, and 14.2% in the gynecology department. Rest of the departments together, dermatology, psychiatry, orthopedics, and ENT, 7.2% candidates faced violence. The location of violence. Now, this is something which is very important, where it was observed that 74% of all assaults took place in the emergency room, 15% in the ICUs, and 6% in the OPD. But none were reported in the OT area, operation theater area, probably because of high security or probably because of the strict compliance on the entry prohibition. Now, if you compare the types of violence faced by the doctors, 71.2% stated verbal abuse, 64% verbal threat and intimidation, 12% physical violence, pushing, hassling, 4% severe physical violence, and 8% of false statement on social media. The reasons for violence stated by patients and patients' bystanders, mostly it was the wish to receive priority treatment. Next, enough care was not provided. Third, dissatisfaction with the treatment. Fourth, late arrival of doctors. Fifth, counseling not done properly, and unknown reasons were 8%. If we continue, 68% of doctors felt worried when they think about the safety of themselves when at work. To our amaze, 8% of doctors were found to be afraid to carry out their duties daily due to the constant threat by bystanders and relatives verbally and physically abusing them. 52.4% doctors were distracted from their work, while 28.6% doctors preferred to be detached from social contact and preferred living in isolation, and 9.5% doctors started suffering from insomnia and depression. A similar study was conducted in Israel, where the most common reason for violence was stated as long waiting time, followed by dissatisfaction with the treatment. To conclude, violence against doctors has become a palpable fear. In a country like India, where Mahatma Gandhi is the father of the nation, it is very ironical to see the government's reluctance in interfering and trying to prevent such mishaps. So it is high time that we doctors step in and take the necessary precautions that can protect as well as save our medical profession. This was the case pro forma that was used, where the violence was categorized and the reasons were also categorized as per different commonly observed reasons stated by the different resident doctors. These were my references. Thank you.
Thank you, Rohit, for selecting this very important aspect for research, and methodology was good. Contrary to my belief, being from last 40 years in the profession, my thinking was that the most important cause of violence is less communication. And second may be the long hours of duty of resident doctors. In my university, I have found out the most important cause we can, a remedial thing can do, not dressing up properly. If doctor is not dressing up properly in the busy resident duties, they are very poorly dressed, not wearing apron up to the knees. If somebody is having good, decent dress, I think even the violence will go down. And communication can only improve it.
Right.
Government agencies cannot do anything. It is impossible for any government to interfere in the violence. It is impossible. Because it is a social problem, not the government problem.
Right.
So only our associations, in our 5 years course of MBBS and 3 years course of MD, 3 years course of DM, nothing is taught how to behave, how to have good communication. The ADCOM by the NMC is total useless, because ADCOM cannot be taught, only it can be improvised, it can be, you can show it by example.
Right. So one thing I wanted to add is that during the era of COVID-19, everybody recorded the number of people who died, but nobody recorded the number of doctors and residents who actually expired due to COVID.
No, you are influenced by media. Not everybody. Only
only the
media.
research is done by medical
if you can
professionals.
ban media, violence will go down. Because media was saying that half of India has died and Indian population has increased. Nobody died. So this is not the scene. Scene is different. Satisfaction to doctors has increased during COVID days. During COVID days, we were having more respect. And initially, at that time, only few doctors are attending. So their respect went high at that particular time. Good aspect.
You did a good study, but as I was asking with all the people, so what was the impact of the study? How do you see that? What the change this study will bring about?
Sir, it was actually the same point what sir said, that we should not wait for the government to take initiative, but instead we should improve our doctor-patient relationship, and that can only help in preventing such mishaps. The most suggestion that I would give with my limited practice that I have is that when we have a patient on a ventilator in the ICU, when the patient is showing signs of recovery, we should not go towards counseling such that the patient will become completely all right, you don't need to worry. Instead, we should be counseling in such a way that there are consequences, there might be complications, and we must be prepared for it until we are absolutely sure that the patient will recover completely. So if we are preparing the patient relatives for a certain amount of time, that can help digest those complications which the patient is facing.
The follow-up, I think, there should be a follow-up study on what are the behavioral modalities that should be adapted by the doctors to prevent violence at practice. Thank you. It was a good insight.
There is one comment I would like to make here, that the tolerance of our doctors, the young doctors, has decreased too much. If we just think that any patient who has come is really charged with the worries, the patient is going to die or patient is having problem. So we have to be a little patient and compensate so that we can understand the problem of the patient, number one. The another thing which I personally feel can improve this communication skill is that beside a direct communication, we can evolve a method by software that we can communicate bilaterally to the patient's attendants and patient. Suppose if we are doing any activity during course of time, and if attendant gets that information through the app or through the software continuously, then the worries of the patient is decreased, and these episodes of violence can be reduced drastically. This is being done in the developed countries, but not followed in our country, but it can be done very easily without much effort. It can be done. Only thing that willingness is there. And our doctors should definitely be taught how to face such challenging patients that we have lost. I personally feel that every time a junior resident is not tolerant at all. There is a slight trigger, the impulse goes high, and both the parties, they start fighting. If you just console the patient, I think everything can be comfortably managed. And only communication is the only answer to stop these things. Thank you.
Thank you, Dr. Rohit. I would like to call upon Sir Shendu Pal for his presentation on study of cardiac manifestation in patients with human immunodeficiency.
virus infections in West Bengal, precisely in North Bengal. Background of our study, it was a case control study done on 40 HIV infected patients of North Bengal Medical College and Hospital compared with a healthy matched control group. Aims of our study to assess the cardiac chamber anomalies along with changes in the pericardium, to check for lipid abnormalities and compare them with echocardiographic abnormalities, and to document the relationship between CD4 counts and echocardiographic abnormalities. Methods: study area and population, HIV positive patients residing in North Bengal. Selection criteria: age greater than 20 years, Western blot confirmed cases, cardiac causes not attributable to other diseases. Exclusion criteria included alcohol or cocaine addiction, family history of cardiomyopathy, pericarditis or storage disorders, drug intake of procainamide, doxorubicin, antiretrovirals like zidovudine, history of radiation exposure, trauma, acute myocardial infarction, uremia, neoplasia or other confounding illnesses, pregnant and peripartum women, and dyselectrolytemia. Our sampling was random. Study group 40 HIV patients with or without symptoms. Control group healthy matched subjects without HIV. Duration of the study was 1 year. We collected the identification data. History was taken. Physical examination done, followed by the investigations. Statistical analysis included mean and standard deviations, and the tests of significance used were standard error of difference between two means, standard error of difference between two proportions, the paired t-test, the chi-square test, and coefficient of correlation. Results: the total cholesterol, HDL, and LDL of study group were found to be significantly lower than the control group, but triglycerides were similar in the two groups. A positive correlation existed between CD4 count and total cholesterol, HDL, and LDL. There was a negative correlation between CD4 count and triglyceride and VLDL. Patients with CD4 counts less than 200 per microliter had a statistically significant echocardiographic abnormalities, in contrast with those with counts more than 200 per microliter. Low LDL and HDL were more significantly associated with pericardial effusion than diastolic dysfunction, and low total cholesterol and high triglycerides were more significantly associated with diastolic dysfunction and pericardial effusion. So to conclude, the lipid levels could be used as markers for cardiac dysfunction where echocardiography is not available. Thank you.
We are asking, sir, the same question. How your study is going to impact the practice of physicians?
Yes, a very good question and a very practical question also. We know echocardiography is not available in the peripheral parts of India. Also, CD4 count is also not available. Till 1 year or so back, CD4 count was available only in the medical colleges. So, to follow up patients of HIV, this could be one of the markers. If you go through the entire lipid profile, we have done correlation studies and found that they could give us indications whether the patient is deteriorating, whether he is improving. When we do not have centers in the periphery of, say, viral loads or CD4 counts or echocardiography, this could be a great help.
Thank you. Thank you. Thank you very much.
Thank you, sir.
next presentation, I would like to call upon Tanvi Borse.
bone marrow is better, we need not wait for the result also, sir. It's better to do it on the second or third day, or else you lose the crucial time window to give steroid and treat the patient.
Chalo, it was a good study. Thank you.
Thank you, sir.
Now I'd like to call upon
Good morning. I'm presenting a case on dermatomyositis. A 65-year-old female resident of Mumbai with 5 issues came with the chief complaints of breathlessness since 3 weeks, cough since 3 weeks, facial puffiness since 2 weeks, and erythematous rash over the neck since 2 weeks. She had no other history of any orthopnea, PND, syncope, any chest pain, or any allergies. Of significance in her past history was that she was diagnosed with cervical cancer stage 2 3 years ago and was treated with radiotherapy for the same 2.5 years ago. She also has had remote history of pulmonary cox, which has been treated, and bronchial artery embolization for the hemoptysis. On examination, her vitals were stable. On local examination of her rash, she had an erythematous rash which was present over the nape of her neck, over her shoulders, the upper portion of her trunk, and her face, especially in the periorbital region. This pattern of the rash was very characteristic for the presentation of dermatomyositis. Her respiratory system had equal air entry, but she had coarse crackles that were present bilaterally. On neurological examination, she had a little decreased power in the proximal muscle groups, and the rest of the examination was normal. On doing basic laboratory investigations, they were normal except that she had the presence of anemia. Then we conducted special investigations where her ANA was found to be positive, and on her myositis panel, we observed that she had positive anti-Me2 beta antibodies, and she also had extremely high CPK levels. We also conducted a muscle biopsy from the gluteus muscle, which showed the characteristic of dermatomyositis with perifascicular atrophy. She was referred to dermatology, where they then did the nail fold capilloscopy and did a biopsy of the skin, which again showed features such as periungual telangiectasias and solar elastosis, which was categorical for dermatomyositis. We did a PET scan to rule out any current cancers or any recurrence of her cancer. This is a photo of her periungual telangiectasia and her muscle biopsy. So after ruling out everything else, we made a diagnosis of dermatomyositis, and hence she was treated with prednisolone 1 mg per kg per day in tapering doses, after which we can see that she had a remarkable improvement in her rash. So, what is the takeaway from this case? Firstly, dermatomyositis is known to be associated with malignancy in at least 32% of adult patients. These cutaneous neoplastic, paraneoplastic syndromes are important diagnostic markers because once a patient presents with such syndromes, we can go and diagnose if there is any underlying cancer. Most of the cancers that are associated with dermatomyositis are usually ovaries, stomach, colon, or lung. But here we present a case of cervical cancer being the underlying neoplasm. If we treat the underlying neoplasm, the patient has a very good prognosis, and hence we must ensure that if a patient comes with such dermatological presentations, we should rule out underlying cancers and screen them for the same. In return, if a patient with cancer is present and you see such manifestations, you can attribute those to paraneoplastic syndromes. Thank you.
Thank you. Although you have mentioned, but most important differential diagnosis, what you will like to keep?
So the differential diagnosis would be probably SLE, or else any polymorphic light eruptions, or any discoid kind of lupus, such kind of presentations.
And during treatment, how long the steroids are given?
So it depends on the way that the patient is responding, to what dose of the steroid the patient is responding. And here we give her for 1 kg per day, and then she was treated over a period of 2 weeks.
2 weeks.
With
And
tapering
then-
doses.
And then you taper it.
Yes, and then she responded to that.
In your particular case, it was given for 2 weeks, and then you tapered the dose for another week or 2 weeks?
Yeah, like 1 week, and then we decreased it in 1 week, and then again decreased it for another week.
So 1 week full dose, then you taper the dose for another week.
Yes.
That was enough?
No, 2 weeks we gave the full dose, and then we tapered it for 1 week, and then we tapered it again for another week.
Okay, so 4 weeks. Total duration,
Yeah.
4 weeks.
Yeah.
So what were the side effects of this 4-week duration of steroid therapy?
So she had, so actually because she also had other syndromes like other symptoms like facial puffiness and all, she was already given furosemide, so she didn't have a lot of any water retention, or even in that much she didn't experience any moon phases or something. She had a slightly elevated sugar level for that duration, but
Yes, I was coming to that. What were the blood sugar levels?
So when she presented to us, it was normal with her fasting being in around 80s to
After 4
90.
weeks?
After 4 weeks, the fasting had gone up to 100 to 110.
But not in
Nothing more
diabetic
than
range?
that, no.
Okay.
So what was the follow-up after the stoppage of the steroid therapy? Did the sugar levels stay like that? Did you follow her? Did you go for an HbA1c prior to the start of the therapy? Or did you order HbA1c all along the duration of the treatment or follow-up?
So an HbA1c was ordered when we did the basic investigations. That was normal, and then after that she followed up after 3 months. When after that again we checked her sugar levels that time, which was normal, and her rest of the panel was repeated again, including the markers and HbA1c, and that didn't show any much difference. So
Thank you.
thank you.
Next on stage, I would like to call upon Mimamsa Jindal, presenting topic on COVID-19 vaccination drive in India and hesitancy among people living with HIV/AIDS.
Good morning, everyone. Today, I, Dr. Mimamsa Jindal, am here to present the results of my review, which I did during my MBBS internship on the topic COVID-19 vaccination drive in India and the hesitancy among people living with HIV/AIDS. So to begin, with COVID-19 occupying the center of the healthcare in India, all other chronic illnesses had to suffer. Especially in HIV, there was difficulty in obtaining refill of ART medicines. There was difficulty in getting vaccinated. According to Johns Hopkins COVID-19 Resource Center, 2 of the 3 countries with the highest burden of HIV infections, that is South Africa and India, are also the countries with the highest COVID-19 burdens. According to WHO SAGE Group, vaccination hesitancy can be defined as a delay in acceptance or refusal of vaccination despite the and also vaccination hesitancy will be higher in people living with HIV as compared to the general population. Our primary objective in this study was to provide insights about the ongoing COVID-19 vaccination drive and also to analyze misbeliefs, especially amongst people living with HIV in India. Our secondary objective, since this is a scoping review, was to suggest a study design for future research in this area. So a literature search was done on PubMed, and astonishingly we got only 2 results with a proper advanced search. So we decided to search with loose terms, and also we did a very careful analysis of the cross references to reach 10 articles. To gain a better understanding of this topic, we divided the review process and also the body of this article into 4 parts. First, the impact of COVID-19 on HIV. So in a cross-sectional study done in UK, it was found that people living with HIV were at an increased risk of COVID-19 mortality as compared to the general population when adjusted for both age and sex. In a similar study in Spain, it was found that one-fourth of HIV patients, especially with those with low CD4 counts and comorbidities, had developed severe COVID-19 and had 12% increased requirement of ICU. And also in a similar study, it was found that HIV positive status doubled the risk of mortality after adjusting for sex, ethnicity, age, baseline data, and 10 separate comorbidities. It was also found that HIV patients with COVID-19 infection also had a higher burden of cardiovascular comorbidities. The second part of my review, COVID-19 vaccination drive for the immunocompromised. So the armamentarium of Indian vaccination drive till May 2021 comprised of two vaccines primarily, that is Covishield and Covaxin. The current WHO recommendations suggest that COVID-19 vaccines are safe for people living with HIV. Some countries, including India, have also prioritized that vaccination for all people living with HIV and immunocompromised states should be given early, especially with CD4 cell count less than 200. An informal poll of 52 countries done by WHO revealed that 24 of them already had an immunization poll in place, which was prioritizing people living with HIV. Third part of my review, COVID-19 vaccination hesitancy in general population. So it was found that multiple reasons, such as general lack of awareness about health and prevention, self-perceived risk and benefit ratio of vaccines, lack of perceived risk towards vaccine-preventable diseases in general, and media-influenced anti-vaccine reports on trials and adverse effects were affecting vaccine hesitancy in the general population. It was also found that countries wherein people had a higher belief in the central government showed more positive attitude towards COVID-19 vaccination. Last part, COVID-19 vaccination hesitancy among people living with HIV. So in a study done in France, it was found that people living with HIV particularly expressed concerns and had higher vaccine hesitancy due to their chronic disease status. They also reflected concerns about the serious side effects of COVID-19 vaccines and their perception about already having a decreased immunity to COVID-19. In another study done in South Africa, they found that more than half of the population already had one or more misbeliefs towards COVID-19, and these misbeliefs were positively associated with a negative attitude towards vaccination. So the scope and justification for future studies, we suggest that studies in future should include 4 aims. First, evaluating the acceptance, the general acceptance of COVID-19 vaccines among the PLHIV, its association with various factors, its association with history of COVID-19, whether in self or in family or nearby friends, and lastly, to analyze the misbeliefs in PLHIV community. We also suggest that a preliminary examination and also the provision of vaccine should be provided in the ART center itself to mitigate the social stigma. We suggest that in a preliminary questionnaire, following domains should be concerned. First, demographic details. Second, details about patients' HIV status and ART therapy. Patients' existing knowledge of COVID-19 disease and their existing knowledge about COVID-19 vaccination. The following suggested outcome measures should be visible after answering this questionnaire. First, the acceptance rate of COVID-19 vaccine, the association of acceptance and refusal rates with various factors which we had included in our review, and the perceptions and beliefs of PLHIV community about COVID-19 disease and the vaccine. Here are the references for my study. Thank you.
Good, but you will have to accept that in medical science, if you remove surgery and you remove vaccination, then nothing is left.
Absolutely, sir.
All the credit to the modern medical science is just because of vaccinations. We have been able to remove so many diseases just because of vaccination. And with all vaccination, whether it is COVID or something else, initially there was a lot of reluctance. So you are very correct, but here in COVID, 2 factors more very important. Basically, this all hue and cry was because of 2 regions, most prominently. One is political. Politically, it was opposed. And second was media. Today, in medical science, the biggest threat I consider is media.
I agree, sir. And just to mention, the initial design of the study was an original research. We were planning to do it in the ART center of GTB hospital amongst 300 participants. But again, because of ethical reasons, we couldn't get an ethical clearance. And so we converted it into a review.
So why did you select this particular set of patients?
So because first reason was that GTB has an excellent ART center. We are handling 500 plus patients every day. So this was, the availability of patients was one reason. And second, sir, like I said, the methodology, there were not enough studies available on this subject. So this was, I think, a very good area to explore.
So what would be the impact of the study? And what would be the derivatives of the study? So how do you plan and what could be the message that you will derive after the study?
So firstly,
and rather I should put it like this, what would be the remedial action designed out of this study?
sir, talking to the patients and understanding what are their misbeliefs and then countering them. I think that will be the biggest step, because what they will learn from us, they will tell it to 10 other patients in their community. And so in general, the acceptance will increase. Secondly, our thought process was that we can submit our research results to NACO so that there can be a provision of providing COVID-19 vaccines in the ART clinic itself. Because many patients are shy to avail the priority group because of social stigma and revealing their PLHIV status.
So 3 remedial steps can be taken. Number 1, at the designing of the various, when the trials of these vaccine start, even from that time, we have to keep this in mind, that what can be the questions in the mind of the persons who are going to take it.
Yes.
And since very beginning, we have to take that decision. Second, more information should be provided, that what can happen after vaccination and whom not to be given. That is not specified. That happened during COVID times.
Yes, sir.
Still, few people are complaining that they have lot of problem after vaccination, because it was not very much specified whom not to give. So these are remedial things which we can include to make the vaccination program more successful.
Thank you, sir.
Next on stage, I would like to call upon Pallavi Goyal.
A very good morning to everyone. I'm Dr. Pallavi, PG resident from Mahatma Gandhi Hospital, Jaipur. I'll be presenting a case report of Coombs negative autoimmune hemolytic anemia. Autoimmune hemolytic anemia occurs when antibodies directed against the person's own RBCs cause them to burst. This leads to insufficient number of oxygen-carrying red blood cells in the circulation. The normal lifetime 100 to 120 days of RBCs is reduced to just a few days. The antibodies are usually directed against high-incidence antigens, therefore they also commonly act on the allogenic RBCs. AIHA is an uncommon disorder with an estimated incidence of 0.8 to 3 per 100,000 every year and a prevalence of 17 is to 100,000 in adult population. It can be warm, cold or Coombs negative type. Coombs negative AIHA is characterized by laboratory evidence of hemolysis plus a negative Coombs test. We report a case of a young male who presented with acute hemolysis and was later diagnosed as Coombs negative AIHA. A 31-year-old male presented to us with fever, yellowish discoloration of eyes and skin, reddish discoloration of urine, and generalized weakness and fatigue. Patient was apparently asymptomatic 5 days back when he developed fever, which was high grade, associated with chills, relieved on medication. This was followed by development of yellow discoloration of eyes and skin, and he noticed reddish tinge in his urine 2 days back. He started to feel very weak and had fatigue since the symptom onset. There was no history of any associated burning maturation, shortness of breath, chest pain, any rash, blood donation history. or history of weight loss, and there was no history of alcohol use. Patient is a known hypertensive since 4 months, was on medication for the same. There were no other comorbidities. In family history, his mother was HbsAg positive. Personal history was normal. On examination, the significant findings were patient had fever, 101 degrees Fahrenheit, pallor was significantly present and icterus was significantly present. On systemic exam, hepatosplenomegaly was felt. Rest all systems were within normal limits. Now to investigate this patient, we saw the hemoglobin was only 6.1 gram per dl, which is suggestive of severe anemia. Rest parameters were within normal limits. Now to search the cause of anemia, we did LDH, retic count, bilirubin. Indirect bilirubin was significantly high. This suggested that it is a hemolytic type of anemia. Further, on USG, we found a fatty liver and mild splenomegaly. Now we know it's a hemolytic anemia. Now to go towards the etiological workup of hemolytic anemia, we did Coombs. Direct and indirect Coombs, both were negative. Urine was positive for HB, which was suggestive of hemoglobin urea. Rest, haptoglobin, ANA, ceruloplasmin, PNH clone, G6PD, everything was normal. After all this, we concluded that this patient has Coombs negative AIHA. To manage that, we started the patient on steroid pulse therapy, but he did not respond to this and continued to have symptoms with hemoglobin urea and severe anemia, thereby requiring daily blood transfusions. On day 7 of admission, he had an episode of severe abdomen pain, which was referred to the left shoulder, managed by IV analgesics. At that time, we were not sure why is this happening. Due to post-steroid response, we shifted patient to second-line treatment, IVIG. IVIG was preferred over plasmapheresis because of severe anemia. 1 gram per kg per day for 2 days was given along with steroid pulse. After steroid pulse was over, patient was started on oral prednisolone and rituximab was started. Weekly rituximab was given. After the second dose of rituximab, patient became transfusion independent and was maintaining HP of more than 8 for 1 week. For further etiological workup, we tested for HIV, Hep B, Hep C, CMV, EBV. All tests were negative. Anti-HPC ELISA came out to be positive. For this, he was started on tenofovir as a prophylactic measure because rituximab can increase the risk of Hep B reactivation. A whole body PET-CT was done to rule out anything that could have been missed. It showed presence of splenomegaly with multifocal infarcts. Likely this was the cause of severe pain that the patient felt, which was radiating to the left shoulder. For this, aspirin was started. Patient was gradually improving and discharged after third dose and is still in follow-up. The diagnosis of AIHA is based on low hemoglobin concentration, a positive Coombs, and at least one feature of hemolysis, as were present in our case: high retic count, raised LDH, and raised indirect bilirubin or splenomegaly. Positive Coombs suggests diagnosis of AIHA. However, Coombs negative AIHA occurs in 5 to 10% of patients. AIHA with negative Coombs is uncommon and requires investigations to exclude secondary causes, as we did. Negative Coombs may be due to presence of IgG autoantibodies in quantities lesser than detectable threshold, IgA or IgM autoantibodies, and low affinity autoantibodies. Further, serological tests for EBV, CMV, HIV, everything was performed to exclude the secondary causes, but everything was negative. The anti-HPC, which was positive, was mostly due to the presence of family history of a positive HPS in the family, and patient responded well to rituximab therapy, which thereby confirms the autoimmune etiology of hemolysis. High degree of clinical suspicion of autoimmune hemolytic anemia should be made in patients presenting with acute hemolysis and should be diagnosed after exclusion of secondary causes by appropriate investigations, including Coombs. Negative Coombs does not rule out the possibility of AIHA, and in such cases, compatible clinical course helps in diagnosis of AIHA. These are my references. Thank you.
Thank you. Thank you for this presentation. You use the Coombs test?
Yes, sir.
So what is the basic of Coombs test, how it works?
So it's the type 2 hypersensitivity reaction. That is how the antibodies and antigens are detected. We use warm type and cold type.
presentation, what we can learn and which can utilize in our practice?
So majorly because mostly we see AIHA, majorly whatever I have seen in my residency is Coombs positive type. Coombs negative was the first instance I saw in my patient.
Okay. What is the impact of the study?
Sir, it was a case report.
Okay.
Yeah.
Thank you.
Thank you, sir.
Next on stage, I would like to call Mohammad Riaz. Is Mohammad Riaz here with us? Okay. I'd like to call Sir Shendu Pal for next presentation on nutrition survey and protein consumption pattern in North Bengal. Sir.
Yeah. So once again, bringing greetings from Siliguri district, Darjeeling, from North Bengal. Welcome you all to the City of Destiny. My third presentation. Nutrition survey, or its better term would be an assessment and protein consumption pattern in North Bengal. Background of our study, it is an observational nutritional assessment study. It was done on 100 patients from the hills and dwars of North Bengal. Our aims and objectives were to study the average daily consumption and the consumption pattern of proteins, to know the distribution of different food groups in the protein intake of the population of North Bengal, to find out the difference in protein intake among males and females, and to study the contribution of protein, fats and carbohydrates in the calorie intake of the people of hills and dwars. Methods: study site, indoor and outdoor patients attending Shanti Swasthalaya and Anusandhan Kendra Multi-Speciality Hospital, Siliguri. Study population, patients from hills, that's Darjeeling, Kashing, Kalimpong, and dwars, that's Jalpaiguri, Coach Bihar, Alipurduar. Inclusion criteria: aged more than 15 years, both vegetarians and non-vegetarians. Exclusion criteria: addiction to alcohol, cocaine, heroin, accidents and poisoning cases, ill patients undergoing parenteral nutrition, or mentally deranged patients. Sampling was random, and we studied our patients for 2 months. We collected identification data, food choice, recorded heights and weights, and BMI. Questionnaires were given to each patient, and we used the 3 days recall responses, and these were recorded for amounts, that servings in each food group and frequency of intake. We analyzed data for 100 patients. Statistical analysis included the statistical average, that's arithmetic mean. The measure of variation was the standard deviation, and the test of significance used was the standard error of difference between 2 means. Results: we found that proteins contributed 16.8% of total energy intake, much better than the rest of India. Protein energy, that is the protein energy ratio, was 16.8%. Fat contributed 24% and carbohydrate 60%. In males, the protein energy ratio was 18.7%, while among females it was 15.44%. The fat intake was 56.75 grams per day for males and 49.60 grams per day for females. The standard error of difference between males and females showed significant difference in energy intake. Protein intake was also significantly more in males, but carbohydrate intake did not stand the test of significance, and it was similar in males and females. So thank you, sir. That's my presentation. I'm not listing the references for time.
Thank you, sir. It was a good insight, and I think it is much needed. And we need to have pan-India studies in this particular line, because what we have been seeing and what nutritional surveys we have been conducting at various places, we have found that even in non-vegetarians, the intake of protein, predominantly non-vegetarian populations also in India and communities, the intake of protein is very low. So it's high time that we rise to these things and increase the intake of protein. So I think more of interventional studies are also needed. So how can we go about it? How can we increase this skewed ratio of protein and carbohydrates? So I think that will be something which will add to the value of these studies or the nutritional surveys. So your comments, please.
Yes, sir.
I think, thank you, sir. It was great.
Thank you, sir. Thank you.
Next on stage, I would like to call upon Rohit Jacob for his next presentation.
Good morning, everyone. To my third presentation, an unusual case of Kunis syndrome, myocardial injury during anaphylaxis in a healthy female with normal coronaries. A 27-year-old female was brought to the emergency with complaint of swelling over the umbilicus, which becomes prominent on cuffing. No history of fever, abdominal pain, discharge from the umbilical site, or any other sign of sepsis. Local examination did not reveal any signs of obstruction, strangulation, or incarceration. She was admitted on the same day and was prepared to be posted for laparoscopic hernia repair after 2 days. These were the investigational results, which showed no abnormal findings. This was the ECG on admission, which seems to be more like a normal sinus rhythm. On the night before the surgery, she was administered injection piperacillin tazobactam, 4.5 gram intravenous, as a part of pre-anesthetic protocol. 5 minutes post-administration, she developed complaint of fever with chills, temperature of 101, and breathlessness at rest. On examination, her pulse rate was 110 beats per minute, BP was 130/80, respiratory rate was 38, and saturation was 98% on room air. Systemic examination did not reveal any abnormal findings. She was immediately given injection hydrocortisone 100 mg IV, injection chlorpheniramine 2 ml IV, and monitored. 10 minutes later, she developed complaint of chest pain and complaint of choking sensation. On examination, her pulse rate was 110 beats per minute, BP was 90/60 millimeters of mercury, respiratory rate was 38, and saturation was 98% on room air. Systemic examination again did not reveal any abnormal findings. She was immediately administered injection adrenaline 0.5 ml IM in the lateral aspect of left thigh and closely monitored. 20 minutes later, she again had persistent complaint of chest pain with a pulse rate of 98, BP of 100/60, respiratory rate was 30, and saturation was 98. Systemic examination did not reveal any abnormal findings. After the adrenaline administration, an ECG was taken. Now, the ECG is showing T-wave inversion in 2, 3, and AVF. So this showed more like a myocardial injury kind of pattern, and hence a serial troponin values were assessed. So patient was immediately given tablet aspirin about 150 milligram and IV normal saline, and serial troponin I levels were checked every 6 hours. So as you can see here, the troponin levels were normal in the first, at the initial assessment up till 12 hours. And at 24 hours, it was found to be 1.2 nanogram per ml. So as we all know, a high level of troponin is definitely diagnostic of myocardial ischemia. But of course, if there is a serial elevation of troponin levels, even if it's normal, it is also considered to be a myocardial injury or ischemia. So 2D echo was done on the next day, and it was suggestive of normal chamber dimensions, no regional wall motion abnormality, good biventricular systolic function. Coronary angiography was done, and that also revealed normal coronaries. Fourth day since admission, chest pain subsided, and patient recovered without any residual illness. However, she was posted for laparoscopic hernia repair in the next visit. So as we see here, it is more of a myocardial injury that occurred probably due to adrenaline, but it did not manifest as an ischemia or an infarction to a greater stage. So Conus syndrome, or allergic angina as we locally call it, is an acute coronary syndrome occurring in association with conditions that involve mast cell activation such as hypersensitivity reaction, anaphylactic or anaphylactoid conditions. There have been 5 reported cases where therapeutic doses of epinephrine have caused myocardial infarction. Out of these reports, 1 was after IV injection, another after intramuscular use of injection, and 2 cases following subcutaneous injection, and 1 other where a subcutaneous EpiPen auto-injector was used. So to conclude, this study is not meant to discourage the use of adrenaline, but of course to remember the fact that adrenaline-induced complications can also occur. Nevertheless, the use of adrenaline still remains the best life-saving measure in multiple life-threatening situations. These are my references. Thank you.
Good case presentation, and it's a very rare case. So being insightful, I think, is very important in the medical practice. So great case. Thank you.
Next on stage, I would like to call Pallavi Goyal, speaking on Indian Diabetes Risk Score.
Good morning, sir. I'm Dr. Pallavi, PG resident, Mahatma Gandhi Hospital, Jaipur. Today I'm speaking on a paper I did while my internship was going on. It's on Indian Diabetes Risk Score. Diabetes, as we know, is the fastest growing chronic disease worldwide and has become one of the most common non-communicable diseases. Its burden is on the rise among all age groups, affecting urban and rural populations both. The etiological basis is not clearly defined. It depends heavily on the risk factors like age, gender, family history, which are non-modifiable, while others like smoking, diet, physical activity, and hypertension. Conventional diagnostic tests recommended by WHO for screening of diabetes are OGTT, fasting plasma glucose, and HbA1c. Although they are reliable, but they are invasive and relatively expensive for application in a low-income country and in a rural setup, making it less feasible due to cost and other constraints like lack of qualified technicians and equipment. Hence, a simple, effective, and non-invasive assessment tool could be used to screen those who have potential to develop type 2 DM in developing countries. A short questionnaire, that is the Indian Diabetes Risk Score, is an efficient diabetes screening tool which takes family history, waist circumference, age, and physical activity into account. Thus, high-risk individuals can be identified by using IDRS, and by systematic counseling and intervention, it can be an efficient tool to reduce the risk in the population. This is the Indian Diabetes Risk Score, which was developed by Mohan V. et al. It was published in JAPI in 2005. Maximum score is 100, and a positive score is more than 60. So the objective of my study was to study the relationship between waist circumference, physical activity, family history, and the risk of type 2 diabetes included in the score, and also I included body mass index, which was not a part of the score. It was a descriptive cross-sectional study done in Rural Medical College, Loni, Maharashtra for 2 months. A sample size of 120 was taken. Medical students were taken in this study. The results of my study: 5% were in score 10, 14% had score 20, 25% had score of 30, 25% had a score of 40, and 9% had a score of 50. 16.7% had score of 60, and 4.2 had score of 70. The high-risk category is 20.8%, that is score of more than 60. This is a tabular form of the same result. The Indian Diabetes Risk Score, developed by Mohan V. et al., it's very simple, fast, inexpensive, non-invasive, reliable tool to identify the individuals at high risk to develop type 2 diabetes. It has been previously validated by other researchers in India as well. IDRS comprises of 4 risk factors: age, family history of diabetes, physical activity, and waist circumference. In this study we conducted, 120 medical students were taken. Only 19% were in low risk category, 60% were in the moderate risk, and 20% were in the high risk group. These observations were similar to those done by other studies in India. This shows that a large number of the study subjects had some kind of risk of developing diabetes in the future. This is the group where active intervention in the form of health education, counseling, and further workup is urgently required. We also tried to find a significance of gender for risk of diabetes, but in our study, there was no significant difference in men and women. Also, we tried to find the risk of diabetes along with BMI. We tried to find a correlation, but and we also, the results were significant. The chi-square was significantly, highly significant as calculated, even on p-value 5% and 0.1%. In the overweight and obese group, the risk of diabetes increases as BMI increases. 33% of overweight and 34% of obese being in high-risk category in our study. This was also similar to other studies which also included BMI in their group. Few studies of Tamil Nadu and Kerala did not find any association of diabetes with BMI. Based on Asian standards, central obesity, as predicted by waist circumference, was prevalent in 40% females and 35% of males. Parental history of diabetes was present in 44% students. 89% students were not exercising regularly, neither were they performing any strenuous work. Sedentary lifestyle is an independent risk factor of diabetes. After computing for IDRS score, it was found that 20% subjects were already in the high-risk group and 60% were in moderate risk. If steps are not taken to control their obesity, they may land up in high-risk group after the age of 35 years. To conclude, do we really need a score for India? Yes, we have 32 million Indians with diabetes and have the largest diabetic pool in the world. The problem is further compounded by the fact that 60% of Indian diabetics are not diagnosed as compared to 50% in Europe and 33% in the US. Therefore, a risk score will help us to devise effective screening strategies to unmask the burden of the disease. Universal screening should be done in high-risk urban cities in India like Mumbai, Delhi, Chennai, etc. However, universal screening is neither cost-effective nor feasible. It is difficult and expensive to screen everyone. Hence, selective screening is necessary to make screening cost-effective. Therefore, there is a need for having an Indian diabetes risk score. This can come only from a geographical cohort with urban and rural component. The CURE is a classic cohort which has generated risk score called IDRS with 2 modifiable risk factors, that is waist circumference and physical activity, and 2 non-modifiable risk factors, that is age and family history, which may be amenable to intervention. These are my references. Thank you.
Dr. Pallavi,
Yes, sir.
What do you intend to do after this? Because going for an IDRS score and calculating the risk of future diabetes in medical students, we know that because basically where we should put in our resources, we should be putting in our resources at the places where they are needed the most, first and foremost. And all these risk scores, IDRS scores, they were basically developed to find the risk strategies in siblings, spouses, or the families who have parents who are suffering from diabetes. So first thing is that how do you see your study? What could be the impact of this study? And how do you postulate this study, or you increase the dimensions of the study in the general population? First is this. And what should be the future strategy? Because just identifying people with high risk of diabetes. So primarily we need to have more of interventions, what we can do. Because this is very well known that if there is an increased waist circumference, definitely that person is predisposed to diabetes. So what should be the future course of action? What should be the studies? What should be the interventions that should be planned? So that is my question.
Sir, I feel that the study I conducted was during my internship. So that at that time I took medical students. The limitation was this, that I did not take patients. But since now I am a PG resident, now I work with patients. Now I can definitely put this in the patients and find a way to help them. We can definitely, sir, counsel patients. Even physical activity can improve their HbA1c scores. It can also prevent the complications, or it can actually delay the complications of diabetes. Even a small, counseling the patient for a physical activity of 30 minutes daily. So that is what I think I want to do. That is why the score is important, because diabetes is a big burden in our country.
Thank you. But any IDS score or any scoring needs a lot of background data. So
Yes,
whether
sir.
this scoring has enough background data, research has been done, because you cannot do that, these numbers you can give by your own.
Yes, sir.
No. So it requires a lot of research. That
Yes,
is
sir.
why you have kept 0, 1, 2, these scores.
Yes,
That
sir.
requires. Because initially at the Becker's Institute, Australian this score was developed. And they had a very scientific manner. Why 0, why 1, why 2? And that
Yes, sir.
requires a lot of scientific data. We cannot do by our own.
Sir, I definitely feel that research needs to be done. I don't know whatever research has been done on this score is enough or not. I am not the person to comment on that. But I think even if we start at a small level, then we can definitely make a change. That is what I feel, sir.
Thank you. Thank you.
Thank you, sir.
Next on stage, I would like to call upon Daksh Bansal, a case of a silent killer, rare presentation of carbon monoxide poisoning and its successful treatment. Daksh.
Good morning, everyone. My name is Dr. Daksh Bansal. I'm a medicine resident at Dr. Ram Manohar Lohia Hospital, New Delhi. I'll be presenting a case titled "A Case of a Silent Killer, a Rare Presentation of Carbon Monoxide Poisoning and its Successful Treatment." A 45-year-old lady who was apparently healthy until the morning of 11th January was found in a state of altered sensorium, along with her husband, who was also found unresponsive. According to her son, the previous night, both the lady and her husband had slept in a closed room with a partially burning coal-lit fire, also known as an angithi. Both were taken to a nearby hospital where the husband was declared dead and the lady was admitted and given supportive treatment, after which the lady recovered and she was discharged 48 hours later with no neurological deficit. The routine investigations during this admission were normal. The ABG and imaging were not done. Now, 1 month later, the same patient was brought to our hospital emergency in a state of altered sensorium with complaints of generalized slowing of movements for the past 10 days, associated with inability to maintain an upright posture and inability to speak. On examination, the patient was vitally stable. On the CNS examination, the patient's GCS was E4V1M4. She was not oriented to time, place, or person. The patient was awake and opening eyes spontaneously, but no meaningful response could be elicited. She was unable to communicate and comprehend any of the commands. The cranial examination, no deficit was elicited. Both the pupils were normal in size and normally reactive. In the motor system examination, tone was increased, generalized in all the limbs. In a lead wheel type of rigidity was seen. The patient had a mask-like face, the glabella sign as well as the grasp reflex were present. All the deep tendon reflexes were normal, the plantars were flexor. The patient, on sensory examination, the patient had a withdrawal response to pain, but other modalities could not be examined properly. Neck stiffness was present, but Kernig's and Brzezinski's was absent. The rest of the systemic examination was within normal limits. Now, we investigated a patient on the lines of subacute encephalopathy to rule out infective causes as well as metabolic causes. The routine investigation of the patient was within normal limits, as you can see. A CSF panel was done which was suggestive of mildly raised protein, but it was the cytology was acellular and rest of the infective workup in the CSF panel was negative. The ABG analysis, no hypoxia was seen, no CO2 retention or metabolic abnormality could be elicited. These investigations were also done along the same line of thought, that is to rule out infective as well as metabolic causes, as well as to rule out any autoimmune cause. A brain imaging was also done. NCT head was suggestive of bilateral chronic lacunar infarct in the basal ganglia region, and an EEG which was suggestive of a diffuse background slowing in the delta range suggestive of encephalopathy. This was done to rule out non-convulsive status epilepticus. As most of the investigations were non-contributory, we planned for an MRI brain. The MRI brain was suggestive of hyperintense signal in symmetric distribution in bilateral globus pallidus as well as the deep white matter area, which also showed marked diffusion restriction in the deep white matter as well as the globus pallidus areas. Now, following this, we also planned a TRODAT scan. This was done because carbon monoxide is a documented secondary cause of Parkinsonism. So we did a TRODAT scan as well. Although this did not show any abnormality, there was preserved tracer binding in the basal ganglia area. Now, on the basis of history and examination, this was the timeline of events. The day of accident was on the 11th of January, followed by a lucid interval of 20 days in which the patient was absolutely normal. And then she presented to us 1 month later. Now, keeping in mind the history, the examination, and ruling out all other causes of subacute encephalopathy, and on the basis of the MRI findings, we kept the final diagnosis at delayed subacute encephalopathy due to carbon monoxide exposure. All the supportive treatment was given. The patient was enrolled into a hyperbaric oxygen therapy program in which she received 15 sittings of HPOT during her stay in the hospital. Five more sittings of HPOT were given after discharge. Injection IV steroids were given for 2 weeks, followed by an oral therapy for further 2 weeks, the total duration of 4 weeks. And tablet galantamine was also started after informed consent of the patient. At the time of discharge, there was no significant improvement in the patient. No verbal output was seen. The patient was not able to follow any basic commands, although she was moving all her 4 limbs spontaneously, and generalized rigidity had reduced since the day of admission. The carbon monoxide poisoning in India, it has a very high mortality rate. A study which was done in AIIMS from 2010 to 2015 revealed 40 cases of fatal CO poisoning. The high fatality of carbon monoxide poisoning has been attributed to the early misdiagnosis as well as the late presentation to the hospital. Now, in some cases, mostly the patients do not survive, but the patients who survive acute carbon monoxide poisoning, they have around 2 to 3 patients tend to have a biphasic presentation, in which they present to us with delayed neurological sequelae after a lucid interval. Now, delayed neurological sequelae is usually diagnosed in only 2 to 3% of such patients. Now, we further reviewed the literature regarding the treatment of delayed neurological sequelae, but no definitive guidelines exist regarding this specific diagnosis. But a few, like a potential neuroprotection bundle, which has been proposed by some authors, which includes targeted temperature management, hyperbaric oxygen therapy, and anti-inflammatory therapy. Now, after reviewing further literature, we found around 2 case reports, in which they had successfully used acetylcholine esterase inhibitors like galantamine and donepezil in treatment of delayed neurological sequelae. On the basis of these case reports, we took an informed consent of the patient and we introduced tablet galantamine in our patient. Now, the surprising thing was that we followed up the patient. At 1 month of follow-up of the patient did not improve much. The patient had developed tremors, but she was able to have she was able to follow basic commands like clenching of fist and closing of her eyelids. But the surprising thing was that at the 2-month follow-up, the patient came walking to us in the OPD. She was able to carry out all her activities of daily living independently. She was oriented to time, place, and person. She was able to speak and have a meaningful conversation with the family members. The thing was that the patient had developed tremors, and after examining the patient, we also noticed that the patient had anterograde amnesia. She was not able to remember events post the accident, which is again a documented finding in patients of delayed neurological sequelae of carbon monoxide poisoning. So in conclusion, I would like to say that usually the patients do not survive an acute carbon monoxide poisoning event, but the patients who survive, they tend to have a biphasic presentation in 2 to 3% and should be under close neurological follow-up. And there are no definitive predictors of delayed neurological sequelae in such patients. Like, we cannot predict that which patient will develop a delayed neurological sequelae, but some biomarkers are under evaluation, like CSF myelin basic protein, which is based on proposed pathophysiology of delayed neurological sequelae. And there is a significant role of hyperbaric oxygen therapy, not just in acute, but also in the delayed neurological setting as well. And the role of galantamine, although it has just been reported in some case reports, but it needs to be studied further. And such patients need to be under close neurological follow-up, as carbon monoxide poisoning can later lead on to Parkinsonism. As in our patient, the patient had developed tremors, so she's still in a continuous follow-up with us. Thank you.
Nowadays, these coal agoutis are very rare.
Yes,
and 30, 40 years back, we used to see a lot of cases of carbon monoxide poisoning.
Yes,
but still, the cases can be there. Few areas in India still use these coals as a source of heating. So, very interesting and good job done. Thank you. Thank you.
would like to call upon Mohammad Muzamil. Mohammad Muzamil. Mohammad Riaz. Vishwa B. Unakat. I think, judges, we are done with the presentation here. Thank you, judges.
Presentation of the morning time, and we have done it within stipulated time, and everything is running at the time. So, thank you.
Thank you, judges. For our Best Thesis Award session, I would like to call our judges, Dr. J.K. Sharma and Dr. M.M. Prabhu, on the dais, please. Judges, with your permission, I'd like to call upon the first presenter, Dr. Sunny Malde, representing on study of categories of albuminuria and its correlates in diabetic kidney disease.
A very good morning to all of you. Myself, Dr. Sunny Malde. I am going to present my thesis topic about the studies of categories of albuminuria and its correlates in the diabetic kidney disease. So, coming to the introduction, diabetes mellitus is a metabolic disease with a rising prevalence worldwide, causing multi-system damage. The prevalence of the macro and the microvascular complications such as diabetic nephropathy, which occurs around 20 to 40% of type 2 diabetes patient, has risen worldwide. The classical phenotype of diabetic nephropathy is described as the linear progression from normoalbuminuria to microalbuminuria to macroalbuminuria and eventually ending in the end-stage renal disease. So the recent studies have shown the possibilities of decline in the GFR without the presence of significant proteinuria, which is a UACR ratio of more than 300 milligram per gram, is known as a non-proteinuric phenotype of diabetic nephropathy. This is albuminuria and diabetic kidney disease is divided into three categories based on the spot urine and its finding its urinary albumin creatinine levels. So the three categories are normoalbuminuria, which is less than 30 milligram per gram, which is A1 category. Microalbuminuria is 30 to 300 and macroalbuminuria is more than 300, which is A3. So the proposed mechanism of correlates of non-proliferative diabetic nephropathy, as it is very much important these days. So the mechanisms are these various factors such as age-related sclerotic changes in the glomeruli, interstitial fibrosis and ischemia. Microangiopathic changes are more than the microangiopathic changes, and enhanced vascular resistance in renal interlobular arteries, which can be assessed by the renal resistive index. Atherosclerosis is enhanced in patients having NPDN, ankle brachial pressure index can be used as a surrogate marker for detecting atherosclerotic changes. And hyperuricemia and inflammatory markers such as TNF-alpha, TGF-beta, VEGF, ICAM, VCAM, these are the factors which may act through the apoptosis and vascular inflammations. So this is the pathogenesis of diabetic kidney disease. Basically in diabetes mellitus, there are various metabolic factors and hemodynamic factors. These both factors plays a role together and they're causing the activations of the intracellular signaling pathways oxidative stress, dysregulated autophagy, and epigenetic changes which leads to the inflammation and fibrosis leading up to the diabetic kidney disease. So our research question was, what is the proportion of categories of albinuria like A1, A2, A3 in patients with diabetic kidney disease, and what is the correlation of renal resistivity index, ankle brachial pressure index, and serum uric acid with the categories of albinuria in patients of diabetic kidney disease. So the aim of the study was to determine the categories of albinuria and diabetic kidney disease and to correlate these categories of albinuria with various factors such as renal resistivity index, ankle brachial pressure index, and serum uric acid. And the objectives were to see the proportion of the categories of albinuria in the patients among the diabetic kidney disease, to measure the serum uric acid, ankle brachial pressure index, and renal resistivity index, and to see its correlation with the various categories of albinuria in patients of diabetic kidney disease. So these are the various review literature. There are 4 literature which I have taken, which showing the various factors like renal resistivity index, uric acid, and ankle brachial pressure index, and its relation to the diabetic kidney disease. So the type of study was a cross-sectional study, and it was studied at the Department of Medicine at Eras Lucknow Medical College, Lucknow, and the duration of study was of 24 months, and all the IPD and OPD patients of Department of Medicine were diagnosed as a type 2 diabetes mellitus with diabetic nephropathy as per the criteria of JNC were taken, and sample size was 148. Exclusion criteria, we have excluded the patient such as the kidney disease from the other cause from the diabetic nephropathy such as obstructive uropathy, UTI, polycystic disease, renal artery stenosis, hematuria, malignancy, sepsis, and patient consuming uric acid lowering drugs, pregnancy, and critical ill patients. So this is the table showing the classification of classical diabetic nephropathy. On the extreme left-hand side, we have the various stages of the nephropathy, from stage 1 to stage 5, which is stage 1 is pre-nephropathy, and when we do the USCR ratio, it comes out to be the normoalbinuria of less than 30, and eGFR tends to be more than or equal to 30. Similarly, microalbinuria, which is an incipient nephropathy, overt nephropathy, which is a macroalbinuria or persistent proteinuria, and kidney failure is the stage 4 of CKD, which in the urinary albuminuria ratio, it can be any state of albinuria or protein status, and the eGFR levels are less than 30. So this is the flow chart of the study. Initially, we took the patients presenting in the medicine OPD with the type 2 diabetes mellitus. Screening for the inclusion and the exclusion criteria was done. History and examination and urine and blood samples were taken. Renal Doppler was performed, and eGFR was calculated based on the Cockcroft-Gault formula, and based on it, we have divided into 3 categories of USCR of less than 30, USCR of 30 to 300, and USCR of more than 300. And after it, we have correlated it with various parameters such as serum uric acid, renal resistivity index, and ankle brachial pressure index with categories of albinuria. So results are, first is the categories of albinuria. We, according to 148, from the 148 sample size, we have found that around 48% of patients had microalbinuria, and the second most common was 32% patient had normoalbinuria, with 20% having a macroalbinuria. So this is the graph showing we have taken various comorbidities and correlating it with the various categories of albinuria. So A1 category, which is a normoalbinuria, we have seen that type 2 diabetes mellitus and cardiovascular diseases were most common, around 62.5% in patients of normoalbinuria. And in microalbinuria, type 2 diabetes mellitus and hypertension were most common. And all the risk factors on A3 category, type 2 diabetes mellitus, hypertension, and CVD were around 35.3%. So we have, after categorizing the patient, we have taken various parameters such as uric acid, HbA1c, SBP, renal diastolic blood pressure, renal resistivity index, and ankle brachial pressure index, and based on it, we have correlated it with various categorical group. So in A1 category, which is a normoalbuminuria group, we have found a very significant finding that in the early stages of diabetic kidney disease, renal resistivity index and ankle brachial pressure index and uric acid was statistically significant. And in coming to the A2 category, we have also found that USCR, uric acid, RRI and ABPI, it is statistically significant. But it was very strange that we found it in normoalbuminuria. And this is we have also done the fundus examination in these patients, and it had shown that around 42.5% of patients in normoalbuminuria group doesn't have any kind of retinopathy. But in microalbuminuria group, we have found that moderate type of non-proliferative diabetic retinopathy was present, and severe retinopathy was present in microalbuminuria group. And we have also done the NCV, and we have found out that around 35% in A1 category, and around A3 category, we have found 68% of patients had sensory motor neuropathy. So concluding to this result finding, so it is very important nowadays to rule out the patients of diabetes with any kind of diabetic kidney disease initially, so that we can prevent the patient landing up into CKD. So while albinuria is considered as the gold standard for diagnosing diabetic kidney disease and remains the strongest predictor for mortality in diabetes, and it does not detect almost the half of the patient with the diabetes that progress to diabetic kidney disease, which list remains normoalbinuric. And this study was attempted to stratify the risk for renal disease progression according to albinuria as well as according to the values of EGFR as well. This cross-sectional observational study also showed that alongside with the albinuria excretion, EGFR may also be helpful to predicting the worsening renal function in the early stages of normoalbinuria itself and progression to later stages of albinuria in type 2 diabetes mellitus patients. Thank you.
Thank you, Dr. Sunny.
Thanks.
What message you would like to give?
Sir,
What message you would like to give to the audience?
Yes, initially as being a role of physician, whenever we detect any patient with type 2 diabetes mellitus, initial stages, if we go for initial investigation for any type of complication, so that we can prevent it early. So it is in our hand that we can detect the complication early, so that the patient burden reduces of the diseases later on.
Thank you.
So good study, but there are any drugs which are approved for prevention of the progression of the disease now?
Yes.
And what drugs these patients were on? You told that some anti-uric acid drugs were not there, but were they on AC inhibitors, SGLT2 inhibitors like that? You
No,
didn't
sir.
mention those things.
Yes, sir. These patients were not on any type of antihypertensive like ACE or ARB. We have taken such patients. And after finding out that these patients were having normoalbinuria or microalbinuria, we have started them on ACE and ARB therapy. And
AC
we have,
or ARB or
Yes.
started. And you told microalbuminuria based on one value or three values, or what was
based
the
on,
method
sir,
used?
Sir, based on the three values, we have taken patient three values.
Three values,
Three
two
values,
present.
two present.
Over a period of?
Over a period of 3 months, we have done this.
Okay. Now, just for this thing, you are asking, what are the other drugs which are proved benefit in prevention of the kidney disease?
Sir, such as SGLT2 inhibitors are also helpful.
Yeah.
And they are very good drugs for prevention of diabetic kidney disease. And we have found out various studies on them which are very helpful.
AC, ARB,
ACE,
SGLT2.
ARB, and
Any other
SGLT2.
new drug?
Sir, new drugs such as this DPP4 inhibitors are also helpful.
DPP4 inhibitors may not.
May
Okay.
not.
Anti-inflammatory drug, Fenrinon is another newly FDA approved drug to prevent this. They are in early stage. They can progress to stop that. Thank you. Good study. Thank you.
Thank you, sir.
Good morning to all. I am Dr. Akanksha Tandon, and I'll be talking about association between ankle brachial index and severity of coronary artery disease. So the clinical research question of my study is that can ankle brachial index be used in routine clinical practice to predict the severity of coronary artery disease? The aims and objectives of my study were to investigate ABPI as a surrogate marker and predictor for severity of coronary artery disease, and to determine the relation between ABPI and angiographic findings, along with major cardiovascular risk factors in patients with suspected or at risk of developing CAD. So this study investigated the association of ankle brachial pressure index with various atherosclerotic risk factors and angiographic findings in suspected CAD patients without peripheral arterial disease. So all patients with peripheral arterial disease were excluded from my study. And blood pressure ratios between the four limbs can be simultaneously obtained and calculated with ABI measurement. So the rationale of my study was that ABI is a measure of the severity of atherosclerosis in the legs, and an abnormal ABI value that is of less than equal to 0.9 is sensitive and specific for detecting PAD. But it is also an independent indicator of the risk of subsequent atherothrombotic events elsewhere in the vascular system, which is a leading cause of morbidity and mortality in the world. ABI may be used as a risk marker both in general population free of clinical cardiovascular diseases and in patients with established or suspected CVD. So my research methodology was that it was a hospital-based cross-sectional analytical study which was conducted in the Department of Physiology in KGMU in collaboration with the Department of Cardiology, and the total study duration was of 12 months. So I recruited the subjects from Lari Cardiology Department OPD, fulfilling my inclusion and exclusion criteria, and informed written consent was filled by each subject. Patients who were included were all the subjects who came to me in the OPD, along with patients who were in the IPD after their angiographic findings were concluded. Subjects at risk for CAD examined were on the basis of risk factors like age, sex, endocrinological disorders including diabetes, tobacco and smoking history was also taken along with their hypertension status. Patients with chronic stable angina, unstable angina, non-ST segment elevated MI and ST segment elevated MI were included in my studies, and all the patients who were planned for coronary or CT angio were included. Patients with lower limb gangrene, deformity of the upper or the lower limbs who did not give consent for the procedure, any patients with valvular or congenital diseases or established malignancy and with severe lung, renal or liver comorbidities were excluded from my study. So ABI was measured in supine position using an automated device, which was a portable device. And this device automatically and simultaneously measured systolic and diastolic blood pressure of both right and left sides using the oscillometric method. Right ABI was calculated by the ratio of the right ankle systolic blood pressure divided by the higher systolic blood pressure of the arms. And also likewise left ABI was calculated by the ratio of the left ankle SBP divided by the higher SBP of the arms. So in cases of different values between the right and the left side, the lower value was included in my study, and the value was calculated up to 2 decimal points. After measuring ABI patients, I categorized them into 2 groups, that is ABI positive, having an ABPI value of less than equal to 0.9, and ABI negative. Particularly in ABI negative, I further subcategorized them into 2, which is between 0.9 and 1.2 and more than 1.2. The basic aim was to include patients having an intermediate risk of developing vessel disease, having an ABPI value of between 0.9 to 1.2. So angiographic findings were included, like having single vessel, double vessel, and triple vessel disease. And the vessels which were studied were left marginal coronary artery, right coronary artery, left anterior descending artery, diagonal arteries, obtuse marginal, and left circumflex artery. Vessel occlusion was also as a criteria which was seen in the angiographic findings, seeing no occlusion, less than 50% inclusion, and more than 50% inclusion. And the third thing which was included in my study was vessel calcification, whether the vessels were calcified or not calcified. And then further, these angiographic findings were compared with my ABI values. So with respect to these angiographic findings, I divided them into two categories, which is mild CAD and severe CAD. Patients having no vessel involvement or a single vessel disease were included as mild CAD, and patients with severe CAD who were having angiographic findings involving double vessel and triple vessel disease. So based on the formulated objectives of the study, in a sample size of 210 subjects, as I already said, I divided them into three categories. Thereafter, interpretation using descriptive and inferential statistics, it was done on two categories, that is ABI positive and patients with intermediate risk. Among the population studied, 49 subjects were ABI positive and 161 were ABI negative. And out of those 161, 20 patients, that is 9.5% patients, had an ABI value of between 0.9 and 1.2, that is at intermediate risk of developing CAD in future. So patients having low ABI showed that 24.4.8% patients had single vessel disease, 51% patients had double vessel, and only 24.48% patients had triple vessel disease. Taking ABI as a dependent factor and vessel disease, single, double, and triple vessel disease is an independent variable, we took out inferential statistics and we took out these coefficient values, in which we can see that in single vessel disease, the coefficient value is 0.84, and as we move on from single vessel to triple vessel disease, the coefficient value increases with a p-value of less than 0.05, which is statistically significant. In cases with ABI values between 0.9 and 1.2, significant values were seen with patients having triple vessel disease. As I said that I also studied various atherosclerotic risk factors and compared between the two groups. So there was statistical value seen between patients having a history of diabetes, hypertension, family history of CAD, and smoking, but no significant, statistically significant findings were seen with BMI more than 25. So the conclusion of my study is statistically significant association was seen with these risk factors except BMI more than 25. And the risk of severity of coronary artery involvement is significantly higher in ABI positive, as with increasing involvement of the vessels from single vessel to triple vessel disease, in which ABI is less than 0.9, which was statistically significant. So thus, supporting the statement that low ABPI can predict the severity of CAD, and I also said that there were patients having borderline risk, in which also significant association was seen with the vessel disease involvement. So since this is a hypothesis proving study, so therefore it has a high significance in clinical setting. Thank you.
Thank you, Akanksha, for a good study.
Thank you, sir.
Your study is from the cardiology patients. They
Yes.
came to physiology after they have undergone angiogram or before angiogram?
So before, all patients who were planned for CT or coronary angiography, initially when all patients who were at risk or suspected CAD, patients who came to OPD, all those patients were...
These patients were excluded.
Peripheral arterial disease patients were excluded.
Excluded.
Yes,
so
sir.
none of them had this thing.
No, sir.
And you looked at the risk factors, you told only diabetes and hypertension.
Yes,
What is
sir.
the other most important significant risk factor which probably would have been done which you didn't look?
Sir, history of smoking, tobacco intake, and having a significant family history of CAD.
Yes. One more is cholesterol. Lipid profile.
Lipid profile.
Okay, so you didn't look that
So lipid
consideration.
profile was included in my study.
But you didn't show
So
that.
yes, sir. So but it was included in my study with all the cholesterol, LDL to HDL ratio and CHOL to LDL ratio.
Did you find
all-
the differences?
Yes,
between-
sir. Yes, sir.
And you told that some people had a normal coronaries, but
Yes, sir.
they were having a significant low brachial index. That you didn't show the number. Those who had a normal, mild or no coronary artery disease. How many were there?
Sorry, sir, I did not get
No
it.
coronary artery disease. No obstruction documented.
In how many patients the coronary CT angiogram was done, and in how many CT coronary angiogram and in how many conventional angiogram was done? How you decided the calcium scoring?
Sir's question is, how many of them underwent a conventional coronary angiogram and CT angio? And what was the coronary calcification score?
So calcification score wasn't calculated. I did not calculate the calcification score. Whatever findings were given in this angiographic findings showing +1, +2 or +3 calcification, they were just as such included in my study. But as such, no calcification score was calculated.
And out of that 160, how many went for conventional angiogram or CT angiogram? That you didn't show that.
Yes, sir, that I did not show.
And what are the other surrogate markers to look for this coronary artery disease?
So there are cardiac biomarkers like TROP-T, BNP, and
No, they are for the acute, for the chronic, underlying CAD, any surrogate markers.
so CKMB. and-
Carotid edema media thickness, did you go for that? Did you go for the retinal examination, the fundoscopy?
So fundoscopy, no.
Okay, thank you very much.
Thank you, sir.
Thank you so much.
Relevance to the history is important, both time management we give 18? 18, yeah, for both. Okay, reliving the study I have 14. For this, Vedanta is also 14. Time management. Mark for communication skill, she is little better or he is better? He is little better. We can give 16 and 14. Presentation skill is good for both.
Sir, आप take over करिए.
Question answer. Question answer. He put answer. He was 14. So whom to give you suggestion? I give 14.
This award session. I would like to call the next session of moderator, Dr. Ajoy Tiwari, for the next session. Thank you so much.
Good afternoon, everybody. And this time, American College of Physicians is going to do something which is very pertinent and very relevant. So we are having a hands-on training on bronchoscopy. So to chair this session, we have got two eminent consultants, Professor Julhasuddin and Dr. Sanjay Arora. So may I request the chairpersons to kindly come on the dais and introduce our speaker and the performer who will be showing us the nitty-gritty of bronchoscopy and how it is pertinent to us as clinicians.
For our next session, that is on fiber optic bronchoscopy, we have Dr. Viruttam Tomar. He's MD in chest, FCCP USA, EDRM from Italy, interventional pulmonologist, EBUS, and critical care expert. He's director, Dr. Shivraj Memorial Chest and Allergy Center from Meerut. Welcome, Dr. Viruttam Tomar.
Thank you, Chairperson. And good afternoon, everybody. First of all, I want to congratulate American College of Chest Physician in Indian chapter for organizing this conference and giving me opportunity to give this lecture on the basic of fiber optic bronchoscopy. And the purpose of this talk is to sensitize the physicians regarding the bronchoscopy. And you will see in my slides that first bronchoscopy was done by ENT surgeon, and later on, lots of physicians are doing bronchoscopy world over. So in next 25 minutes, first I will give the glimpse of what is basic bronchoscopy, what is the indication and other, and what is the newer things are coming up in the bronchoscopy, the suits. And later on, I'm having this Olympus bronchoscope for workshop. If anybody want to do hands-on, we can. I'm glad and thankful for Olympus people for giving this mannequins and this scope here. So to start, I am Dr. Viruttam Tomar from Meerut, working as interventional pulmonologist. So since long, doctors are having curiosity to look inside the body, how we can see inside the body. And this journey started in 1805 when Philip Bozzoni invented this illuminator. And he took this candle and the mirror here, and he looked in the throat and see vocal cords. And later on, till date, we are having the small chips that can be put on the fingertips that we can see all these images in the monitor. Regarding this bronchoscopy, the Gustav Killian, we call it the father of bronchoscopy. He has done first removal of foreign body from the right main bronchus in 1897. And before that, in 1895, Alfred Christian from Germany, first direct visualization of vocal cords done by using of esophagoscope. He called it otoscope. And Gustav Killian in 1897 from Freiburg, Germany, examined trachea and main bronchi and removed 3 foreign bodies in the similar fashions from the rigid bronchoscope. And 1898, Dr. Elgren colleague from Harvard Medical School used open urethroscope with a head mirror to see and to remove the hard rubber from the right main bronchus. On May 29, 1898, Gustav Killian stated at the 5th annual meeting of South German ENT Society conference in his first report on direct bronchoscopy, he said, the practical relevance of bronchoscopy cannot be assessed accurately at that moment. I hope that apart from foreign bodies and bronchial disease, it may also be applied to diagnose and therapy of affections of the lung. And today, more than after 125 years, what Dr. Killian said is true today, and we are using this utility in different disease and for different purposes. In 1897, the junior of Dr. Gustav Gillian, Polinki in Freiburg University said, on March 30th of this year, I had the honor to assist my admired principal, Professor Killian, in extraction of piece of bone from the right bronchus. This case is of such peculiarity with respect of diagnostic and therapeutic importance that a more extensive description seems justified. And these are the pictures Dr. Killian doing in the sitting posture or in the lying posture using this primitive rigid bronchoscope. Later on, Cavalier-Jackson has invented the telescopes, and he has his own workshop. They developed 0-degree, 30-degree, and 90-degree telescopes, and they use in rigid bronchoscopy. In 1970-80, the era comes of fiber optics, and Dr. Shigeru Ikeda developed this flexi-rigid and this flexible bronchoscope, and we call him as the father of flexible bronchoscopy. These are the developments you can see from starting rigid bronchoscope to flexible bronchoscope, from video scopes, and later on we are now having robotic bronchoscopes worldwide. We are using different types of very thin, small scope, pediatric scopes, alveolar scopes we are having, which we are using in pulmonary medicine. This is the basic bronchoscope, video scope, like this, which is having, latest one is 190 series. That is very advanced bronchoscope. Just to give the list of indications, we can use as a diagnostic tool, like for ventilator-associated pneumonias, for community-acquired pneumonias, for acute interstitial lung disease like hypersensitivity pneumonitis, and intrathoracic tumors are for therapeutic purpose to remove the mucus from the bronchus, especially in the ICU patient when on ventilators, or to remove the inhaled foreign bodies, to look the central obstructing tumors, central area of tumors, and the management of massive hemoptysis. These are having good utility. And it also helps to support when anesthetists fail to intubate or patient is having difficult intubation, then we can use this type of technology. Even for percutaneous tracheostomy, we use this type of bronchoscope we can utilize. And like inspection of upper airways, to lower airways, vocal cords, for evaluation of diagnosis of chronic cough. The most important use of bronchoscopy is cough. More than 37 to 48% bronchoscopy is utilized for the cough. And in any physician's clinic, more than 50% patients are from the simple cough or viral bronchitis sometimes. But these chronic cough, not always chronic bronchitis, there may be some foreign bodies, there may be endobronchial tumors, there may be interstitial lung disease. So it's the evaluation of chronic cough. This is the tool to rule out for wheezing evaluation, especially in children, to look out foreign bodies. For pneumonia, persistent pulmonary infiltrates, disrupted bronchial tree secondary to trauma, thermal or chemical inhalation injuries, and position of patency of endotracheal tube or tracheostomy tube. And the management of tracheoesophageal fistula, we can put stents, both metallic stents and the plastic stents. For management of tumor, debulking of tumors, to removal of foreign bodies, and to assess the lymphadenopathy by transbronchial needle aspiration. For mediastinal lymph node, we can do different type of needles we can use for mediastinal lymph nodes. There are few contraindications. Like absolute is like patient has not given informed consent. You have not taken informed consent. Profound refractory hypoxia is not improving by giving simple 2 liter, 3 liter of oxygen by face mask. Or patients having severe bleeding diathesis not controlled at the time of procedure, and patients having malignant cardiac arrhythmias. Relative indications like patients having lack of cooperation, recent myocardial infarction or unstable angina, respiratory insufficiency or failure, uncontrolled hypertension, and severe pulmonary artery hypertension are relative contraindications. And uremia, especially when we want to take biopsies, transbronchial lung biopsy, you should avoid in the. And to start with bronchoscopy, there is a simple requirements like one table, OT table, simple OT table can work. and oxygen source, and suction should be good. And at least 2 suctions should be there in OT, so if one fails, then another should work. All cardiac monitoring and resuscitating, and the trolley for all instruments, and facility to display radiographs. The trained respiratory or any physician can do, if having little bit training in the bronchoscopy, he can perform bronchoscopy in any hospital's OT, and bedside, even in ICU, he can perform this type of procedure. 2 personnel are minimally required, like one scrub nurse and one the trained physician, but you can have, if you have opportunity to have 1 or more, if you are doing in anesthesia, then definitely you require 1, 3 or 4 personnel to do in anesthesia. Informed consent is must. All parameters like bleeding parameters, BT, CT, PT, PTT, and platelets are essential, along with urea. And radiologically, you have at least X-ray chest, PA view or lateral view. CT is more informative if you are having HRCT, so that you can do the bronchoalveolar lavage for particular segment, and you can avoid unnecessary poking this scope in other segments. The instrument is basically flexible and rigid, but to start, flexible bronchoscope is a must. And if you are having ROSE facility, ROSE is rapid on-site evaluation for, like if you are doing transbronchial needle aspiration, then immediately a pathologist give answer that this patient is having at least lymphocytes or any malignancy in the lymph node or not. So you can do this by ROSE technique. For upgradation, the newer technology that has changed the pulmonary medicine totally, I can say the pulmonary medicine has changed since the development of bronchoscope, then later on development of HRCT thorax, and now in 2000 it's the EBUS, endobronchial ultrasound, that has changed totally the pulmonary medicine or interventional pulmonary medicine era. That is EBUS. We can have this position, the routine we are doing from the supine, from the head end, or lateral position you can do when few bronchoscopists are trained in the lateral positioning. Anesthesia, local anesthesia, 2% xylocaine. Even I am doing in the 1% xylocaine spray on the vocal cords, and conscious sedation can be used like in midazolam or using propofol or combination of this fentanyl and this midazolam. Definitely you require this type of workshops where you can train with experienced experts to how to do bronchoscopy. There are simulators are available where you can learn different types of stations, how to perform, and different books are available like this, bronchology, www.bronchoscopy.org, where you can learn the basic bronchoscopy, even advanced bronchoscopy, even EBUS you can learn in this, having this, you can note down and you can learn to start bronchoscopy. When we say the technology, the newer development in interventional pulmonology, look this video, it's like this. What we are assuming now, that is become very near future, these technology can be available. So, like this, EBUS. You are doing, this is the EBUS, it's a bronchoscope. On bronchoscope tip, there is a ultrasound probe. This is a convex probe, and here needle will come out, and while direct visualization, when you touch this scope to the tracheal wall, you will see the different lymph nodes and vasculatures, and in real time, you can puncture these lymph nodes very efficiently. So this is the change in the different needles. We are having transbronchial, for lymph node biopsy, we are having small miniature needles, and the elastography, we can use like this in blue dot here. If you are finding on EBUS this large round lymph node, you can say that this is a malignant lymph node. If it is reddish in color, there is a benign lymph node. So you can accurately, if you are finding one blue and another one is red, so you have to puncture this blue one to confirm that this you are hitting right node or not. Just to give this EBUS, endobronchial ultrasound, how it works. This is the lymph node, and you here see this is the needle. The real-time FNAC you can done when you are puncturing this lymph node by the EBUS scope. This needle is coming out and taking the FNAC, this from the here. This subcarinal lymph node, basically, this is a subcarinal lymph node, station 7 we call it. And this elastography, I have already told you regarding this. Another thing is coming up is electromagnetic navigation. In India, two centers are having this electromagnetic, the EVM we called, where like you are driving a car with the help of GPS, if there is any particular peripheral nodule is present like here, so you have to select the path, and this module, this system give you the path, and you have to reach at that permanent nodule very efficaciously, and you can take out the transbronchial lung biopsy from peripheral nodule very perfectly. LIFE is a tool, another method of bronchoscopy, where the laser-induced fluoroscopic guidance images are produced. If you detect in malignancy, this like in carcinoma in situ or early dysplasia from mucosa from the trachea bronchial tree, you can increase the survival of the patient up to the 90%. But if you detect it later on stage, when invasion is already occurred, hardly 5 years survival is hardly 15%. So there are the method like this. LIFE, when we use, in normal white light bronchoscopy, you find almost normal mucosa, little bit inflammation. But when you put a button and shift to the LIFE or light band imaging, you find this is the suspicious malignant or dysplastic mucosa. And if you take biopsy from this, and you can, I think, detect earlier malignancies of tracheobronchial tree and increase the life. This is narrow banding imaging, increasing the size, vascularity. You can see the same looking normal mucosa, but when you switch off to the NBI by the same button here, that can be, you can find this increased vascularity and take biopsy from this mucosa. Another thing is coming up, it's optical biopsy. Even without doing biopsy, you can see the invasion of this mucosal or cartilages. When you touch this growth and you want to see the invasion by optical biopsy, without doing biopsy, you can do. And one thing is more coming up, the confocal biopsy imaging. There is a real-time images of histopathologically. Without even taking tissue from the bronchus or alveoli, you can see these type of disease, and where the risks are more, like interstitial lung disease, IPF, you don't want to take biopsies. At that moment, these type of confocal imaging are helpful, and this will be available. You can see this alveolar structure looking, this is the is abnormal, and this is a normal structure. This is totally infiltrate with the either malignant alveolar carcinoma or the different things. Here you can see the virtual histology. By putting scope on the alveoli, you can see the malignant tissues are coming like this. This is a normal, and you can see the larger. So without taking biopsy, you can see by the bronchoscope, and this the endoscopists are using in the colonic cancer. This is a colonic cancer cells looking like this when they are so these are the technology. One more technology, like COPD patients, where emphysema is significant. If you do lung volume reduction surgery, the survival and the breathlessness score and overall improve. And but the risk of VATS or thoracic surgery is significantly high. So what we are doing, we are having this bronchoscopic valves are there, the one-way valve. When you put these valve, like in upper lobe bullous area, if you want to occlude this or lung volume reduction you want to do, you first calculate the size of this bronchus, and you can put different valves in all segments to complete collapse this upper lobe. And this is what we call non-surgical techniques like this, one-way valve. You have putting the umbrella valve, all secretion will come through there, but no air will go inside this. So there's no chances of abscess formation and all that. And all the lung air from the particular lobe will come out, and this part of either segment or lobe will collapse automatically. So this is a very newer things that are available and practicing in the world over. And in India, I think in next few years, the government will allow to put these type of valves. Like you can see here, this is looking emphysematous lung. And if you want to collapse this lung, you can see this is the complete collapse of this lung, and patient, that contour of diaphragm will improve, and the dyspnea score reduces significantly when you're using this type of. Another methodology, by putting the shape memory nitrilol stents, these implants, when you put these stents in the particular bronchus, this will take automatically shape and reduce the particular lobe or segment volume. Here you can see in this picture, multiple coils are putting in the upper lobe to reduce, and you can see the contour of the diaphragm, which was flattened earlier, it become convex. This is the observed volume reduction without surgery of upper lobes. One more thing is micro debrider, especially for central airway obstruction. You can do directly putting this the debrider in the bronchus and immediately cut and suck out all these debris from the bronchus. This is a newer technology. And futuristic robotic bronchoscopes already world over is existing without robotic surgery. The pulmonologists sit here and bronchoscope work on the patient, and very precisely you can take different type of biopsies and such lavage from the segments. These are the futuristic the capsule bronchoscopes. Endobronchial gene therapy is newer technology where direct installation of soluble vectors via bronchoscope, you can reduce different type of diseases like in cystic fibrosis, adenovirus, adeno-associated viruses, and lipid DNA complexes are putting directly in the airways, and they work well. Even in non-small cell lung cancer, delivery of WTP33, a tumor suppressor gene, which is responsible for detecting and repairing damage of DNA, also as a guardian of genome, you can reduce reduce the size of this cancer and progression of these type of cancers by endobronchial gene therapy. And the future developments by high-intensity focused ultrasound itself will be an efficient tool for destruction of pathogenic tissues, and we are using endoscopic MRI. More recent developments, neurons are directly connected to the computers or computer-driven machines. Thus, manipulator will be no longer controlled by hands, but eye tracker and brain wave sensors can do all these bronchoscopic maneuvers. I'm putting one scenario. Like a person at risk of lung cancer screened by molecular analysis for his exhaled for suspicious cells. By exhalation, you can detect malignancy. Alteration indicates by cluster of oncogenes and suppressor genes that he has developed early stage lung cancer. After overt tumor or peripheral lesions have been excluded by HRCT, a detached computer-driven endoscope is sent down the airway by navigation according to the virtual 3D bronchoscopy. By fluorescence imaging, a truly early lesion is detected, like I have shown in previous slide. By optical coherence tomography, which I have shown in the previous slides. By OCT and microscan, an early stage cancer confirmed by a pathologist after transmission of images to the department. Local strategies by 3D video imaging and a high resolution ultrasound proves that lesion is within the superficial layer or bronchial walls and no lymph nodes or metastasis in the lung. If curative local treatment seems feasible by excision, the data are fed to the robot that guides an intelligent molecular nano knife which cuts out the lesion exactly with some safety margins. A local cytotoxic or immunological sterilizing agent is instilled into the tumor bed before the wound is closed by an intelligent fibrin suture that automatically attaches itself to the rims and closes the gap of infection. So, in one sitting, you are diagnosing the malignancy, you are removing the malignancy. So this is the future where by bronchoscope you can achieve this type of surgical removal or treatment of malignancies and other diseases. Here, this is the video of bronchoscope, how we do. We are going through the nose, you can see here, and we are reaching to the vocal cords by spraying local anesthesia 1% or 2%, a few percent are using 10% xylocaine spray. This is the epiglottis. These are the vocal cords, you see, and by proper anesthetizing these vocal cords, we are entering into the trachea. The scope should remain into the center of the tracheal lumen, not touching the trachea. If you touch the trachea, then coughing will start. And after reaching below, you see this is the carina, this is the main carina, and left main bronchus on the left side, right main bronchus on the right side. Again, you have to put topical xylocaine to anesthetize this area. And when you enter into the right main bronchus, turning to right side, this is the right subcarina, middle lobe and right lower lobe. And here you can see this is RC1. And when you want to see the right upper lobe, you can again further move like here. When you move, you can see this is a Mercedes-Benz sign, right upper lobe, apical segment, anterior segment, and the posterior segments when you reach to the right upper lobe. And when you take out again into the bronchus intermedius and want to go beyond in the below, you can see these structure like these are the middle lobe and lower lobe. You can see very effectively like this is the RC2, the middle lobe on the 11 o'clock position, and here you can see the 4 or 5 segments of the right lower lobe. And then in the same manner, when you withdraw this scope to the cranial level and want to see the left side of bronchus, you have to see that basically on the right side, there is almost 3 lobes, right upper, right middle, and right lower. But on the left side, there is only left upper lobe and left lower lobe. In upper lobe, there is a division of lingular lobe that is, I will show you. We are seeing this is the right lower lobe here. This is the lower lobe segments, medial basal segments, anterior basal segments, lateral basal segment, posterior basal segments. But on left side, medial basal segments usually remain absent. So this is the way how we see on the right side different segments anatomy. It is very essential to look the manuals of bronchoscopy and videos of bronchoscopy to confirm that this which is segment we are dealing is the middle lobe, or it's the lower lobe, and which segment we are having. So this is not a very difficult task when you are doing and you performing the bronchoscopy with local anesthesia, or to start initially you can do in the conscious sedation. We are coming back, and now we will turn the scope to the on the right left main bronchus. You will see here the two lobes will appear, 2 openings, one for upper lobe and one for lower lobe. And when you reach in the upper lobe, again there is a division for lingula, and upper lobe there is a apicoposterior segment and the anterior segment onto the left side. So here this is a LC2, and when you further go, there is a upper lobe segments, anterior, apicoposterior, and this is the segment. So by this way, you can see different segments and anatomy of the lower lobe like this. Here, this is the lower lobe. You can see here, medial basal segment is absent here, and you can see superior segment to lower lobe segments. One more thing you want to show how we remove this bronchoscopically. We can remove this type of growth without surgery, or when patient is not fit for surgery, or patient is having metastasis and tumor is blocking the airway. Very efficiently we can remove by snare, we call it electrosurgical snare, which gastroenterologists are using. May I ask from the audience, how many have seen bronchoscopy in their hospital or endoscopy in their hospitals? 2, 3, yeah. So this is the technique like endoscopists are using. We are using like endoscopists are removing the polyps. We are using in the airway, and by removing this, we can take out by the cryoprobe or by foreign body forceps. We can remove these type of large growths very efficiently, even in conscious sedation. So these are the debulking technique which we are doing in our practice for removal of the central airway obstruction. In 2009, I have removed the 7 tooth intact in a denture. Adult patient has taken with bronchoscope, and it is, I think it is the largest foreign body world over which have removed from the airways the 7 tooth intact in the. This is in my YouTube. It is, if you want to see, like this. If you see this patient present with cough, with no fever, no any chest pain, no dyspnea, and long-lasting chronic cough. This is the X-ray, but here you can see there's a collapse of left lower lobe. If you do bronchoscopy here, we have done bronchoscopy. This is my patient, and I will surprise. You see, this is on the left main bronchus. You see the whitish structure looking like a growth. When I have taken the biopsy from this lesion, it was very foul smelling. So when I taken out this bronchoscope out and asked the patient, what you have taken, anything inside, any history of any eating anything, so he said, his doctor, one Ayurvedic doctor, suggested to take this garlic clove to take for cardiac diseases. So garlic clove impacted in the left main bronchus, and it was very foul smelling. We have taken out with the rigid bronchoscope. So this is the way how suspicious of chronic cough, always suspect foreign bodies, even in adults, if they are not giving history of any asphyxiation or inhalation of any foreign body. One more, like here, this patient is presenting with right side collapse of lung, and by direct, just at the level of carena, this is the technique how to take biopsies from the growth to confirm the disease. So I think we have done almost 25 minutes, and any question if you want to ask regarding before starting workshop, anybody want to do hands-on, so we can do hands-on training. Isko chalu kar do. Olympus people is there? Any? No. Okay. So this is not a difficult job, but definitely with few assistants, like anesthetists can help you in patient sedation or patient not coughing. We are taking 2-3 minutes. Any postgraduate student want to ask regarding bronchoscopy or any other question regarding the before we do the hands-on training?
Dr. Sab, can you just repeat when not to do it?
Well, when not to do it. Yeah. The first is if you have not taken informed consent. A very important thing we missed sometimes, taking consent from the patient. Most of the time in a hospital, what is the practice? We take consent from the attendants only. So brother, sister, father. But we usually miss to take consent from the patient. And last few years back, Supreme Court had very clearly said, take consent from the patient himself or herself. That is one thing. Another thing is patient is not cooperative. Like you are doing in local anesthesia, patient is agitated, patient is coughing violently to avoid in the stop patient. Third is if patient having low platelets. Like if patient is having, like in platelet counts are less than 40,000, 30,000, avoid. In up to 50,000 we can do bronchial lavage, but we can't do biopsies. Even after lavage, sometimes bleeding starts. Mucosa is so fragile in these type of patients. Okay? Laga diya? Scope lab. So these are the few you should avoid doing bronchoscopy, or patients having quite obese, patient short neck, or you are not able to put from the nose, to avoid putting bronchoscope through the mouth. Sometimes this is a very costly equipment, patient can buy it. So if you do simple putting xylocaine jelly here and with proper anesthesia like xylocaine, you can do. And initially for starters, do in the fit patient. Like fit patient means patient is healthy, having no comorbidities, patient not having history of bronchial asthma or any airway disease. If you want to check out any particular segments, you want to take lavage, they start from healthy patients, and later on when you have got, if you are doing at least 10 bronchoscopy per year.
Dr. Tomar, you use any drugs there?
For intravenous? For sedation? Yeah, yes.
Or local?
Oral, no oral drug. We usually give, if anesthetists are there, or midazolam, or I'm more comfortable in propofol. But anesthetist is must for propofol, or you can combine, if anesthetist is not there, even OT staff or trained staff from your hospital will give midazolam with fentanyl. 1 ml midazolam fentanyl on aliquots. You can give SOS basis when patient is having conscious sedation. Otherwise, most of my patients do in the local anesthesia. There's no need of putting the tracheal. Sometimes they put tracheal puncture for cricothyroid membrane. They install the local xylocaine, but that is not necessary.
Is there any role of local anesthesia there?
Oral?
Local anesthesia?
Oral, yeah, xylocaine. That is most essential. Without anesthesia, you can't do. You start with 10% xylocaine in mouth, 2-3 spray in the vocal cord by opening mouth, and while doing bronchoscopy, you have to put 1 ml, 2 ml local anesthetist through the channel, working channel that is there. You have to do the local anesthesia. You have to put. Yeah. Yeah. The complications are less than 0.1% in bronchoscopy, even with transbronchial lung biopsy. But definitely, the major complication is the only thing is hemoptysis sometimes, massive hemoptysis. When taking biopsies from the fragile tissue, or you are taking biopsy from the very friable vascular tissues like carcinoids, you are taking, then only the risk is that there. Otherwise, this is a quite safe procedure. So avoid in those situations, and most important, when you are doing bronchoscopy for hemoptysis, don't try to remove these large clots from the bronchus. And when we see large clots, then there are high chance of again bleeding. So avoid removing of these clots from the segments or subsegments of bronchus.
May I request PG students to come in the front, so they will have a hands-on experience of how it is done. It will be demonstrated live. So I will request all to come in the front, because now there is no lecture, it will be all hands-on.
ऑन है अभी लाइट नहीं है इसमें लाइट पावर देना पावर आ रही है इसमें आई ना इसमें नहीं आ रही और चेक करना इसमें नहीं आई है नहीं इसमें नहीं आई इसका वो पावर वही चीज नहीं इसमें नहीं आ रही है पावर अभी भी इसमें नहीं आ रही ठीक पावर नहीं आया देख लो यहाँ से पावर नहीं आ रहा है कहाँ गया लगता है अच्छा आ रहा है वो ठीक कर रहा है कभी तो आया था इसमें पावर ये दबा के देखना इसको लेकिन आने लगी So this is the video scope. This having this lever here. This is a small tube. The outer diameter is approximately 6.8 to 5.8 millimeter, and there is a small working channels you can see here. One is for the fiber optic light source we call it, and another is a working channel. This is the working channel. From here you have to put either bronchoscopy needle or biopsy forceps from here, or you can install the local anesthesia during procedure like 2% or 4% xylocaine from here. So this is the working channel we call. This is one more button here. This is the suction. When you press it, this button, the suction will on and it clears the secretions from the bronchus or the tracheobronchial tree. And this is the lever. When you introduce the bronchoscope from the nose, it should be remain in the straight position. When we reaches at the vocal cord, while visualizing, first thing what we visualize after crossing the nose is the epiglottis. We have to reach behind the vocal this epiglottis to visualize the vocal cords. And you can see the vocal cords in the V shape, 1, 2 at the anterior commissure, and the posterior base is the posterior commissure where the arytenoids, most of the time you see the arytenoids. So when you want to enter in this vocal cords, you have to go through the posterior commissure, not with the anterior commissure. When you reach, इसमें आ रहे हैं लाइट नहीं है, इसमें लाइट नहीं है. So this is the way to introduce the bronchoscope in the trachea. When you go inside, you have to put 1 ml or 2 ml local xylocaine to anesthetize the tracheal tree. And most sensitive part of tracheobronchial tree is the carina, main carina. So you have to again put few ml, 1 ml or 2 ml diluted xylocaine. 1 ml is sufficient, 1 ml, 1% solution is sufficient to anesthetize this main carina. Then you have to take, you can do the maneuver like turning right side on left side. And when you want to up and down, this is the lever. When you press it down, it will up, it goes upside. And when you deflex, it will do the 90 degree is the anti-flex, and approximately 170 degree, 160 degree, it will be the anti-flex position. So you can do the, take biopsies and visualize the whole tree. क्या हुआ? इसको change करके देखो। पकड़ना, ये चलिए गलत कर दिया। ये ठीक है? हाँ, power क्यों नहीं आ रही? So this is the way if volunteers want to take a touch or this feeling of this bronchoscope can volunteer. You want to one come? So you are medicine resident? Senior resident, okay. So this is the way how to hold. This the thumb should be here, when the index finger should be here, and the three finger will hold the scope. This is the way, and never angulate, more angulate this from the joints like here or here. This is a very sensitive part of the bronchoscope. So when you want to intubate, this is the way to hold, and start from nose by putting jelly over there and going inside the airways. So this is the way try to hold it. Yeah, left hand, and maneuver with the right hand. You want to put any like forceps, anything you want to put, you can put from the this side. इसका बैग देना, बैग में से ये देना, सार सा रखा है, नहीं लंबा सा, ये दूसरा, ये आगे, हाँ यस, so this is for suction. If you want to suck out, this is the way. When you press it, the suction will go in the. You want to take lavage, there is a suction trap is there. There's some anything you want to suction take out, it will be in the trap, down in the suction trap. So this is the way. And like this if you want to take brush smear from the bronchus, you have to put like this, then remove this, and this will go inside the. And the same way you want to take biopsy, it will go inside the lung like this here. It will come, and you have to take biopsy from the airways or lesion and take out and spread it over the slides to check the cytological examination. And the same way the biopsy will go inside this, and you have to take, assistant will open and lock, close this biopsy forceps to take the biopsy from the endobronchial tissues. So just I want to show, please come here. This is the mannequin. ये लाइट बंद कर सकते हैं, सामने वाली जो लाइट्स हैं, ये वाली लाइट, हाँ ठीक है. So like this, and it should be remain in the central of the trachea. When what we are seeing, the first thing is the main carina. This is the main carina, and when we go on the right side, first we see what the shape of the carina. Carina should be sharp. It should not be widened. If there is a widening occurs, that means there is a subcarinal lymph node is there. And by putting FNA needle, you can directly take FNAC from the subcarinal lymph nodes. And When you try it like this, and you want to go, this you can see here. This is the right intermediate bronchus is visible, and at around 1 o'clock position there is a upper lobe, right upper lobe, and you have to flex this to go up. When you go up, you see this is a 3 apical, anterior and posterior segments here. So if you want to further take out lavage from this area, you have to put saline 10 ml, saline 10 ml saline, and you have to suck it, and take in the suction trap and send for bacterial culture, cytological or gram stain fungus culture or any other thing. Now you have to come back again in the position here. This is the intermediate bronchus. When you go down further, you can see here 3 openings are visible. At one is around 9 o'clock, and one is on the 9 o'clock or 3 o'clock. One is on 9 o'clock and another is 3 o'clock position. This 9 o'clock position is a middle lobe bronchus. And when you want to go here, you can turn this scope and go inside. You can see the medial and lateral segments of the right middle lobe. Again come out, and this 3 o'clock position is the superior segment of the right lower lobe. And when you further go down, you see the further segments, medial, lateral, anteroposterior basal segments from the middle. Again, whenever you lost, come to the carena. Here, this is the carena. This is the main station. And now you want to go to the left side. Then turn the scope to the left side. And you see the major bronchus. The left bronchus is the longest bronchus. And when you see, there's a 2 openings, one at around 11 o'clock and another is in a 6 o'clock position. Upper lobe, this is the left upper lobe opening, and this is for the lower lobe. If you want to go the left upper lobe, again you will see the 2 division, upper and lower. The lower lobe division is basically for the lingula, superior segment and the inferior segments. And for arm, again flexing it to go the upper lobes. Here you can see the anterior apicoposterior basal segments. And for, again you have to come out to go to the lower lobe. Again this on the 7 o'clock position, this is the superior segment of the lower lobe, left lower lobe. And when you go further down, you see the, except medial basal segment, you can see the lower lobe segments. So try it, take it and try it. Yeah. In a neutral position, just check where is the up and down. Check. This is the up and down. If you do like this, then it will be different. So it should be like anteriorly, it should be up and down. Try up and down. So you know which part is angulating, in which area.
You mean to say the left hand has to be stable?
Yeah, left hand should be stable. So this is very good. You are going in the, first thing what you are seeing, main carena. You want to go on the right side to turn this scope towards the right side. Yeah, yes, turn, yes, move like this, little bit, and go into the, keep this scope in the lumen of the, go, further go, and flex it little bit, flex it, take this flex it, go down, and see, visualize, try to visualize the upper lobe. Yeah, no, not difficult. Just go and see, want to see like the, yes, this is the upper lobe. Keep behind little bit retract, yes. And this is the upper lobe opening. This is the upper lobe opening. You want to go here, try to negotiate this. Reach here. Yeah, go further, very good, excellent. Go further. Go further. This is the anterior apical. This is a very simple way. This is a very simple way to reach the right upper lobe. You can take lavage, snugly fit, and ask assistant to put saline here, and you have to suction it to trap the anything inside the trap, and come out. Withdraw it. Withdraw it, or withdraw. Take out a little bit more. Now, you want to go to see middle lobe and lower lobe. Go on this orifice. This is the intermediate bronchus. Go down. This is the middle lobe. And come this side. shape it, and turn more, and turn the scope towards the anti-clock, anti-clock. You want to go inside this bronchus. This is the middle lobe, perfect. So in the very first hand, you are able to negotiate these lobes very easily. It's not a very difficult task. Start doing this, take only lavages from ICU on ventilatory patients, where patients already intubated, go through the endotracheal tube, and very easily you can take out the secretions for sampling or for purpose. This is upper lobe. So this is the upper lobe, very good. Sorry, this is the middle lobe, right middle lobe, lateral and basal segments. Come out again and go in the lower lobe. This is the superior segment of lower lobe, and this is the, any abnormal tissue, if you want to, like growth is visible, you can take out even biopsy from here very easily. So this is the lower lobe. Perfect. Come out now and go on the left side. And come, always stand behind the head of the patient, so that is easy, go on the left side. Take anti-clockwise scope, anti-clockwise, go for anti-clockwise, ऐसे turn करिए थोड़ा सा. Yes, yes, this. Try to go in this orifice. Lightly flex it, and go inside this. This one. I think. Yes. Introduce more. Yes, good. Introduce more. Yes, and flex it. Keep in lumen in the central of the airway. Yeah, it is good. Completely anti-clock this scope. Yes, and keep putting forward. Go further. It is sticking up in the main carina. Just take out it like little bit and do this like this. Fine. Go on this side. Flex it. Yes. Go. This is the, you have to keep this scope here by flexing it and going forward. Yes. Go forward, further. Introduce it. Yeah, this is the, you are touching the wall, but this is the lower lobe. Come out again and forward, push it. Yes. This is the upper lobe. Keep flexing it. This is the upper lobe, this is the lower lobe. Try further. Push it more. Yeah, push it more. You are going in the lower lobe. This is the left lower lobe. And left upper lobe is here. If you want to go, see left, take out little bit more out, and keep this scope in the. Yeah, this from this side. Yeah, like this. Yeah. Take out. Yes. Yeah, you can do this. Take out and try to anti-clockwise. Yes. Perfect. And go further. This is the upper lobe. And go flex it and try to go up this. Yes. Go further. Up. Flex it and go further. Here. Very good. Perfect. So this is the way to reach the different segments. Left upper lobe, this is the lingula. Yeah, you are seeing lingula. If you want to see apicoposture, this is the apicoposture and segments here. Take further more. Poke it more. This is the segments you are seeing visible here. These are the anterior apicoposture segments. So this is the way to do bronchoscopy. So this is the way we have to do. We can learn very easily this type of bronchoscopy. So thank you so much, I think, Chairperson.
Thank you. That was so wonderful. So nicely directed. It was, I think, definitely they've achieved a lot of new experience out here.
It's very easy thing, and even different part of India. Yeah.
Thank you so much. Thank you, Dr. Tomar. Thank you. Any further questions from the audience? Any queries?
Little bit, always keep oxygen ready. If saturation is dropping down below 94, give oxygen by the mouth, by face mask, anything. That is it. So, and keep nebulizing sometimes after, if there is a hypoxia is occurring, you can give nebulization, even give hydrocortisone or anything to just, this is the way doing.
Right. Any other? Thank you, Dr. Tomar.
Thank you so much. Thank you so much.
And now we proceed to the next program, and now it will formally we will be opening the scientific program, and our scientific chair, Professor Narsingh Verma, will be giving his insights how we planned this unique program, what are the salient features of this program. So over to Professor Narsingh Verma, sir.
Thank you, Dr. Ajay Tiwari. Scientific program of this ACP was made keeping in view that back to basic. That was our motto. And why this all started and why we thought of this theme for this conference. First of all, in every conference, we want more and more young brains. And you saw that since morning, lot of presentations, very good presentations of cases, review articles, and own study, original study. They were presented. And then you saw thesis presentation. Best thesis we selected. Not only that, in the coming time, there were presentations, posters, free papers. So every sort of things were welcome. Clinical cases, all were included in that. Then back to basic. Why back to basic was chosen as a theme of the conference. At present, our thinking is that we are passing through a very crucial era. After COVID, the medicine has changed a lot. Before COVID, initially if you think of doing our MBBS days, MD days, we cannot think of without seeing the patient, without examining in detail how we can prescribe the drugs and how we can diagnose. But this was happening during the COVID days. Most of the physicians, most of them were not examining patients. They were just listening their history and just watching the different problem narrated by them, and also investigations, only investigation reports. And the problem here is that if we continue that, then what will happen? We will be replaced by the computer, because patient can come with a vial of blood and history will be narrated to the computer, and computer will provide the prescription and we will replace. We are not required. So that is the danger. Why back to basic? Because essence of medical, whole medicine is a careful history. and what to ask, what not to ask, and a very vigilant examination, which was the essence of medicine. And that what we were teaching to our students, that careful history, what to ask, what questions you can ask. Whole Hutchinson's clinical method of examination is still, that is how the patient should be examined, what examination should be included. So all this was the backbone of medicine. And after these two, a provisional diagnosis was made. And when we were making provisional diagnosis on the basis of the literature, available literature, and on the basis of the history and examination, the differential diagnosis was also made. And that gives the idea to the brain that what type of disease the patient can have. And that differential diagnosis can be further shortened by just advising one or two investigations which are very much required. After that, final diagnosis comes. So that was the basics of the medicine. But with the time, the things have been replaced. Now the patient is coming to you with a battery of tests, and 99% of those tests have no meaning. They are not required in that particular patient. So only on the biochemical basis, how one can diagnose patients, how one can make the diagnosis, and how one can correct the things which have gone wrong. So only on the investigational basis, the diagnosis is being made. So why back to basic? Again, the same thing. Just in this conference, various lectures and other topics have been included, those we are encountering daily basis. On a busy daily routine of a physician, what he's facing, what problems he's facing. For example, at present, most of the physicians are facing one problem, that is how to tackle fever. Fever has 101 causes. And what to do with fever? And only on the basis of investigation, you cannot treat it. So careful history. Without history, you cannot think of what can be the cause. So on that basis, the whole conference menu or scientific menu has been designed. Those problems, they're ranging from very basic problems to some complex problems, not just limiting to one particular area. All areas have been included. And in that inclusion, basically we have tried to cover most of the systems ranging from respiratory system to cardiology and to very basic immunology. All they have been covered, and you will find that in this 3-day conference, most of the important areas have been covered. And we have tried to choose the faculty on that basis, and we send these topics to them very early so that they can prepare and they can mix their own experiences. After that, we can learn that how the basic things can again be remembered, because without them, these are the ethos of the medicine. Without them, we will not be able to diagnose or treat most of the diseases. So that was the reason that this whole scientific program was made. And we have also included few workshops, few discussions, and we have created ample time so that discussion can be made, and we are inviting questions from each delegate, and they are being honored and they are being answered. We have included even nutrition, starting from nutrition to other aspects of the treatment. They all have been included in the program of this ACP. So in this particular program, you will find the most of the questions which you face in your day-to-day busy practice. You will find their answers if you attend whole of the conference. So with this, I think I will like to end here because still we have just started in the morning and we have most of the lectures, they are waiting in the coming time, and we have tried to create a space for discussion as well, and healthy discussion and healthy questionings can be definitely benefiting you all. Thank you very much.
Thank you very much, Professor Dr. Narsingh Verma, for telling us why the theme Back to Basics that was made for this conference, particular conference. In fact, most of the talks and the deliberations, they are telling us the basics of the medicines, which we are forgetting. Even in today's scenario, most of the medical students, who is passing their MBBS and PGs through this NEET examination, they are more confined to the multiple choice questions, and rather than they forget what is the CBC report, what is the meaning of auscultation, and what is the use of palpation of the abdominal cavity. So many things which we will learn in this conference. That way we are coming back to basics. Thank you, Professor Dr. Narsingh Verma, for his elaboration. Thank you very much.
Thank you, sir, for the warm welcome. And I invite all the delegates for this wonderful scientific extravaganza. Without any further delay, for the next session, I would request our chairpersons, Dr. R. Digurmati, Dr. Sanjay Arora sir, you need to stay back, and Dr. J.K. Sharma sir. Dr. Sharma sir is a senior consultant physician from Delhi, Sanjay Arora sir from our own Lucknow, and we are in the host of city, Dr. Digurmati. Since morning, we have been having excellent presentations. We had two halls where the continuous online physical presentations were there, and one hall we are running where the virtual presentations are still going on. Now we start our scientific session. I would request our chairpersons to invite the first speaker and start our scientific program of ACPIM India chapter. Thank you.
Thank you, Dr. Anuba. Good afternoon to all. There is a slight change in the program, and the first speaker in place of Dr. Ashu Rastogi is Professor P.K. Maheshwari. May I invite Dr. P.K. Maheshwari? Dr. P.K. Maheshwari is, at the present time, head of the Department of Neurology at Sun Medical College, Agra. And before that, he has been continuously for 8 years professor and head Department of Internal Medicine. He is MD, DM Neurology, and he is a fellow of the Royal College of Physicians of Edinburgh and also academic life member of Innovative Physicians Forum. He will speak on management of hypertension in stroke patient. There is a lot of dilemma to what level the blood pressure should be brought down in a stroke patient. So, sir, please enlighten us how to manage a patient of hypertension in stroke.
Thank you, chairpersons, for nice introduction, and also thank you organizing team as well as Dr. Anuj, who has given me this opportunity to speak about blood pressure and stroke. It's a very important topic from the point of life of the persons, morbidity of the persons, mortality of the persons. As we know, after our age, the death is MI, stroke, and the cancer, and you never know the trauma. So, stroke and the hypertension is one of the leading cause to with heterogeneous pathomechanism and is primarily considered to be ischemic or hemorrhagic. Hypertension is one of the important risk factors for stroke, may lead to endothelial dysfunction resulting in development of atherosclerosis. And small perforators, who usually supplies the basal ganglia, in which we find out the dense hemiplegia. Altogether, they are being supplied by the perforators. They are also affected by the hypertension, and in hypertension, these small arteries rupture may lead to intracerebral hemorrhage or may cause occlusion and resulting in lacunar infarcts. And these lacunar infarcts may be the silent one, but may give rise to deterioration in the cognitive functions. Higher BP may be beneficial to the penumbra, ischemic penumbra, which is viable tissue, but under perfused. On the other hand, higher BP may increase the risk of hemorrhagic transformation. See that central area of the infarction or the hemorrhage is there and surrounded by the ischemic penumbra. And altogether the BP management lies here to whether to reduce how much so that ischemic penumbra should be revived. And this is our treatment, main aim of the treatment. Many previous studies have investigated the optimal BP level and the effect of early rapid lowering of elevated BP. However, no ideal BP has been established. Management of blood pressure in ischemic stroke is complex as multiple factors to be considered to determine BP target, including baseline BP, prior to treatment, reperfusion status, whether successful or not, hemorrhagic transformation after reperfusion treatment. Now, because as we advances, then the thrombolysis gradually coming up in so many areas, and also the awareness about stroke also there, so because the window is a 4.5 hours. So if the patient shifts and he also agrees, then good option is for the thrombolysis. And here the different criteria for the thrombolysis, that AHA and ASA guideline recommend that if AIS patients have a BP more than 185 by 110 and eligible for treatment with intravenous etiplase, their BP should be lowered carefully before intravenous etiplase treatment is initiated. Current guidelines recommend maintaining blood pressure less than 180 by 105 during and after intravenous etiplase treatment for the first 24 hours after the treatment. Before and after intra-arterial endovascular treatment, that the mechanical thrombectomy. Current AHA-ASA guideline recommend that for patients who undergo endovascular treatment, BP during and or for 24 hours after treatment should be maintained at less than 180 by 105 millimeter mercury. In particular, if successful reperfusion is achieved, guidelines recommend that blood pressure should be less than 180 by 105. Before and after intra-arterial endovascular treatment, recent multi-center study demonstrated that higher BP within first 24 hours after successful endovascular treatment was associated with higher risk of intracerebral hemorrhage and mortality. Moreover, the patients were divided into 3 groups, but the results remains that systolic blood pressure goal of less than 140 millimeter mercury was associated with better clinical outcome. Then systolic blood pressure less than 160 or less than 180. 140 is a better choice after endovascular treatment. Now, acute phase of about ischemic stroke, with the AHA and the ASA guideline, early treatment is indicated in patients with severe acute comorbidities such as acute coronary event, acute heart failure, aortic dissection, post-fibrinolysis, spontaneous intracerebral hemorrhage, hypertensive emergency or pre-eclampsia, eclampsia, and excessive decrease in BP can increase the risk of infarction growth. That means that if we rapidly decrease the blood pressure, then infarcted area may increase. Therefore, BP management should be individualized. Although there is no standard, it is generally considered safe and reasonable to lower BP by 15% from baseline in 24 hours. Acute phase for patients who did not receive intravenous atiplase or endovascular treatment and those without comorbid conditions, the recommendation differ based on the BP level. If BP is more than 220 by 120, the benefit of initiating treatment of hypertension within the first 48 to 72 hours is uncertain. However, it is generally considered reasonable to lower blood pressure by 15% during the first 24 hours after the stroke onset. If blood pressure is less than 220 by 120, initiating treatment of hypertension within the first 48 to 72 hours after attack is safe but not effective in preventing death or dependency. So more than 220, it's more better to reduce by the 15%, and if less than 220, the recent guideline says that your choice is there and you may reduce 15% by the baseline in first 24 hours. The extracranial atherosclerosis, systolic blood pressure can be decreased up to 140 millimeter mercury, but risk of ischemic stroke is increased if systolic blood pressure is further lowered in both sides, if more than 70% stenosis is there. Intracranial atherosclerosis target BP is 120 by to 140 millimeter mercury. A small vessel disease like perforators, BP to be maintained less than 130 by 80. Now in the hemorrhagic strokes are categorized as either subacute, subarachnoid hemorrhage, intracerebral hemorrhage, with accounting for the 10 to 20% is of the intracerebral hemorrhage, and subarachnoid hemorrhage accounting for approximately 5%, so more amount of the intracerebral hemorrhage. Primary medical treatment for acute spontaneous intracerebral hemorrhage is BP management with goal of reducing hematoma expansion and perihematomal edema, improving functional outcome and reducing mortality as well as morbidity. In patients with subarachnoid hemorrhage, BP should be controlled to balance the risk of rebleeding while maintaining cerebral perfusion pressure. Elevated BP is very common in intracerebral hemorrhage, which may be due to premorbid hypertension or secondary increase due to raised ICP or stress. Elevated BP during active phase of intracerebral hemorrhage has been found to be associated with hematoma expansion, perihematomal edema, rebleeding, neurological deterioration and death. However, there are certain concerns about decreasing BP too far, which may cause cerebral ischemia around the hematoma. Now, in TRACK 2 and TEST 2 trial, they say that systolic blood pressure should be 150 or 180 in the intracerebral hemorrhage, but we don't follow because subsequently American Stroke Guideline as well as American Heart Association guideline recommendations are there, and there are drawbacks in the INTERACT 2 trial. It was a large phase 3 clinical trial to address the effect of acute blood pressure lowering on intracerebral hemorrhage functional outcome. Randomized patient with spontaneous intracerebral hemorrhage within 6 hours of onset and a baseline systolic blood pressure to two different systolic BP targets less than 140 and 180. So we don't follow that. We follow with result of these trials, American Heart Association and American Stroke Associations have provided guidelines which state that for patients with an systolic blood pressure between 150 and 220 millimeter mercury and without contraindication, the acute lowering of systolic blood pressure to 140 millimeter mercury is considered safe and may improve functional outcome in patient with intracerebral hemorrhage. Reducing systolic blood pressure less than 140 millimeter may increase the risk of adverse renal events. So they want to say that 150 to 220 millimeter mercury, if the blood pressure is there, in a case of intracerebral hemorrhage, acutely you are seeing, reduce it out immediately to the 140 millimeter mercury if there is no comorbidities. Reducing further to 140 millimeter mercury may create the problem, and particularly in the renal area. Systolic blood pressure more than 220 millimeter mercury, aggressive reduction of systolic blood pressure may be reasonable with continuous intravenous infusion with frequent BP monitoring. A recent retrospective study has shown that when comparing target systolic blood pressure less than 160 millimeter mercury group and systolic blood pressure 140 millimeter mercury group, acute cerebral ischemia and neurological distoriation were more common in systolic blood pressure less than 140 millimeter mercury. In conclusion, in large randomized trial did not provide a consistent evidence that a specific target BP is beneficial. Therefore, individualization of BP target, risk and benefit in each patient may be needed. So here I would like to say that 140 millimeter mercury is a cutoff limit. So reduce it out. If there no comorbidities, nothing, then it's safe. Less than 140, if you reduce, it may create the problem. Target in subarachnoid hemorrhage. Rebleeding in patients with subarachnoid hemorrhage lead to an extremely poor prognosis. Although proper BP control is necessary to prevent rebleeding, the magnitude of BP control necessary to reduce the risk of rebleeding has not been established. For most patients with acute subarachnoid hemorrhage, the AHA, ASA recommends maintaining a systolic blood pressure less than 160 millimeter mercury to balance the risk of ischemia and rebleeding. The Neurocritical Care Society states that extreme hypertension in subarachnoid hemorrhage should be avoided and suggests maintaining a mean arterial pressure less than 110 millimeter mercury. When increased ICP is suspected, given the risk of impaired cerebral perfusion, increasing mean arterial pressure may be the only way to maintain cerebral perfusion pressure. Because here the maintenance of the cerebral perfusion pressure is very much required to improve the ischemia and to avoid the infarction. Therefore, antihypertensive therapy is often withheld unless there is an extreme elevation in BP. A European guideline recommends MAP above 90 millimeter mercury to maintain proper cerebral perfusion pressure. In case of symptomatic cerebral vasospasm and delayed cerebral ischemia after subarachnoid hemorrhage, induced hypertension is recommended. Now, few drugs which can be used because non-vasodilating agents like labetalol, nicardipine and esmolol are preferred for the IV use. So in conclusion, the management of BP in stroke is complex and challenging due to the variety of stroke subtypes, heterogeneous etiologies, hemodynamic status and comorbidities. BP management in AIS remains problematic, and questions such as when to start antihypertensive medication and how significantly to reduce BP have yet to be answered. The comorbidities, baseline BP and stroke mechanism should be considered, and the time and target of lowering BP must be individualized. When reperfusion is achieved through thrombolysis or thrombectomy, lowering BP reduces the risk of hemorrhagic complications. BP lowering in acute intracerebral hemorrhage is probably safe. However, if BP is lowered rapidly in the acute phase, adverse renal events may occur. In patients with intracerebral hemorrhage, systolic blood pressure between 150 to 220 without contraindication, acute lowering of systolic blood pressure to 140 millimeter mercury is safe. Reducing below 140 the first hours after onset may increase the risk of renal adverse events. For patients with systolic blood pressure more than 220, aggressively reduce. Control of BP variability may be useful. For prevention of recurrent stroke, BP management for target BP less than 130 by 80 millimeter mercury is recommended when the patient is medically and neurologically safe. For intravenous thrombolysis before IV TPA less than 185 by 110, during and for 24 hours after TPA less than 185 by 105 millimeter mercury. Regarding for the thrombectomy, during and for 24 hours after endovascular treatment, less than 185 by 105 millimeter mercury. If failed reperfusion, then maintain blood pressure at more than 150. If successful reperfusion, maintain blood pressure less than 140. If hemorrhagic transformation is there, maintain blood pressure at 140 millimeter mercury. In acute phase, in the ischemic stroke, more than 220 by 120, generally lower BP by 15% in first 24 hours. Lowering BP has uncertain benefit within 48 to 72 hours. If BP is less than 220 by 120, 110, initiating hypertensive is safe but not effective to prevent death or dependency. But if hypertension is present with severe acute comorbidities, I'll lower BP by 15% from baseline in first 24 hours. Patient's systolic blood pressure more than 140 by 90 and neurologically stable. Start antihypertensive during hospitalization. Thanks for your attention.
Professor Maheshwari, I had one small doubt. We are taught that hypertension can be reactive to CVA. It is not necessary that the patient need to have been hypertensive to start with. Does it make any difference in the treatment, or it's just the same?
In this context, I would like to say that individual patient has got individual things, and it's more better because in majority of the cases, initially in 1 hour, there is a reactionary rise. And in that case, if you infuse something, then there is a quite good amount of the problem, and we used to see. Because here, in the podium, I have to talk about a guideline. But in practical, wait for 30 minutes or 1 hour to see whether the reactionary blood pressure rise is there. And in majority of the cases, I have seen that reactionary blood pressure rise is too much, and by giving them, and then subsequently lower down to the 80, and then DOPA is going to be infused. This is the practical thing which we used to see commonly in our IC.
Thank you. Any questions from the audience? Any questions from my co-chairs? Thank you, sir. Thank you for that lucid elucidation.
Thank you.
So now we have another important topic, and to present the topic, may I invite Professor P.S. Karmakar, who is a professor of medicine in Kolkata Medical College, and he will speak on, is biofortification beneficial for human? Sir.
Please provide the slides. Respected chairpersons and the learned gathering, good afternoon, everybody. I'm really thankful to the organizers, Dr. Anuj Maheshwari, Dr. Bharma, Dr. Anuba, and Dr. Murthy for giving me this chance of having a talk on a very important, that is back to basic, whether this one. I'm sorry. It's not coming. Whether that is biofortification beneficial for human? Now we are really back to basic. So really, if biofortification is beneficial for health, then it may take us a long way to make ourselves, all the people globally, healthier than what we are today. Let's see what happens. So I will cover the topic by briefly touching upon a very important thing, that is hidden hunger, then nutrition deficiency in modern era, global as well as Indian, nutritional value of foods, how it could be increased, biofortification and food fortification. Is there any difference between these two words, biofortification with micronutrients, and conclusion? So, 1 out of 3 people suffer from a very tragic condition, what is called hidden hunger. And what is hidden hunger? Hidden hunger is a very important thing, that is when a person may appear healthy, they take calorie to a sufficient amount, but their diet is low in nutrients and vitamins, that they are vulnerable to serious illness and diseases. So that is called hidden hunger. Calorie intake is adequate, but the nutrients, micronutrients are inadequate. And the problem in the society, women and children are preferably at risk. So why these are hidden? Because people who suffer from it do not suffer any disease. They don't show any visible warning signs, and women and children, I have already said, poor families are main victims. And for this reason, what we do have so far, our practical life is concerned, the increased amount of blindness, then the stunted growth, and reduced cognitive development in all the people that remains in the subclinical stage, and increased maternal mortality also. So if we think about the global scenario, the lack of these four micronutrients, iron, zinc, iodine, and vitamin A deficiency, they are the most prevalent deficient micronutrient. And you'll be astonished to know that over 2 billion people globally, that is more than 200 crores, do suffer from iron and zinc deficiency. And more than 7 million children do die before 5 years due to direct or indirect effect of these micronutrient deficiencies. And World Bank had a study, and they published a paper that iron, zinc, and vitamin E malnutrition in South Asia cause economic losses equal to almost 5% of GNP each year. So these are the visible clinical scenario that patients are suffering from micronutrient deficiencies from vitamin A, iodine, etc. But this is the tip of the iceberg. And hidden hunger, that is micronutrient deficiencies, are huge amount that is underneath the water. And here the countries globally has been shown in different color codes. And out of these color codes, the maroon colored, and which covers the whole of the India, where the micronutrient deficiencies are very dense and very high. The whole India, as well as surrounding countries like Bangladesh, Afghanistan, and Pakistan. So now the scenario, after global scenario, now the scenario in India. In daily diet, you will be astonished to know that less than 50% of adequate nutrients are being in 75% of Indians. And 57% preschoolers and their mother do suffer from vitamin A deficiency. Similarly, in iron deficiency also, the preschooler children and pregnant and lactating mother, the incidence is 50 to 60%, almost 70%. And the same is the scenario with zinc deficiency. So what is the option to recover this, hidden hunger or micronutrient deficiencies? We have 4 options. One is fortification of food, second is use of medicine, and third is diversification of the diet. But all these 3 first options are very expensive. And these are the options which cannot reach the Aam Janata, that is majority of people of India or globally. So that's why the 4th option that is left with is biofortification. So biofortification versus fortification, biofortification means that there should be selective breeding from different seeds, and study starts with seeing the nutrients of different seeds, and selective breeding is to be made with or without some genetic modifications that will give rise to biofortification. And it differs from fortification, that in fortification the processed food is being added with either calcium, magnesium, sodium, or iodine, something like that. And supplementation, you all know, by taking medicines. So biofortification means, bios, a Greek word, means life. And Latin word fortifere fortify care means making strong. That means make life strong by just overcoming the micronutrient deficiencies. Now, biofortification and fortification, these are the two very term being used, and they mix us with each other. Biofortification means always to improve nutritional quality of the crop itself through conventional breeding of the plant. Examples: high zinc variety of wheat, high iron containing rice varieties, beta carotene rich sweet potato variety, and lysine and tryptophan rich quality protein maize varieties, QPM. But fortifications means just addition of that molecule, that is iodized salt or iron in flour or fluoride in toothpaste. So this biofortification, the first thing came from a great economist in 1990s, and he said a noble idea that how can we make staple foods more nutritious by breeding micronutrients into the crops planted by smallholder farming families. And for this novel idea, he was awarded World Food Prize in 2016 to this laureate, Dr. Howard Howdy Bruce. And the big name was given to his novel thought, that is biofortification. His idea was really needing this sort of big word, that is biofortification. And the first time, the Harvest Flask, after getting this novel idea from Howard, Mr. Howard, and Harvest Flask was launched in 2014. And it is the pioneer most organizations so far research of biofortification is concerned. And it was funded by Bill Gates and his better half, Melinda Gates. And they started doing researches on iron, zinc, and beta carotene, how they could be increased in the cereals and grains, that is biofortification. And they took up 7 staple crops of different countries, and these are rice, wheat, maize, sweet potatoes, bean, pearl, and millet, and cassava. And in the millet, I have written the year 2023, because 2023 is being considered as International Year of Millet, as suggested by India, then followed by US. So International Year of Millets, they are really very nutritious. After biofortification, they are very nutritious cereals or crops, and they should be used in increased amount in our daily diet. India is not also lagging behind. In the same year of Harvest Plus, India also set up the Department of Biotechnology, DBT, in the same year 2004. And varieties of rice, because our staple food is rice, wheat, or maize, our researchers tried to biofortify these 3 crops with iron, zinc, and provitamin A. And in March 2007, Harvest Plus signed a memorandum of understanding with DBT of India. So biofortification and its advantages. Biofortification capitalizes on food staples. So staple foods all the time being taken in biofortification, because staple foods predominate in the diets of the poor, so easily cover and targets low-income households. It is a one-time investment. Through research, if you can create the nutritionally enhanced cereals or crops, then once the crop has been fortified, the seeds will fortify themselves. Biofortification is an improvement over ordinary fortification when it comes to providing nutrients for the rural poor, because rural poor people are not at all willing to take the fortified foods or diversification of food, that they are not capable of buying all these things, and these are not also available in the rural areas. And Copenhagen Consensus in 2008 and Lancet series of maternal and child malnutrition in 2013, they also advocated biofortification very strongly. And challenges, what are the challenges for biofortification in India? Lack of consumer acceptance due to color changes. Because due to this I mean, selective breeding as well as some genetic modifications, color changes are there in the crops. And adoption of farmers and cost involved in the process of fortification. I have said that there is one-time investment, and that is to be taken care of. The researchers, fund and everything is to be taken care by government so that they can get the biofortified crops even in lesser amount than the conventional crops. So that should be taken care by our government. And it is a slower process than genetic modification. So now proof of concept studies. Here I have shown some golden rice. So golden rice 1 and golden rice 2 compared to the conventional rice. This golden rice definitely contains extra amount of vitamin B compared to the conventional rice. And if one consumes 72 grams per day, it is enough to avoid vitamin A deficiency. And studies show no risk to human health, and presented in, you will be astonished to know that presented in 2000, still not grown commercially in any country including India. And I have tested this golden rice. It is little bit rough in appearance so in our oral cavity, otherwise the taste is being maintained. Now another important proof, that is orange sweet potato. What is that? OFSP. OFSP means orange flesh sweet potato, and that has been taken, adopted, and consumption is quite satisfactory in the country of Mozambique of Africa. And it has shown that dissemination of orange sweet potato, that is OFSP, led to a vitamin deficiency reduction from, huge reduction from 50% to 12%. So biofortified crops definitely works in a miracle way. And proof of concept, another study is iron and zinc rich rice. There is iron deficiency in anemia globally. It is the most important cause for anemia in all, especially in the schoolgoers, pregnant ladies and lactating mothers. And IRRI, that is International Rice Research Institute, head office is in Philippines, rice variety up to through this biofortification, 6 to 4-fold increment in the iron and zinc is possible. And if we take this iron, if this rice in our daily staple as a staple food, 30% of average requirement for women and children will be met. So it's no joke. And introduced genes are non-toxic and non-allergen, and no loss in agronomic and quality traits. So till date, through biofortification, biofortified foods have improved the lives of over 30 million people and have been grown in over 60 countries, but many miles to go. And the Harvest Plus, I have already talked about the organizations of Bill Gates and Melinda Gates. They have chosen, I have told you, 7 crops of different countries, including India, Pakistan, India, Bangladesh, to fortify them with iron, biofortify with iron, zinc, and vitamin A. So our aim is to, by 2030, 1 billion people is now hoped by 2030 to be benefited through biofortifications. And that is to be reached by anyhow, through our effort as well as government's effort. So take-home message is, it's time to have adequate food with right nutrient content. Micronutrients are essential for growth and overall development, starting from our physical, mental, as well as immune system of our body, and to prevent various diseases. Micronutrients deficiency causes 5% GNP loss. It's not our data, it's a World Bank data. Copenhagen Consensus in 2008 and Lancet series of maternal and child malnutrition 2013 advocated biofortification very strongly. Biofortification can be an effective solution to hidden hunger, which is prevalent all over the globe, and a cheaper way for mass fortifications of daily food. But staple food is to be targeted, is to be addressed. Iron, zinc, iodine, and vitamin A, these are the 4 most prevalent deficient micronutrients. Iron and zinc deficiency, there is total more than 12 billion people globally. And Harvest Plus Global and DBT of India, important research body globally, those who are going through researches on this biofortification of crops. Golden rice and orange flesh, sweet potato, imported biofortified crops. So make it a pledge to eat right. And it all starts with a seed. Thank you very much for your patient hearing.
Karmakar, for a wonderful talk. And we all have seen during the post-COVID era also that there is a lot of zinc deficiency, presenting patients with varied symptoms. And when the zinc is fortified,
Yes.
I just want to ask, earlier we have seen that in these hydrogenated oils, on the box it was written that vitamin A and D fortified. Because vitamin A, D, E and K, they are all the fat soluble vitamins. So what about vitamin D fortification? Is that also important as on today?
Sir, as of today, hydrogenated oils we have almost discarded because it's a saturated fat. That is usually in decades back it was being marketed as dalda. So we have discarded that thing. That's a good thing. And whether it is fortified with vitamin A, D and E, all are fat soluble vitamins, absolutely right, sir. But you don't have any monitoring whether they are really giving in adequate amount or not. That is one. And you all know, even better than me, that majority of people globally as well as in India, 60% of us do have subclinical vitamin D deficiency. So we are using right and left so far vitamin D prescription is concerned.
I have one question.
Yes, sir.
Roughly 17 states in India report fluorosis. In my own state, Anantapur district is a stark example of dental and skeletal fluorosis,
Yeah.
where crippling can occur. But there is no ban in sale of fluorinated toothpaste in any of those states, any of those districts. So how do you regulate this? So nobody tells the people that you should not use a fluorinated toothpaste, you will get dental fluorosis. The government is least bothered, the regulatory authority is least bothered. So I don't think that fortification itself is deficient, but educating the people, as you rightly said, for example, the uptake of sweet potato, which is fortified in Mozambique, but that is a staple diet for them.
Yeah.
Like sweet potato and cassava is a staple starch for them, like rice is for us. So that might be quite useful.
Yes, sir. But fluorosis regarding, sir, fluoride in the paste, that is in very minor amount, and that is not at all preventing caries or something like that, what they actually demand. And fluorosis is usually occurring due to increased intake of it through our water, through water intake. When water is being contaminated by
So in those areas where there is already dental and skeletal fluorosis, what's the point in selling a fluorinated toothpaste? Doesn't make sense at all.
Definitely, sir. Absolutely right you are.
And even in few districts of Rajasthan also this is happening, fluorosis. So thank you very much.
Thank
is
you,
there
sir.
any, yes sir.
Hypothyroidism in society. Sudden increase in the
Sir, you are talking about fortification. I have talked about biofortification. So biofortification is really different from fortification. Iodized salt is really fortification, what you have said. That is, iodine is being added. First, usually in the hilly areas, the iodine is very much deficient in the diet. So iodization of salt as available in the Tata salt or something like that, it is really helpful. But as I said, that we don't monitor whether that is containing the adequate amount of iodine or not. So that could be one of the causes, but hypothyroid could be as a result of Hashimoto's thyroiditis, not really related to iodine deficiency.
But in real sense, we do need iodization in plain area where iodine is sufficient in diet.
So for that, we definitely need epidemiological data. What
Sir.
is the scenario right this moment so far iodine deficiency in our diet is concerned?
It is actually, there is a survey done about the sea coast and sea coast foods along our coast. We know that the seafood, sea salt and marine products actually contain only 2 parts per million of iodine. It is not sufficient. We require a minimum of 30 parts per million of iodine. So it is a myth to think that sea salt is rich in iodine as well as marine food is rich in iodine. It is not true at all. So it is a myth that we think that sea salt is rich in iodine. You can eat sea salt but still be iodine deficient.
Right, sir. Thank you so much.
Thank you, sir.
For the third topic, we have Dr. Divya Saxena. She'll be talking about how to deal with anemia of chronic infection. Dr. Divya is MBBS 1988, MD 1992, FACP. She's Director Saxena Multispecialty Hospital, Sonipat, and Orange Clinic, Lady. She's got multiple awards and special achievements also. It is a proud privilege to serve Indian Medical Association both at national and state level for last many years. Dr. Divya.
A very good afternoon to all of you, and thank you, esteemed chairpersons, for the kind introduction. I must thank at the outset to the organizing committee, Dr. Anuj Maheshwari, Dr. Narsingh Verma, Dr. Murthy, and Dr. Anubha for giving me this opportunity. And today I am going to talk about a very important subject, that is anemia of chronic infections, which is very less talked about and need more discussion in such conferences. So my topic would be under following subtopics that will be discussed. I'll tell you about certain points about chronic anemia of chronic infections, about prevalence, etiology and pathophysiology, its clinical features, evaluation, how to manage the infection of anemia of chronic infections. So what we should know about the anemia of chronic disease. It is a mild to moderately severe anemia with a hemoglobin ranging between 7 to 12 gram per deciliter. It is usually associated with chronic infections and inflammatory disorders and some of the malignancies also. And the newer terminology which is being given to this kind of anemia is anemia of inflammation. It is most common among hospitalized patients, and it develops in patients with cellular immune activation, and the degree of anemia is usually correlated to immune activation in that particular patient. If we talk about the prevalence of this anemia of infection or inflammation, it is the second or third most common form of anemia after iron deficiency anemia and thalassemia. It is really difficult to tell the exact prevalence rate of this condition because this is usually confused with iron deficiency anemia and usually a diagnosis of exclusion in any of the patient. And the incidence increases with the increasing age, with the affecting almost 77% of the elderly, where there is no clear-cut cause of anemia, and usually it is because of multifocal etiology. And if we talk about the anemia in infectious disease, it is common in developing and underdeveloping countries. And if it is because of malignancies and inflammatory diseases, the prevalence is more common in developed countries. There is another entity with the name of acute variant of anemia of chronic diseases. After surgery, after major trauma, after myocardial infarction or sepsis, and this is known as anemia of critical illness. It is almost having similar features of anemia of chronic diseases like low serum iron, high ferritin, blunted response to erythropoietin, and it is most probably because of tissue damage, extensive tissue damage, and acute inflammatory changes. And it is supposed to be a variant of anemia of chronic diseases, which is characterized by shortened red blood cell survival in this particular type of anemia. And there are various inflammatory diseases which may be associated with this anemia, like infections, like most of the viral infections, including HIV, bacterial infection, parasitic, maybe fungal or Hellman's. Malignancies may be hematological malignancies or maybe solid tumors. Various autoimmune diseases like rheumatoid arthritis, systemic lupus erythematosus, and connective tissue diseases, vasculitis, sarcoidosis, inflammatory bowel disease, systemic inflammatory response syndrome. In chronic kidney disease and inflammation also, this anemia can occur. And the prevalence among infectious diseases are almost 18 to 95%. And if it is with cancer, in cancer patients, almost 30 to 77%. In autoimmune disease, almost 8 to 71%. And in solid organ transplant patient, it occurs in 8 to 70% patient. In CKD and inflammation, almost 25 to 30% of patients. If we talk about the pathophysiology, the cornerstone of this type of anemia is the mainstay is hepcidin, which is induced by the inflammatory reactions, and it leads to alteration in iron metabolism, causing reduced absorption of iron from GI tract, increasing the trapping of iron in macrophages, thus making it unable to for the use. Or iron stores are plenty, but the serum iron levels are reduced, causing hypophonemia, the low iron binding capacity, low transferrin level, and there is always an inability to increase erythropoiesis in response to anemia in these patients. There may be death of red cell precursors also within bone marrow, and there is always a relative decrease in EPO production. Normally, in normal circumstances, there is an inverse relationship between hematocrit levels and serum EPO, which is disturbed, which is not maintained in anemia of chronic diseases. And the minor component may be due to decreased red cell survival also, and this reduced red cell lifespan may occur in cases of acute inflammation, which is characterized by increased macrophage activity. The anemia is usually normocytic normochromic, but it can be, so in some cases, in severe cases, it can be microcytic and hyperchromic as well. This slide is showing how inflammatory stimulus can activate monocytes and T cell, further leading to overexpression of hepcidin in liver, which inhibits iron absorption from gut, increases macrophage activity and trapping of iron. There is always inhibition of erythropoid proliferation and availability of erythropoid in response to anemia. So let us see what are the effects of cytokines on iron metabolism and erythropoiesis, where TNF-alpha inhibition of erythropoietin production causes stimulation of ferritin synthesis in red blood cell, enhances degradation and phagocytosis of effete red cells. It directly inhibits erythropoiesis, where IFN-IY inhibits production of erythropoietin, increases intracellular iron by stimulation of DMT1 and inhibition of ferroportin, increase nitric oxide production and inducible nitric oxide synthetase, mRNA expression, etc. IL-6 increases iron uptake via DMT1 activation. It reduces TFR by decreasing TFR RNA expression and downregulates expression of SL4A1 in erythroid precursors. IL-4 and 10 also increases ferritin by action on iron regulatory elements and proteins. So hepcidin, which is a master regulator of iron hemostasis, is a peptide with antimicrobial potential, and its expression is induced by iron in the liver and also by LPS and IL-6. And its overexpression finally leads to iron deficiency anemia and hepcidin knockout to iron overload also. It inhibits duodenal iron absorption, and the basic mechanism is by the degradation of ferroportin, which is the transporter of iron from the cell to the outside, which is a membrane protein. So this diagram is clearly showing how hepcidin is going to increase the macrophage activity and degradation of ferroportin. So iron is somewhere related to immunity and infection also. It affects cell-mediated immune function, and thus host responses are also affected towards pathogens. We all know that microbes needs iron for proliferation and pathogenicity, where cytokines and acute phase proteins, they regulate iron metabolism genes under inflammatory conditions and then finally lead to development of anemia of chronic disease or iron limitations for pathogens. So we can say that ACD may result from the endeavor of the body to limit the availability of iron for invading pathogens and to strengthen antimicrobial immune effector pathways inside the body. So these are the laboratory features through which we can identify the anemia of inflammation or of chronic disease. This is basically normostric, normochromic, but with increasing severity and duration, it can become hypochromic and eventually microcytic also. There is absolute reticulocyte count is normal or maybe slightly elevated. There is hypoferemia, decreased serum transferrin also, IL-6, hepcidin and hypoferemia. There is normal to increased serum ferritin and marrow iron stains are there. So how can we differentiate between anemia of chronic disease and iron deficiency anemia? If we see the laboratory values of iron, this is reduced in all three forms, whether it is ACD, IDA or both the conditions are coexisting. Serum transferrin levels are reduced in anemia of chronic disease while it is increased in anemia of iron deficiency anemia, and reduced if both the things are coexisting. Transferrin saturation is reduced in both ACD and IDA, and even both the things are coexisting. Ferritin is normal to increased in ACD while it is reduced in iron deficiency anemia and reduced if both the things are coexisting. Soluble TFR is normal in ACD while it is increased in IDA, and it may be normal or increased if both the conditions are coexisting. Ratio of TFR to long ferritin is low, less than 1 in ACD. It's high, more than 2 in IDA, and high if both the things are coexisting. And cytokinin levels are increased in ACD while it is normal in IDA, and may be increased if both the conditions are coexisting. So how to differentiate between ACD and ACD plus IDA anemia? First of all, we know that there is clinical evidence of inflammation and transferritin saturation. If it is low, below less 16%, then we have to rule out other causes of anemia also. For that, we have to get ferritin levels done. If it is less than 30 milligram per liter, this may be because of iron deficiency anemia. If it is between 30 to 100 milligram per liter, serum transferase determination should be done. If it is more than 2, then both the conditions are coexisting. If it is less than 1, then it may be because of ACD. And if ferritin levels are more than 100, it is to be diagnosed as ACD. So hypoferemia, we are discussing since beginning. It is there, and it is the most significant sign of anemia of chronic diseases, and it is a defining feature. But where decrease in transferrin concentration, it develops more slowly because of its longer half-life of 8 to 12 days in comparison to the shorter half-life of iron, which is only 90 minutes. Marrow iron stains are rarely required, and it is just to obtain the content of and distribution of iron in the body. So how to manage? It is the most important part of the topic, how to manage this kind of anemia in such scenarios. The most basic thing is to treat the underlying disease, and if it is present in the setting of infections, inflammations and malignancy, certain other things are always to be looked for, like for any occult hemorrhage, iron, B12 or folate deficiency, hemolysis or any drug reactions. And the treatment modalities are, as usual, the blood transfusions, iron supplementations, or erythropoietic agents. And treatment of underlying disease is really very important in such scenarios. Transfusions may be required in both the anemia of chronic diseases and iron deficiency anemia. Iron supplementation is really not needed in anemia of chronic deficiency because we know that iron stores are plenty. Only serum iron is reduced, but if both the anemias are coexisting, we all have to always check for the laboratory parameters. It may be required in certain scenarios. Erythropoietic agents are required in anemia of chronic diseases, and in iron deficiency anemia, if it is coexisting, it may be required if there is no response to iron therapy alone. So the initial approach for this, the management of anemia of chronic disease, is the correction of underlying disorder, and the degree of response to the treatment, it depends upon the underlying disorder, and several other factors where the inflammatory component is controlled, and if there are any other contributing factors coexisting or not. And other complicating factors like blood loss, deficiencies of iron, folate, and vitamin B12 should always be treated for. And this may obviate the need of blood transfusion and erythropoiesis stimulating agent as well. But blood transfusion or red blood cell transfusions or use of an erythropoiesis stimulating agent may be necessary for those patients with severe symptomatic anemia. So we have to, or we should rather, measure the plasma erythropoietin concentration, which may be helpful in these patients who have symptomatic anemia or who have not responded to the treatment of their underlying disorder, or who continue to have symptomatic anemia and requiring further treatment. So the patients who are with autoimmune disorders like rheumatoid arthritis or malignant conditions or AIDS, who have EPO levels of less than 500, they may respond to administration of an erythropoietic stimulating agent, and it can be given once per week, while another agent, that is darbepoetin, has an effectiveness equal to that of EPO when it is given once every 2 or 3 weeks. Supplemental iron should be given in every patient who is receiving EPO or darbepoetin in order to maintain transferrin saturation of more than or equal to 20% and a serum ferritin level of more than or equal to 100 nanogram per ml. Because our aim is to maintain a short-range response to anemia while the investigations are going on and the underlying disease is to be still found out, it is always preferred to use EPO rather than darbepoetin. So, what should be the dosage of these drugs to treat these kind of anemia? There are two treatment options available. The standard dosing of EPO is to start with 100 to 150 units per kg subcutaneously 3 times weekly along with supplemental iron. And the patient should respond. The hemoglobin should rise by 0.5 gram per deciliter by 2 to 4 weeks. If there is no elevation in the hemoglobin concentration by 6 to 8 weeks, the regime can be intensified further to daily therapy of 300 units per kg 3 times weekly. Or alternatively, we can give 30,000 to 40,000 units of EPO subcutaneous once per week, and that is almost equivalent to 140 to 190 units per kg 3 times per week for a 70 kg person. This dose can be increased to 60,000 units if patient does not respond, or if hemoglobin does not rise by the end of 4 weeks up to 1 gram per deciliter. But it is not worthwhile to continue EPO in patients who do not respond at the end of 12 weeks. So to avoid the adverse effect of EPO, it is recommended that the EPO treatment should always be initiated when the patient's hemoglobin is less than 10 gram per deciliter, and to stop the treatment when the hemoglobin level reaches to 12 gram per deciliter. The darbepoetin should be given in the range of 60 to 100 mcg per week or 300 mcg every 3 weeks. And because, as I already said, we are looking for a rapid short-term response of the anemia, the darbepoetin with its prolonged half-life may result in excessive and prolonged stimulation. So EPO is preferred for this purpose. Supplemental iron can be given to maintain the transferrin saturation and to maintain the ferritin level. Intravenous iron is more effective than oral iron, and if patients do not respond to oral iron, it is always preferred to give intravenous iron if the patient do not respond to EPO treatment alone. The blood-red packed cell transfusion is appropriate when the patient with ACD develops symptomatic anemia, or if there is insufficient time for the patient to respond either to the treatment of the underlying condition or to respond to the treatment with an erythropoiesis stimulating agent. So to conclude, I can say that to understand anemia of chronic disease and consequent diagnosis of it has continuously faced many of us physicians, and the actions of several pro and anti-inflammatory cytokines as well as hormones produces the suppression of erythropoiesis in these patients. The majority control iron release from the intestinal mucosa and marrow macrophage via ferroprotein, and the future treatment options should be targeted at the gene coding these cytokines, as well as using anti-inflammatory food supplements like fatty acids and vitamin D we were talking about. The use of iron supplementation in conjunction with ESA may also be beneficial in certain scenarios. So thank you so much for the patient hearing.
Thank you, Dr. Divya. That was a very comprehensive coverage. Any question from chairpersons? From the House? Yeah, Dr. Kalra.
Yes, sir. So as I already mentioned, sir, ki IV iron is always better than the oral iron, and elemental iron we are using these days, but depends upon, definitely we have to individualize the therapy according to the patient need. Thank you, sir. Thank you so much, sir.
Dr. Divya.
Thank you, Dr. Saxena, for your excellent deliberation. My question is, sometimes we do come across in our clinical practice that sometimes patient is having anemia and we are expecting some chronic disease. That time ferrokinetics come to us. Many of them are showing low normal serum iron, DIBC within normal limit towards the lower part, and transferrin saturation within 10 to 15%. Should we put patients on iron therapy to this?
Sir, for these scenarios, we can give the blood transfusion. I said if we cannot, if the time is shorter, we cannot, there is delay in diagnosing the patient, what is the underlying cause, we can very well give blood transfusions in these scenarios.
Thank you, Dr. Divya. We can have further discussion with lunch. Thank you. To the organizer.
Thank you, sir. Thank you for that wonderful chairing session. And let's move on to the next session, which is involving approach to PCS and, of course, polypharmacy. To chair this session, I am really honored and proud to call upon two eminent chairpersons from our neighboring country, from Bangladesh, Dr. Khwaja Najmuddin, professor, senior professor from Bangladesh. Sir, I would invite you to please come onto the dais. And the second chairperson, again from our neighboring country, Bangladesh, Dr. Mahbubul Islam Majumdar, who is a head Department of Medicine and Medical Education from Bangladesh again, to chair this session. And they've been very stringently following timelines, so I'll appreciate them to follow the timelines again about the session, and I would request the speakers also to stick on to their times. And over to you, sir.
Thank you for nice introduction. For this session, may I call Dr. Abhishek Pandey. Dr. Abhishek Pandey to deliver his lecture.
A very good afternoon. So thank you, organizers. Special thanks to Professor Anuj Maheshwari, Professor Srinivas Murthy, Professor N.S. Verma, and Professor Anubha Srivastava for their kind invitation. So things which look simple in life are complex if you go in depth. So today I am going to talk about a topic, a disease which you daily encounter in your clinical practice, But if you go in depth, then you will understand there are various things which you have to understand in the differential diagnosis. So today I am going to talk about an approach to PCOS mimicker. So as we all know, PCOS stands for polycystic ovarian syndrome. And this is a most common endocrinopathy in a female of reproductive age group. And it leads to multiple problems leading to infertility and various pregnancy complications. I think this house must be well aware about these complications in terms of gestational diabetes, pregnancy-induced high blood pressure, miscarriages, type 2 diabetes, various psychiatric disorders, or abnormal uterine bleeding. So when we talk about the PCOS, we should understand that what are the symptoms. So we can divide the symptoms in like the hyperandrogenism or presence of hyperandrogenemia, the oligo or anovulation, and there are polycystic ovarian morphology on ultrasound. So I think in your clinical practice, you must have seen many females coming with ultrasound report just labeled as polycystic ovarian, suggestive of polycystic ovarian syndrome, and you think that this is PCOS, a very simple case of PCOS. But now I will sensitize this how these simple things will turn into a complex thing. So just brief information about the different terminology which we used. So hyperandrogenism and hyperandrogenemia. So hyperandrogenism is a manifestation due to high androgen level. So it can be a acne, hirsutism, or frontal alopecia. And the hyperandrogenemia, it refers to increased blood levels of androgen. So we have to understand these two terminology that will help in making our diagnosis. And when we say oligomenorrhea, it is defined as an interval between episodes of uterine bleeding longer than 35 days. So if a female coming with abnormal, like irregular periods, so you have to ask how frequent she has periods, what is the frequency. And coming to the polycystic ovarian morphology on the ultrasound. So if you see, almost 75% of the female with polycystic ovarian syndrome have this peculiar ovarian morphology. But the important point to emphasize here that it can be seen, this polycystic ovarian morphology, in 25% of the normal females and women with other endocrinopathy. So you should not just think that if in the ultrasound the report is polycystic ovarian morphology, then straightforward level this patient has PCOS. It can be a normal phenomenon also. So what this polycystic ovarian morphology stands for? So if the follicles are more than or equal to 20 in each ovary, measuring 2 to 9 millimeter in diameter, and the ovarian volume is more than or equal to 10 ml in either or both the ovaries, and the endometrial lining thickness is more than 5 to 7 millimeter in thickness, which indicates endometrial thickening. So there is no formal formal classification of PCOS. I am going to talk about a commonly used classification for PCOS. It can be mild, the ovulatory PCOS, the hyperandrogenism and chronic anovulation PCOS, and severe PCOS. So when we say mild PCOS, it accounts for the 16% of the affected female. It characterized by irregular periods and polycystic ovaries on ultrasound. There can be a mild elevated androgen concentration, and there will be normal insulin concentration. While ovulatory PCOS, it accounts for 16% of the affected females. It is characterized by normal periods. So it is not always that in PCOS you have irregular periods. It can be a normal periods, and then also the person can be diagnosed as PCOS. So almost ovulatory PCOS accounts for 16%. And the polycystic ovaries on ultrasound, there will be elevated androgen concentration and increased insulin concentration. The other group is hyperandrogenism and chronic ovulation. So it accounts for 7% of the affected females. It is characterized by irregular periods, normal ovaries on ultrasound, enlarged androgen concentration, and increased insulin concentration. So I want to emphasize in this slide that the ovaries on ultrasound will be normal in morphology in this subset of the PCOS. and the severe PCOS, which accounts for 61% of the affected females, characterized by irregular periods, polycystic ovaries on ultrasound, elevated androgen concentration, and increased insulin concentration. So there are no pathognomic features that suggest PCOS. So it is a diagnosis of exclusion, and that I want to emphasize here, because straightforward seeing the ultrasound or seeing just irregular period don't label a female as PCOS. It can turn to be a different thing, or it can be a normal manifestation sometimes also. So criteria for PCOS. So it has, through the time we see there are different criteria. So in 1990, National Institute of Health criteria for PCOS, in which the three things should be present, that is hyperandrogenism and or hyperandrogenemia, oligo or anovulation, and exclusion of other disorder. So it has been emphasized, exclusion of other disorders is also a criteria in 1990 NIH criteria. In 2003, there is a Rotterdam criteria. I think many of the endocrinologists and physicians are following this criteria, that in which 2 of the 3 must be present and other disorders must be excluded. But sometimes many do the mistake that they just see 2 of the 3, but they are not excluding the other causes. That can be a fault. So hyperandrogenism or hyperandrogenemia, oligo or anovulation, and polycystic ovaries on ultrasound. Now come the latest one is 2006 Androgen Access Society criteria. So in which all of the following must be present: the hyperandrogenism in the form of hirsutism or hyperandrogenemia in which the serum testosterone level is higher side, ovarian dysfunction in form of oligoanovulation or polycystic ovarian morphology on ultrasound, and exclusion of other disorder. So no, the talk is about the PCOS mimicker. So let's start with the first one. This is a non-classical CH. So NCCH stands for non-classical CH, and this is due to partial deficiency of 21 hydroxylase deficiency. So 21 hydroxylase deficiency will lead to the same presentation, the partial one. Complete will have a different picture. Complete CH will be present as ambiguous genitalia in just a newborn. But partial deficiency of 21 hydroxylase deficiency will lead to non-classical adult onset, leading to irregular periods, and it is very difficult to clinically distinguish between the non-classical CH and PCOS. So non-classical CH should be one of the differential diagnoses when you consider a PCOS case. So how do we diagnose? A morning follicular 17-hydroxyprogesterone level, if it is less than 200 nanogram per deciliter, it rules out the disorders. A value more than 800 rules that it can be there. So then we ask for the intermediate value, we ask for the ACTH stimulation testing. So a woman with a non-classical CH with stimulation, ACTH stimulation testing, the 60-minute, if 17-hydroxyprogesterone value is more than 1000 nanogram per deciliter. So just to make you more clear about why 17-hydroxyprogesterone level is elevated, because if you remember your biochemistry classes, 21-hydroxylase enzyme is responsible for the conversion of 17-hydroxyprogesterone to 11-deoxycortisol. So when this 21-hydroxylase enzyme is deficient, then 17-hydroxyprogesterone level is elevated. Now coming to the thyroid dysfunction, both hypothyroidism and hyperthyroidism can lead to menstrual irregularities. But in the patient having thyroid dysfunction, hyperandrogenism is absent. So generally you will not get the features of hyperandrogenism. And I think the hypothyroidism symptoms or hyperthyroidism symptoms are present. And you can diagnose this disorder just by simple TSH. The other mimicker of PCOS can be hyperprolactinemia. So hyperprolactinemia means the prolactin level is very high. There can be mild hyperandrogenic features may be observed in case of hyperprolactinemia. Galactorrhea is usually present. So whenever a PCOS, you are suspecting a female coming with menstrual irregularity and you are suspecting PCOS, ask for the galactorrhea, whether galactorrhea is present or not. So there can be headache or visual field defect due to the mass effect. And prolactin level is greater than the upper limit of the normal range. Now coming to other PCOS mimicker like Cushing syndrome. So when the circulating cortisol and androgen levels are elevated, it can lead to Cushing syndrome. There will be obesity, hirsutism, acne, menstrual irregularity, moon phases, central fat deposition, hypertension, and proximal muscle weakness, abdominal stria, osteopenia. So I think typical clinical features of Cushing syndrome can be present. You can screen for the Cushing syndrome by 24-hour cortisol, urinary free cortisol. The normal range is less than 90 microgram per 24 hour. Or you can ask for low dose dexamethasone suppression test, where you will give dexamethasone at 11 p.m. to midnight, 1 milligram, and then at 8 a.m. you will measure the plasma cortisol value. If the value is less than 5 microgram per deciliter, then it is normal, it is suppressed. But if it is higher side, this means the test is positive. It can be androgen secreting neoplasm. So in this type of subset of patient, there will be rapid progression of hirsutism in a short span of time. So within months, patient will come that, doctor, I developed facial hairs and other things in a short span of time. So it can be steroid producing tumors of the adrenal or the ovary. So other features, when androgens will be accessed, there will be frontal balding, severe hirsutism, increased muscle bulk, deep and voice, clitoromegaly can be there. And just you order for the baseline total testosterone, the value will be more than 200 nanogram per deciliter. You can ask for DHES also. If the value is more than 7,000 nanogram per ml, it should prompt the CT scanning for look for the adrenal masses. Now coming to one syndrome known as Hiran syndrome. There will be hyperandrogenemia, insulin resistance, and acanthosis nigricans syndrome, also known as Hiran syndrome. So there will be degrees of insulin resistance, hyperinsulinemia, and hyperandrogenism. So how it is diagnosed? So fasting insulin you will order. The value fasting insulin will be more than 80 micro unit per ml. And the peak insulin value will be more than 300 micron unit per ml during a 3 hour 75 oral GTT. Various drugs can also mimic as a PCOS. So if somebody is misusing, female is using testosterone, anabolic steroids, androstenedione, so it can also lead to a menstrual irregularity and PCOS-like picture. Some cases of hypergonadotropic hypogonadism can also mimic as PCOS. I am emphasizing on the important slide, so this one is important, premature ovarian failure. So it will present with anovulations, but hyperandrogenism is absent. There will be high serum follicle stimulating hormone and low serum estradiol. So what we have to order? So any case in which you are suspecting PCOS, so throughout my presentation, I emphasize that it is diagnosis of exclusion. So you have to exclude the mimickers. So the first investigations you will order for a PCOS case, the serum 17-hydroxyprogesterone level. So if the value is higher side, it is pointing towards non-classical CH. The serum prolactin value, so serum prolactin value because we are suspecting hyperprolactinemia as a PCOS mimicker. So if the value is higher side, then we have to do MRI pituitary protocol. Is there any mass is there or not? We have to ask for the drug history which can lead to increased prolactin value. Simple test like thyroid function test. This should be a part of a protocol. Any patient coming with menstrual irregularity and you are suspecting PCOS, you should order TSH also. So both hypo and hyperthyroidism can lead to menstrual irregularities. Oral glucose tolerance test. This test is also required if we are suspecting insulin resistance, because insulin resistance is one of the pathophysiology involved in polycystic ovarian syndrome. The fasting lipid profile, as I already emphasized, the various complications of PCOS, so dyslipidemia can be there and it can be observed. If there is dyslipidemia, we have to manage that part also. The initial part with the investigations I emphasized was the first investigation. Other investigation, it depends upon case to case, depending upon the clinical picture of the patient. So serum total and free testosterone you can ask for. So the hyperandrogenism is present in 60 to 80% of the women with PCOS, and 70% will have elevated free testosterone value, 40% will have elevated total testosterone value, and 25% have elevated dihydroepidone sulfate. So DHES, if it is very high, it can be due to adrenal tumors also. If other serum androgens levels are normal, we can ask for serum androstenedione. The pelvic ultrasound, I already emphasized the PCOS morphology in ultrasound. So in a case where you are suspecting that ovulation is not occurring properly, so you can ask for the luteal phase progesterone measurement. So it is generally performed at the date 20 to 24 of the menstrual cycle. And
Hello.
if the value is...
Please conclude. Your time is going.
Okay. So it's 5 minutes are left, I think.
Still 5 minutes?
It is showing, sir, 5 minutes.
2:35.
No, in the side the time is showing 5 minutes.
We have 10 then.
Okay. So if the value is more than 2 to 8 nanogram per ml, it indicates ovulation has occurred. And then the LH and FSH. So LH and FSH ratio we can see, if it is value is more than 3, it is suggestive of PCOS, but it is not diagnostic of PCOS. So don't go just with a idea that LH by FSH ratio should be more, because in obese patient, LH will not be elevated, and this ratio more than 3 will not be present. In lean PCOS patients, you will get LH FSH ratio more than 3. So in nutshell, PCOS is a diagnosis of exclusion, and PCOS mimicers should be ruled out by clinical criteria and the investigation. Thank you for your patience listening. Thank you.
Thank you, Dr. Abhishek. Your topic was very nice.
Thank you,
see,
sir.
You told about PCOS. I think there is a term PCOD, polycystic ovarian diseases, that is much more in incidence than PCOS. If PCOS is 2%, that is 10%. That is also happening in this age of women. The thing is that PCOS should be diagnosed with exclusion, only with exclusion, but you must suspect it. Nowadays we are getting so many cases. Mimickers, very easy, but only thing is you cannot explain with the thyroid disorders. You can get the diseases with androgen defect hormones. You can disease the manifest. Anyway, thank you very much for your nice presentation.
Thank you, sir.
Our next speaker is Professor H.A.M. Nazmul Hassan. He is Professor of Medicine. He was the past president of ACP Bangladesh chapter. He is a member, American College of Physicians. He was past president of Bangladesh Society of Medicine. He will be with his topic, polypharmacy and de-prescription. Polypharmacy and de-prescription, not mal-prescription. Yes, Mr. Nazmul Hassan, please proceed your topics.
Thank you, Mr. Chairman. Ladies and gentlemen, good afternoon. At first, I want to express my thanks to the organizers, particularly Govardhan and others, organizers of this scientific program. It is really an honor for me to get a presentation at this annual conference. My topic is polypharmacy and de-prescription, issues and concerns. During the 6th conference in Kolkata, I presented a similar paper on de-prescription. During the last few years, I have realized during my private practice that this is actually a very important issue nowadays, because as an internist, we get many cases with so many complications, like an example, a patient with diabetes mellitus having neuropathy, ischemic heart disease, hypertension, and nephropathy. So he consults so many doctors and having a big list of drugs. It is really a very problematic for a patient to take so many drugs. So I have decided to present the same paper with adding polypharmacy, which is also related with this. So actually, my presentation, the segments will be evolution of medicine as a science, about prescription and polypharmacy, particularly, especially in case of elderly persons, and what is deeper prescription, why it is important, and how it is to be done. If we look back to the history of medicine, actually we do not know regarding when from this our medical science started. If we look, there in different regions, different physicians, we will get some informations. In Indian region also, some physicians like Charok and Sutrat, they had many contributions in medical science. We know about Hippocrates. Hippocrates, he is considered to be father of medicine because he has contribution in different fields of medicine. He defined the role of physician, not only writing prescription. He said a physician must have at least two objectives in view regarding the disease. Namely, he has to do some good to the patient or not do any harm to the patient. So we cannot do any harm to the patient. So this is purposefully, I have kept this slide in Bengali. Charok, almost in the similar period, in 400 to 300 before Christ, he described what should be the qualities of a good doctor. What are the responsibilities of a doctor? One of the important responsibility of a doctor is not to prescribe drugs to a healthy person. So this is a very important responsibility of a physician. So these are the important, some of examples of some important physicians. If we look at history, there are some medical institutions of medical science of ancient to present time. Behind the medical science, other than physicians, technology is providing a very important role. You look at this moment, physical attendance is gradually becoming less and less. But at this time, almost thousands of audience are listening to our presentation all over the world, and particularly India, Bangladesh, and many other regions. So technology has a very important role in medical science. What is modern medicine? So when to treat a disease, how to relieve symptoms, how to manage a condition. Not all medications are to be taken lifelong period. So during prescribing medicine, the rational approach is to establish a diagnosis, to decide the therapeutic goal, and choosing the appropriate drugs. This is very important of rationality. So if you know what is prescription, many words of medical science, these are derived from ancient Greek and other Egyptian and other Latin words. So the prescription means writing in writing. So an order that must be written down before a compound drug is to be dispensed or prepared. So this is prescription. We know what should be the components of an ideal prescription. This should be kept in an ideal prescription with the specification of patient's date and drugs, how this should be dispensed, what are the routes to be given. So what are the factors to be considered before writing a prescription? So there are different factors balancing benefits and harms. So seriousness of symptoms is to be considered. What is the efficacy of the drug? What are the potential adverse effects of the drugs? What are the likelihood of the adverse effects? Efficacy and safety of alternative on non-drug, this should be also considered. Regarding present current time, we know there is an environmental change. This is a hot topic. We know there is a transition in world population demography is also. Since 1990, life expectancy has increased by 43% for all ages. In 1900, the life expectancy was almost around 50 years. In 1988, it has become 75 years. So persons over the 65 years are the fastest growing population in USA, not only USA, in many countries of the world. In 1900, it was around 4,000 population. In 1980, it has become 11%. It is expected that in 2030, it will be the 20% of the population. So this is a population pyramid of Bangladesh in 2021. Still, young person is more, but gradually the old people more than 65 years is increasing. It is similar in India also, almost similar. But you look in Japan, the pyramid is almost gradually becoming reverse. The elderly people in Japan is gradually becoming more than the young adults. So the population, these older citizens in different regions are gradually increasing. So this changing population or demography, in Bangladesh, life expectancy has risen from 49 years to now, currently it is 72 years. Approximately 8.4% of the population is aged over the 60 years at present. By 2050, median age may rise to 34.8 years, with 16% of population over the 16 years of age. So look, our Prime Minister, she is traveling in her village with her grandchildren at the age of 71 years. Joe Biden, he is now 79 years old. Mahathir bin Mohamad, he is riding a cycle at the age of 94 years. Perhaps Prime Minister of India, he is also possibly 71 years old. So our many Prime Ministers, presidents, they are more than 70 years old. So prescribing in elderly, we are to keep some points in mind that they have reduced drug elimination, increased sensitivity to many drugs, more drug interactions, lower starting doses is required, and there is drug adherence is also less. They have some other pharmacokinetics due to have many reasons, including having multiple comorbidities and polypharmacy and other contributing factors. So during prescribing medication in elderly people, they are good numbers. They are almost 1/5 of adult populations are treated with polypharmacy. Polypharmacy, when more than 5 drugs are prescribed in a prescription, it is called to be polypharmacy. It has been found that in UK, almost 70% of the prescriptions contain 5 to 9 drugs, and 9.7% contain more than 10 drugs. So in case of elderly, it increases the risk of adverse reactions, drug interactions, number of hospitalization, cost is increased, even death. So it has been found that there is increased risk for fall by 50% due to polypharmacy. Avoiding simply benzodiazepines in elderly person, it can reduce the fracture of hip by 10%. So it is a very important risk factor for multiple fractures, like very hip fracture like that. So what is polypharmacy? Use of 5 or more prescribed or over-the-counter drug therapies, this is called polypharmacy. But when it is more than 10, it is called excessive polypharmacy. But not always this polypharmacy, this is not that it is important, but sometimes it is needed. I have mentioned that in diabetic patients, they have multiple comorbidities. They have hypertension, dyslipidemia, ischemic heart disease, neuropathy, nephropathy. Sometimes it is required. So sometimes this is called appropriate polypharmacy when multiple drug therapies to manage their complex medical conditions. This is an example. Sometimes some prescriptions contain so many drugs, sometimes needed. Dr. Avron, he's a famous geriatrician of Boston. He said that any symptoms, any new symptom in an elderly patient should be considered a drug side effect until proven otherwise. So polypharmacy, common polypharmacy culprits we have observed in our country that anti-ulcer drugs, particularly proton pump inhibitors, this is very commonly written as a medication of gas. Sometimes different types of benzodiazepines, antidepressant drugs, sometimes laxatives, vitamins, calciums, food supplements. When I was posted in one of the remote district hospitals of Bangladesh, I had one small study on drug defaulters in tuberculosis. When second time anti-tuberculosis drugs has to be started, I had a small study why they stopped medications, anti-tuberculosis medications first time. I found that there are different reasons due to ignorance, sometimes due to adverse effects of drugs, due to cost of drugs. Sometimes we have observed that different types of medications are given with anti-tuberculosis drugs, which are sometimes even unnecessary, like multivitamins, anti-tuberculosis drugs, cough expectorants, oral irons. So these are the drugs which are sometimes unnecessary when we prescribe with a serious disease. So PPI, this is a very commonly prescribed drug in our country also. I think this is also practiced in many prescriptions in India also. One of my junior colleague, she did a study on overprescription of proton pump inhibitors on discharge certificates of medical inpatients. Those during discharge certificate, we observed that almost 87% contained PPI and 28.5% had appropriate indication of giving PPI. So in other cases, there were no absolute indications. So proton pump inhibitors, these are very important drugs. These are used for peptic ulcer, anti-peptic ulcer drugs. This is very important. This has a revolution in the management of peptic ulcer. In other conditions also we use it, like reflux esophagitis, Barrett's esophagus, esophagitis. But this should be continued for certain period. There are limited conditions where we can continue PPI, like upper GIT hemorrhage or Barrett's esophagus. So it has been found in many studies that simply if we continue PPI for long time, they can produce achlorhydria and can produce a lot of adverse effect also, like vitamin B12 deficiency, osteoporosis, and many other conditions. So what we can do? Can we allow to keep going or do something? So what is deprescription? This is process of withdrawal of inappropriate medication supervised by a healthcare professional. This is called deprescription. It is systematically defined by Michelle Woodward from Melbourne of Australia, that this is a systemic process of identifying and discontinuation of drugs. This is called deprescription. Objective is to plan and supervise process to reduce medication burden, which is considered inappropriate, and maintaining or improving quality of life of patients. So main objective is to optimize the therapy, avoiding adverse effects, improving outcomes, and enhancing and maintaining quality of life. So the prescription has lot of benefits: avoid inappropriate medication, reduce adverse effects, reduce polypharmacy, and reduce the cost on burden on the patient. So before deprescription, not only stopping the drug, it is not possible sometimes. We have to follow some steps. So full initial evaluation of the patient is to be done, identifying the potential inappropriate medication, prioritizing the drug for discontinuation, and performing deep prescription. So this is a deep prescription cycle. There are 7 steps. At first there is assess the patient, identify, define the goal, identify the medicine, agree, prioritize thing, and finally we can de-prescribe. So there are a lot of barriers also on the part of the doctors and on the part of the patients. So there is sometimes origin doubts from the physician, multiple professionals are involved in managing a patient, and there are barriers on the part of the patients also. They are psychologically and physically dependent on some drugs, feel abandoned if the medication is stopped. So these are the barriers. So there are different prescribing modules have been developed in different countries, like proton pump, PPI module, benzodiazepine module, antipsychotic or anti-diabetic, antidepressant modules. So these are also some drugs. These are also gabapentin and also clonazepam, alprazolam. These are the drugs also is used in many patients without stopping. So before developing a module, each guideline should answer the following question about the medication: when to stop the drug, when to reduce it, and when to discontinue the drug. So these are the prescribing steps. One 30 seconds more. Sorry for the interruption. So I think polypharmacy and deep prescription, this is a very important issue and concern for our present time. We are to avoid prescribing unnecessary drugs. Thank you. Thank you very much. Thank you very much.
Many thanks to the speaker, Professor H.M. Nazmul Hasan, who has described the polypharmacy and the prescription very nicely. It is one of the ethical issues throughout the whole world about the polypharmacy and the prescription. Polypharmacy is not yet strictly defined. Many analysis was there, but the description was given about the 5 or more drugs is polypharmacy, and sometimes in extreme polypharmacy is 10 drugs or more. But life expectancy throughout the whole world is increasing. So it is increasing from 70 to 80 nowadays. So a lot of comorbidities are there with the patients, and patients has to take more drugs. So in that case, there are 3 types of polypharmacy, we can say. One is rational polypharmacy, appropriate polypharmacy is there, but we should not go for the indiscriminate polypharmacy, which should not be from our learned doctors. So it was a nice discussion about the polypharmacy, and this prescription is very important. It is one of the important ethical issues throughout the whole world. I think it was a nice discussion in short about this chapter. I also like to thank Abhishek Pandey. Previously, he has told about the PCOS mimickers nicely. And above all, I like to thank SP India chapter for arranging such a nice seminar. Thank you very much for attending this seminar.
Before we conclude, may I ask the audience for any question for both of the speakers? Dr. Abhishek was with very nice topic. Polycystic ovarian syndrome, hyperandrogenism, cyst of the ovary. And he was also telling of the mimickers of the polycystic ovarian syndrome. Anybody, please. It's a nice topic. Abhishek, please.
Yes, sir. There are the lifestyle which is leading to diabetes, metabolic syndrome. It leads to PCOS. So healthy lifestyle means if you are reducing your weight, so the chances of PCOS will also reduce. So insulin resistance is one of the pathophysiology involved in the in the PCOS. So any condition which is leading to insulin resistance, so obesity, and when we are seeing acanthosis nigricans, so that is also a marker of insulin resistance.
So androgen excess and insulin resistance, both are the features of polycystic. Both things are helped by exercise and reducing the weight. If you can achieve your normal weight, you can hope that you will be relieved too much. At least you will not get the metabolic diseases, which are part of polycystic ovarian syndrome.
And there are various genotypes which are more prone for polycystic ovarian syndrome also. Thank you.
Thank you. Anyone, please?
So one question I had with respect to polypharmacy. So I come from a state where peptic ulcer is very predominant, that is Kerala, because they have extreme spicy food. So when such people are already prone to developing peptic ulcer and they are already having lot of comorbidities, don't you think it's better to prescribe a PPI as a prophylactic measure? And maybe we may not categorize it as a part of polypharmacy in such situations. So what's your opinion on
Yes, Professor Nazmul.
Thank you for your nice question. But hardly there are some evidence that the spice is related with development of peptic ulcer. Mainly peptic ulcer is related to H. pylori infection in 70% cases, and only 20-25% cases it is drug related, and some miscellaneous other factors like alcohol or smoking, but it has been not that much proved that spicy food produces peptic ulcer. And if we give anti-peptic ulcer drugs, H. pylori eradication therapy for 2 months, it can cure peptic ulcer in more than 97%, 95 or 97%. So hardly it is required to continue anti-peptic ulcer therapy for months or years or lifelong periods. So there are many evidences that if you continue this anti-peptic ulcer drug, it produces, this is so strong, it produces achlorohydria of stomach and produces so many complications. And this is used as an anti-gas therapy. So this is not actually required. This is not required.
Thank you, Dr. Nandan. For questioner, please remember there is no prophylactic therapy for peptic ulcers. There is no problem. So far I know there is no prophylactic therapy. You see, I had the chance to work in Saudi Arabia for 10 years. I did not see any Egyptian, Syrian, Palestinian or other country people take this anti-ulcer drug other than Indians and Bangladeshis. Indians and mostly South Indians. It is probably there for their dietary habits. They had they say gas, they say gastric. In our place they say gastric. Gastric does not mean gastritis or gastric ulcer. Maybe it is flatulence and other things. So from this session, I would like to request you to take the slogan, no PPI, unless it is proved, it is required. And regarding deprescription or polypharmacy, we can take one thing as granted that there is over-the-counter medicine is available in our places. It is not available in other countries. Probably they do not bother for this polyprescription and the deprescription. So we should, as per the physicians should think of this, we can say that there should not be any over-the-counter medicine. Thank you.
Hello. In fact, we fear when prescribing NSAID corticosteroids to a person whom we don't know his alcoholic history, his past history. That's why we prescribe along with NSAID, along with steroids, and along with so many gastric irritant drugs. Of course, you say PPI is not a drug for prophylaxis of peptic ulcer, but these NSAID and steroid, if somebody takes with tea or empty stomach, we fear he can develop gastric hemorrhage. Am I right? Am I right?
You could not follow. Please repeat.
If you prescribe NSAID and you don't know he is alcoholic, if he takes NSAID, empty stomach, we fear he can develop gastric hemorrhage.
Thank you. Yes, NSID, you can give PPI with NSID. That is accepted. But no NSID with PPI, no. Only PPI is not accepted. That we are telling, that he was telling. And prolonged use of PPI can cause osteoporosis, renal diseases, and anemia, both iron deficiency and B12 deficiency. This is fact. Thank you very much. Thank the audience for lively discussion. Thank the speakers for their nice lectures. Hoping you to see you again. Thank you very much.
Thank you, chairpersons. And I would like to request our chairperson and the last speakers to get their facilitation from the MediSure stall at the next hall. And for the next session, I would like to invite our next chairpersons, Dr. Suren Nath, and Dr. Vinita Tiwari. Dr. Suren Nath, Professor Medicine, IMS and some hospital, SR visiting consultant, MRI Hospital, founder member of Odisha State API, ex-chairman RSSDI Odisha, and Dr. Vinita Tiwari, Professor and Head, Department of Anatomy, Araz, Lucknow Medical College and Hospital, Lucknow. Thank you, ma'am.
The next topic is exogenous hyper and hypothyroidism by Swati Srivastav. Dr. Swati Srivastav is the professor and unit head at SMS Medical College, Jaipur. Is the head and consultant thyroid clinic, SMS Medical College, Jaipur. Conferred fellowship from Royal College of Physicians, Edinburgh. Indian College of Physicians and Diabetes, India. He has 38 publications in national and international journals. Dr. Swati.
Thank you very much, respected chairpersons, seniors, colleagues, dear friends. At the outset, I would like to thank Dr. Anuj Maheshwari for giving me this opportunity. And I'm privileged to be a part of the team ACP and to be privileged to be present here on giving a talk in front of this august audience. So I'll be speaking on exogenous hyper and hypothyroidism. So basically, when we say exogenous hypo and hyperthyroidism, in that one part is iatrogenic hypothyroidism as well. If we talk about a permanent damage, usually it's a surgical issue or a drug which has led to a permanent damage, then that becomes a permanent sequel. Sometimes there might be a reversible damage to the thyroid, which usually leads to a transient problem. Surgical hypothyroidism, if there is a total removal of the thyroid gland, it has to be replaced. Replacement therapy is mandatory. However, if there is a partial hypothyroidism or subtotal thyroidectomy, then a smaller dose may be required. We have to be careful in pregnancy and in women of reproductive age group. They need to have a TSH less than 2.5. So treatment in a case of post-operative hypothyroidism, even if it is subclinical, should better not be discouraged. It should be given. So when we talk about the thyroid axis, the hypothalamus, pituitary, thyroid axis, this is prone to interactions with a wide variety of drugs, and hypothyroid is the most frequent consequence of these. Thianamides, the drugs causing hypothyroidism, thianamides, as we know very well, it's used in treatment of hyperthyroidism. It inhibits the thyroperoxidase and inhibits the oxidation, the organification of the iodide, the coupling process. So for synthesis of thyroid hormone is reduced, this we know very well. This is in the treatment of hyperthyroidism. However, it's very common to get hypothyroidism if it's given at a dose more in a fashion which is not correct, it may lead to hypothyroidism. Going to other agents now which are more important and which we probably don't realize, one of them is iodine. If we see, iodine is one of the most important constituent, as we know, of the thyroid hormone. The iodine was discovered in 1811 by Bernard Courtiers. Its name comes from the Greek word iodos, which means violet. Now, what happens when this iodine, which is so much required for the thyroid hormone, suppose it is in excess, then what happens? If it's in excess, then it inhibits. There's a decrease in the iodide transport, and there's a decrease in the iodide oxidation organification. It may also lead to immunostimulation. It has been shown that an excessive iodine intake increases the risk of hypothyroidism as well as thyroid autoimmunity. So here is where what we talk about, the Wolff-Chaikoff effect. So what is the Wolff-Chaikoff effect? So it's a presumed reduction in the thyroid hormone levels, which is caused by an ingestion of a very large amount of iodine. So suppose our thyroid gland is exposed to excess of iodine, what happens? Instead of forming the thyroid hormone, all these steps are begun to be hindered and inhibited. This was first discovered by Dr. Jan Wolff and Dr. Lion Chaikoff. And why it happens so? Why does this Wolff-Chaikoff effect occur? Because the thyroid itself has several self-regulatory functions. So it's sort of a protective mechanism. Whenever there is a sudden increase in thyroid iodide serum levels, then as a protective mechanism, the synthesis gets inhibited, and there's a decrease in oxidation as well as synthesis as well as release. So what happens? Hypothyroidism results, but then when a person is normal, when one has a normal functioning thyroid, then within a period of 2 weeks, the thyroid gland undergoes an escape from this inhibition which is going on. So an escape phenomena occurs in a normal person, and again there is the thyroid synthesis again begins in a normal fashion as was before the exposure to iodide. But in a case where there is a lower thyroid reserve, the autoimmune thyroiditis, goiters, in these conditions, they do not have this escape phenomenon so well, which is impaired, and that leads to hypothyroidism. So this Wolff-Chaikoff effect is used in the principle in treatment of hyperthyroidism by iodide, and it also explains so many iodine-containing drugs, which we will be talking about later on. The predisposing factors for iodine-induced hypothyroidism are autoimmune thyroiditis. So if one has any of these, then one is more susceptible to have iodine-induced hypothyroidism. Autoimmune thyroiditis, post-treatment of hyperthyroidism, previous hemithyroidectomy for a nodular goiter, past history of postpartum thyroiditis, subacute thyroiditis, drug-induced thyroiditis, thalassemia major, because there the patients do have some hemosiderosis occurring even in CKD patients and extremes of age group. So where do we get so much frequently exposed? So in acute exposures, especially by radio contrast agents which contain iodine and CT scan with a contrast agent, or we can have systemic exposure to iodine or a topical exposure. In all these conditions, there will be a decrease in TSH, there will be increase in TSH, decrease in thyroid hormones, increase in the urinary excretion. Talking about imaging studies, see, this is more common than what we give it due importance, because it has been seen that all these angiography, venography, pylography, ERCP, myelography, CT, and so many, they use iodine contrast. And because of this, a large number of patients, as high as 20%, may develop thyroid dysfunction, hypo or hyperthyroidism secondary to the iodine contrast. Coming ahead of that, now the next important drug when we talk about iodine excess is amiodarone. Amiodarone is a benzofuran derivative with a high iodine content. About 39% of its molecular weight is iodine. 39% of molecular weight of amiodarone is iodine, and that is why when we take it in a therapeutic dose of 200 to 600 milligrams per day, we are taking about 50 to 100 times higher intake of iodine than what a person who is not taking amiodarone would take. So and it has a long half-life. Elimination half-life is 100 days. So it gets deposited everywhere in the adipose tissue, in the liver, connective tissue, in the thyroid gland, in the muscles, heart muscles. What it does, it causes a decrease in the iodide transport, reduction in synthesis of thyroid hormones by the Wolff-Chaikoff effect that we just discussed, blockade of release of hormone, and then it also may cause thyroid cytotoxicity sometimes, that may lead to sometimes hyperthyroidism. I'll be discussing that later on. So talking about amiodarone-induced hypothyroidism, it usually appears in the first 6 to 18 months of treatment. It's common in women, in elderly patient, and those who have a pre-existing autoimmunity, usually in areas of sufficient iodine intake. If the amiodarone-induced hypothyroidism is sustained or severe, we may have even ventricular arrhythmias. So basically being used for arrhythmias may further lead to arrhythmias because of this complication that may develop. Sometimes even renal disorders are seen, which are usually reversible, thankfully. So what should we do in a patient who develops hypothyroidism following prolonged amiodarone use? If previous thyroid dysfunction is there, then even after the discontinuation of amiodarone, the dysfunction is going to persist. He will require chronic levothyroxine therapy. But it is important to note that it is not necessary to interrupt the amiodarone administration if hypothyroidism occurs. That we have to remember, because usually we can correct the hypothyroidism and that suffices. How do we decide on this? It depends on the degree of thyroid dysfunction, depends on the cardiac status, the patient's age. All these factors are important in deciding whether we have to continue amiodarone and replace the thyroxine, which however is required. For starting a thyroxine in this, we start with a small dose usually, up titrate every 4 to 6 weeks, because the patient usually has a cardiac disorder, and according to the tolerance and the cardiac status, we reach up to the required level. So it's important to note that before we should monitor thyroid profile in all patients receiving amiodarone. That is the underline that we should remember before beginning, at the end of first month, at the end of third month, and then 6 months thereafter, 6 monthly thereafter. Then we come to lithium. Lithium carbonate is an alkali cation used in neuropsychiatry to treat bipolar disorders. Say 1 in 200 patients of bipolar disorders will be given lithium as a treatment. And the lithium gets concentrated in the thyroid around 3 to 4 times more than it is in the blood. So it also causes hypothyroidism and blocks the release of the hormone, inhibiting the iodotyrosine coupling. Lithium has a specific characteristic that it even promotes some of the factors which are the growth factors in the thyroid and leads to goiter formation. So it's supposed to be goitrogenic as well, and hypothyroidism also occurs. Lithium occurs more in women in the first 2 years, and again withdrawal may not be always required. You may correct the thyroid levels, but again the underlying statement that we should monitor and watch for the disorder. Then we have minocycline. Minocycline is an antibiotic in the tetracycline group used to treat acne vulgaris. And it's very interesting to note that way back in 1967, first time minocycline-induced black thyroid was described by Bennett et al. Till date, about 125 cases are reported in literature. And even other tetracycline group like doxycycline may also induce this black pigmentation, which occurs because of the oxidation by the thyroid peroxidase, and this pigmentation can be seen in the skin, in the sclera, in the bone, in the teeth, gingiva, and the nails. So this also inhibits the thyroid function, and this also causes hypothyroidism. Drug-induced thyroiditis. So in addition to what we just talked of, we talked of the Wolff-Chaikoff effect, we talked about the action of these drugs. Now, the drugs directly causing thyroiditis. In that, we have some important groups of drugs, tyrosine kinase inhibitors, which are now very much used these days, the interferons, alpha, beta, interleukins, etanercept, used for so many connective tissue disorders and so many other neoplastic conditions as well. Some monoclonal antibodies, lenalidomide, anti-TNF-alpha infliximab, which is so commonly used. And then the ischemic tyrokinase inhibitors, which block the vascular endothelial growth factor. These all are important as they cause thyroiditis. So interferon alpha, which is a very important drug used very often, how does it cause? So what is found is the mechanism is still not very clear. Way back in 1986, I think that is a time when we began to use the interferons. Since then, thyroid dysfunction has been reported. It is used, where do we use it? In leukemia, condyloma acuminatum, Kaposi's sarcoma, hepatitis B and C. So what is stated is that probably there is a recruitment of some immune cells, probably the natural killer cells, which damage the thyroid, or probably the drug directly has a cytotoxic effect. Thyroiditis is seen in 20 to 40%, and it is more seen in patients with thyroid autoimmunity. It's interesting to note that patients with hepatitis C, where we use interferon alpha very often, they have more, or they are more prone to this hypothyroidism, because it's said that the hepatitis C and the thyroid antigens, they seem to have some molecular mimicry with a similar appearance, and that causes more of autoimmunity and then thyroiditis and then hypothyroidism. Now, having said that, there are other mechanisms by which we can have hypothyroidism, and these are acting at the level of the pituitary. So, secondary or central drug-induced hypothyroidism occurs more often than what we give credit to. There's a drug called bexarotene. Bexarotene is a retinoid. It's a new group of retinoid used in the treatment of cutaneous T-cell lymphoma, and it has been found to induce central hypothyroidism in a large number of patients. So this is what we have to remember, that central hypothyroidism can also occur with these newer drugs. Somatostatin analogs, which are used in many conditions like acromegaly, in carcinoid syndrome, in VIP tumors, they can also induce central hypothyroidism. Glucocorticoids. Glucocorticoids have a very important relationship with thyroid hormones. At physiological level, hydrocortisone plays an important role in the diurnal variation of TSH. It's found that TSH is lower in the morning and higher in the night, secondary to the impact of the glucocorticoids. So in patients who have adrenal insufficiency, we usually will find a high TSH level. It's not uncommon to find that. And in patients who are on high doses of glucocorticoids, in such patients we find that TSH is suppressed in normal as well as hypothyroid individuals. So this is something that we have to keep in mind, since it's a drug which we use very often. Then we have dopamine and its agonists, such as bromocriptine. They also suppress the TSH secretion by activating the T2 receptors. Now some immune mechanisms. When we talk about the immune mechanisms, there is an anti-cytotoxic T lymphocyte associated anti-CTLA antibodies, which of the group ipilimumab and tremelimumab, which induce acute lymphocytic hypophysitis. And this leads to a condition of panhypopituitarism. And central hypothyroidism is one of the commonest features that we see in this lymphocytic hypophysitis. So since these are the newer drugs which are coming up, they seem to have quite a significant impact on thyroid as well as the endocrine system, and have to be kept a watch of. Now, interactions in the treatment of hypothyroidism. Now, having seen the drugs which have affected, now that we have a patient of hypothyroidism, what are the various things which can interact in the treatment and lead to a result which is probably not that good? And sometimes we may be thinking as to why we didn't get the result good enough, that TSH suppression, why it is not good enough. Probably we have to keep in mind so many interactions. When we talk about the levothyroxine, which is given to a person of hypothyroidism, approximately 62 to 82 of the orally administered levothyroxine is absorbed within the first 3 hours after intake, mainly from the jejunum and ileum, and the absorption is higher on an empty stomach. So there are various agents which can alter the intestinal obstruction, and there's a huge group: the lipid-lowering drugs, the sucralfate, aluminum hydroxide, PPIs that we were discussing in the previous session, iron salts, calcium carbonate, laxatives, antacids containing magnesium, sodium sulfur polystyrene, then the phosphate binders, zevalamir and lanthanum carbonate, chromium, raloxifene, orlistat, tyrosine kinase inhibitors. So there's a huge list. And it's preferable to see that these drugs are at a given, if they need to be given, at a time which is separated from the thyroxine administration by at least 3 to 4 hours. Not only drugs, there are dietary substances also which interact with the thyroid, commonly being bran being significantly inhibiting the intestinal obstruction of levothyroxine. Soy containing nutritional preparations, soya being used very often. It has been seen that, but it affects the intestinal obstruction, so we have to keep it separate from the thyroid formulation that we are giving. Prunes, which we call aloo bukhara, that also can cause espresso coffee also in herbal remedies. So to avoid these interactions, it's better that administration of these drugs and food kept separate by around 4 to 6 hours. Vitamin C may increase the absorption of levothyroxine. Now, just a line of the drugs which alter the levothyroxine transport and metabolism. As we know that the main transporter is the thyroxine binding globulin, and we also know that there is an impact of estrogens on the metabolism of thyroxine binding globulin in the form that it gets glycosylated, and estrogens also increase the hepatic synthesis of the TBG. So the clearance is delayed because more of the hormone is in the bound form, so we have a total T4 and T3 may be higher. And in a patient who is receiving the estrogen therapy, postmenopausal woman, for example, receiving estrogen therapy, or a young woman on OC pills, she may, oral contraceptive pills, she may require a little higher dose of replacement to have an adequate thyroid function. So evaluation and monitoring at 6 to 8 weeks of starting of these agents is recommended. Then we have the cytochrome with 3A4 enzyme inducers, the drugs for enzyme induction, carbamazepine, rifampicin, phenytoin. But it is to be noted that in a person with a normal thyroid function, in a healthy individual, the hypothalamic pituitary axis, thyroid axis compensates for all this change which occurs. However, in a person who has a somewhat reduced reserve, again will develop hypothyroidism, and the replacement doses for the levothyroxine will increase. Now, a word about exogenous hyperthyroidism. When I go to exogenous hyperthyroidism, we should know what is the Jod-Basedow effect, which is also called the Jod-Basedow phenomenon. This is exactly the opposite of what we were discussing in the Wolff-Chaikoff effect. It is hyperthyroidism following the administration of iodine or iodide either as a dietary supplement, iodinated contrast imaging substance, or as a medication. Typically, this occurs in patients who are having iodine deficiency, who are the residents of iodine deficiency areas. And when they relocate to iodine abundant geographical area, typically in them it may be observed. It is to be noted that the hyperthyroidism develops within 2 to 4 weeks following the iodine administration. But what is important to note is that it does not occur in patients with normal thyroid glands. Why? Because in them it is under the thyroid gland is under the HPA axis regulation, and there it does not allow this hyperthyroidism to occur. But in the patients who is in iodine deficiency zone, there they begin trapping more of iodine, and they produce more of hormone and lead to hyperthyroidism. Similarly, we have, when we talk about thyrotoxicosis, amiodarone, which we talked about, amiodarone-induced thyrotoxicosis. Here we have type 1 amiodarone-induced thyrotoxicosis. Yes, just one more slide. Related to excess iodine release from the drug.
Timing out.
Yeah, so this is the last only. We have type 1 and type 2, and the monoclonal antibody I already discussed, so I would conclude that several drugs affecting the thyroid hormone status, thyroid function should be previously assessed and regularly monitored. Intake of levothyroxine should be separated from the drugs and the foods which impair its absorption. And the newer immunomodulating antineoplastic therapies, they have an interaction that has to be kept in mind. Thank you so much for a patient listening. Thank you.
Thank you, Dr. Swati. You have very nicely elaborated. Congratulations for explaining very definite and very lucid presentation on exogenous and hypothyroidism. Thank you very much. Any question from the floor? Yes.
Ma'am, thyrotoxicosis factitia. So, how you are going to diagnose it?
Yes, so thyrotoxicosis factitia, something when a patient takes an external agent, a thyroxine from probably some food, or takes it purposefully, and then they develop this picture of thyrotoxicosis. So in that case, a history is very important, and then we have to go in for a thyroid profile. Obviously, it will give us a picture of thyrotoxicosis. When we further evaluate for thyrotoxicosis, we can go in for other further investigations. One is history, I said, and the investigations would be probably a scan would show a suppressed thyroid uptake of the iodine. Otherwise, usually thyrotoxicosis, when we talk about Graves' disease or a goiter which is secreting more of thyroid hormone, that would give result increase uptake. But in thyroiditis, number one, we will have a suppressed uptake, and even in thyrotoxicosis factitia, we'll have a suppressed uptake. So that may be required, but usually a history would be very useful, but sometimes we may have to go in for further tests.
Yes, I think this question is emphasized for that thyrotoxicosis factitia. History sometimes patients deny, so we will not get that history. And at rightly pointed out radioactive iodine uptake and thyroglobulin levels. So it will be suppressed. The one important test by which we can differentiate is fecal thyroxine level.
Excretion.
So fecal thyroxine excretion can be
That can
estimated,
also
and
be
by which we can diagnose. Thank you, ma'am.
And many a times the patients may not realize, because thyroxine is there. We have so many places where we get in diet and all. So patient may not give the history. Thank you.
Any more questions? If there is no question, we can go to the second topic. So, Vinita can.
I would like to invite Dr. Supratik Bhattacharya for his talk on non-thyroidal illness syndrome in chronically ill patients. Dr. Supratik Bhattacharya is Director, SK and Diabetes and Endocrine Center, Kolkata. He is Consultant, Department of Endocrinology, AMRI, Salt Lake and Apollo Sugar, Kolkata. Sir, please deliver your lecture.
Yeah. So thank you so much, Professor Anuj Maheshwari, Professor Narsingh Verma sir, and all of you here at ACP for this excellent choice of topic, and a warm welcome to all of you who has joined today, and thank you chairpersons for the kind words of introduction. So the topic for me today is non-thyroid illness or sick euthyroid syndrome in critically ill patients. Now let's start with a case. It's a 64-year-old gentleman with community-acquired pneumonia and sepsis, got admitted to ICU 5 days back on mechanical ventilation with pressor supports. If you look at the vitals, the temperature is 38.8, blood pressure is 98/64, the pulse is 130, skin warm, dry, no proptosis. If you look at the neck examination, normal sized thyroid without any palpable nodules. Neurological examination, given mild delayed deep tendon reflex, and this is what warranted the resident to order a TFT. And this is how the TFT looked. If you look at the TSH, it was 0.4, free T4 was 11.6, and total T3 was 50. And you see the reference range on your right-hand side. So which of the following is the likely cause of his condition? So you have Graves' disease, you have Hashimoto's thyroiditis, euthyroid sick syndrome or non-thyroidal illness, and subacute thyroiditis. So these are your choices. And we'll come back and revisit these options after we had talked about this. So let's go back to the basics and look at the axis. So we know that there's a negative feedback mechanism that works. And this is how it works in normal, in primary hypothyroidism, there is less free T4, and because of that, you have increased TSH and increased TRH. In primary hypothyroid, it's the other way around as well. And of course, there's a log linear relationship between TSH and free T4. Now, deiodinases are very important because they are the behind-the-scene puppeteers, and usually what is driven is conversion of T4 to T3, and what is suppressed is conversion of T4 to reverse T3. So this is the active mechanism, and this is inactive in normal circumstances. Now, if you want to interpret thyroid function test, this is how it should be in a euthyroid state. Now, in conditions which is a hyperthyroid state like Graves' disease, toxic multinodular goiter, you'll have increased free T4 and free T3 with reduced TSH. So toxic adenoma, thyroiditis, drugs like we had been hearing about before, amiodarone, iodine excess thyroxine intake, factitious thyroiditis. So all of these will lead on to increased free T4, free T3, and reduced TSH. On the other hand of the spectrum, if you look, increased TSH with reduced free T4 and free T3 in iodine deficiency, neck irradiation, renal thyroiditis, congenital hypothyroidism, post-radioiodine therapy, thyroidectomy, hypothyroid phase, etc. There's another condition called the subclinical hyperthyroidism, where the TSH levels are mildly reduced with normal free T4 and free T3. And also the drugs, steroids, dopamine, assay interference can be the result of this. Opposite end of the spectrum again, where you see mildly reduced or increased TSH with increased free T4 and free T3. This is assay interference, thyroxine replacement, etc. Subclinical hypothyroidism, again, poor compliance with thyroxine, malabsorption, etc. But finally, what we are interested in is the non-thyroidal illness, where you see a TSH which is normal or mildly reduced, as was the scenario that we had shown you before, with a reduced free T4 and free T3. So another mimicker of this particular condition could be central hypothyroidism. So when can TSH measurements alone be misleading? In conditions like central hypothyroidism, non-thyroidal illness, what we are talking about today, recent treatment for thyrotoxicosis, resistance to thyroid hormone or TSH secreting pituitary adenoma, where the picture is very similar. So what occurs in euthyroid 6 syndrome? So there is a critical illness and multiple things happen. So reduced food intake, hypothalamic adaptations, pituitary adaptations, intrathyroidal changes, leading on to decreased serum TH concentrations and altered tissue TH metabolism, resulting in more or less bioavailability of the T3. So there is inflammation that happens, and because of that, this is how it normally handles. So hypothalamic thyroid hormone signaling during inflammation, this is what you see. So D2 promoter, increase D2 deiodinase, and there's a conversion of T4 to T3. T3 goes and attaches to the beta subunit of the thyroid receptor. But in euthyroid 6 syndrome, what happens is a relatively common finding, acute or chronic illness, and absence of intrinsic abnormality of the hypothalamo-pituitary thyroid function. And this is the normal, what you see on the left-hand side. D1 is active, so there is conversion of T4 to T3, and also there's conversion of reverse T3 to T2. But in non-thyroidal illness, the D1 is inactive. The activity of the D1 goes down, so conversion of T4 to T3 doesn't happen, and conversion of reverse T3 to T2 doesn't happen, so the levels of reverse T3 go up. So this is exactly the scenario what we come across: decreased D1 activity and decreased D2 activity, leading on to reduced RT3 clearance and reduced T3 production, and augmented D3 activity, leading on to increased T3 inactivation and reverse T3 production, resulting in reduced T3 and T4 levels and increased reversed T3 levels. So if you look at the thyroid function test in this scenario, you'll see low T4, low T3, low T4 syndrome, high T4 syndromes, or other abnormalities. Again, what we want to concentrate on is this particular thing, that severe illness with T4 and free T4 that is low or low normal TSH, and if the measured T3 is low, then we also need to look at the serum cortisol level. So if the cortisol level is more than 30, that's fine, but if it's below, then ACTH should be drawn and the patient must be given supportive cortisol therapy. Over on top of that, we need to also determine FSH in the postmenopausal woman as a sign of pituitary function. Also, use of aspirin, dilantin, carbamazepine should be noted. And dopamine used in this setting of severe illness can induce clear-cut hypothyroidism. So this is the prognostic graph that we see in euthyroid 6 syndrome. And you can see in here, mild, moderate, and severe. So lower the T3 level, more is the severity. And gradually during the recovery phase, you see the T3 levels going back up again. Reverse T3 also increases and then gets better as the patient recovers. So how common is it? In ICU setup, abnormal TFCs are very common. More than 70% patients show a low T3 and 50% of the patients show a low T4. So euthyroid 6 syndrome, relatively common finding following any acute or chronic illness, absence of an intrinsic abnormality of the hypothalamo-pituitary thyroid function. Rather, it is considered a secondary adaptive change. Avoid testing unless strongly suspected. Pre-illness TFT is very vital and invaluable. So if you have, you can compare. Thyroid hormone replacement is not needed. And follow-up testing is necessary after recovery. So these are the reasons why all of these changes occur. So if you look at the TSH, we said that it could be normal, high or low. Low TSH is because of suppression of the hypothalamo-pituitary axis by inflammatory cytokines, abnormal TSH glycosylation, decreased leptin resulting in low thyrotropin releasing hormone, increased hypothalamic and pituitary type 2 iodothyroid dehydrogenase or D2 activity, and transient TSH increase. Why do we see a normal, high, or low T4? Because of increased direct free T4, possibly because of inhibitors of T4 to binding proteins. Total T4, if you look at, they're normal or low, and this is because of low production of the binding proteins, decreased binding to thyroxine binding globulin, and low TSH. T3 is low, but this is because of decreased D1 activity, what we had seen before, low production of thyroxine binding globulin, and decreased binding to thyroxine binding globulin, and low TSH. Reverse T3 is high, increased T3 activity, because of the increased D3 activity that we had discussed before. So this is again talking about the same recovery graph. So as the numbers become more severe, we see there's a drop in the free T3 and increase in the reverse T3. What are the caveats with the TFT in non-thyroidal illness? So low T3, most common finding and seen even early in the disease. Low T4 in moderate to severe illness, additionally due to thyroid binding globulin, transerythrin, and albumin. So again, the chances of survival, this is in COVID-19. So euthyroid 6 syndrome as a prognostic indicator of COVID-19 pulmonary involvement associated with poorer disease prognosis and increased mortality. Pretty much the same thing that we talk about. So if you have very low T3 numbers, that will mean that there is a prolonged hospital stay and also severity of the illness. During recovery from the incurrent illness, thyroid hormone and TSH return to normal. In some patients, TSH may become overtly elevated for short periods of time, and this rise in the TSH typically precedes the increase in the T4 and T3, and it's important to be aware of this transient phenomena in order to avoid inappropriate diagnosis and treatment. Now let's come back to the clinical case that we showed. Let's rule out one by one. So the first choice was Graves' disease. So patient does not have any findings of Graves' disease, tachycardia, fever, etc. on symptoms. And if you look at the Graves' disease profile, thyroid profile, there'll be increased T3 and T4 with a suppressed TSH. So we don't find anything of that sort in this particular person. So Hashimoto's thyroiditis, again, patient's TSH is borderline low, not compatible with the Hashimoto's where TSH should be elevated. Finally, subacute thyroiditis, again, infection can trigger destruction of the thyroid gland, and transiently it might land up in a hypothyroid state, transient elevation of the free T4 and T3, but this doesn't fit into the scenario as well. So the final choice that we have is the euthyroid 6 syndrome or the non-thyroidal illness. So should our patient receive LT4? So sometimes it's better to do nothing than treat, and this is one of those conditions. We do not have very convincing data regarding the use of levothyroxine in this condition. These are the various studies that has given multiple interventions from using combination GHRH or TRH, for example. Some of them have used T3, T4, but none of them seems to be very, very convincing. And sometimes probably it seems at the end of the day that if you do nothing, that is going to be helpful. So if we want to summarize the management, thyroid hormone replacement is not needed in patients with euthyroid 6 syndrome. Treatment and management of the underlying medical illness is the focus. However, periodic monitoring of the thyroid function should be done. After discharge from the hospital, thyroid function abnormalities may persist for several weeks. And in clinically euthyroid patient, thyroid function tests should be repeated 6 weeks after hospitalization to confirm overt thyroid dysfunction and persistent TSH abnormality. And again, if you have a pre-admission value, it's invaluable because you can compare. So guidelines for management, 2 general guidelines are given. First, measure the TSH only if there is a high clinical suspicion of thyroid dysfunction. If TSH is abnormal and further workup is done, if the TSH is greater than 20 or undetectable, then euthyroid 6 syndrome is less likely to be the cause. So when serum TSH is not elevated, euthyroid 6 syndrome should be considered in patients with known thyroid disease and low serum free T4. What about the prognosis? As we mentioned, low serum T3 is correlated with an increased length of hospital stay, intensive care unit admission, and the need for mechanical ventilation, and this was done in the acute heart failure patients. Also, the serum T4 value correlates with the outcome in critically ill patients. Those who have a number less than 3 micrograms per deciliter have been associated with mortality rates, which is in excess of 85%. What are the differential diagnoses? Hashimoto's thyroiditis, hyperthyroidism, thyrotoxicosis, panhypopituitarism, and thyroid dysfunction induced by amiodarone. Role of parenteral nutrition. So when early full parenteral support is used to resolve the caloric deficit, the peripheral changes in the thyroid axis partially normalize, but the central suppression does not. So clinical pearls from today's talk would be, in patients with acute illness, do not assess thyroid function unless there is a strong indication. If TFT assessment is indicated for critically ill patient, serum TSH and free T4 should be measured. TFT in critically ill patients usually show low serum total T3, normal or low serum TSH, and normal or low free T4. Many drugs in ICU setup can alter the thyroid hormone levels. Thyroid hormone therapy is not recommended for critically ill patients with low T3, low T4, or both. During recovery, some patients may have mild elevations in the TSH levels, and thyroid hormone levels may take several weeks or months to return back to normal. So you have to keep on following up these patients. And patients with serum TSH more than 20 during recovery phase, more likely to have permanent primary hypothyroidism. So non-thyroid illness is a relatively common finding following acute or chronic disease. Absence of intrinsic abnormality of the hypothalamo-pituitary thyroid function, rather considered a secondary adaptive change. Avoid testing unless strongly suspected. And pre-treatment TFT, if available, consider that as a lost treasure. And thyroid hormone replacement is not very helpful in this scenario. So with this, thank you so much for your kind and patient hearing.
Thank you, Dr. Supratik. Any questions from the audience?
Any more questions from the floor? If there is no questions, then we thank both the speakers, Swati Srivastava and Supratik Bhattacharya, for their nice deliberation, excellent presentation, and lucid examples, and also very vivid presentation, and they are praiseworthy.
Thank you so much, chairpersons, for your kind words.
So thank you very much for both the speakers and our listeners and who are the delegates and also faculties. Thank you, Dr. Anju Maheshwari, to give us the chairs, and Dr. Srinivas Murthy for these excellent sessions. Thank you very much. We conclude this session.
Thank you, chairpersons. I would like to request our chairperson for the last session to take their facilitation from Mediquip canopy outside on the next hall. And for the next session, I would like to invite our eminent chairperson, Dr. G.R. Sridhar, MD DM, FACE, FRCP, Director, Endocrine and Diabetes Center, and Dr. L. Srinivas Murthy, MD, FRCP, FICP, PDCR, former consultant at Fortis Hospital and Global and Apollo Hospitals. Thank you, sir. Over to chairpersons.
Good evening. Welcome to the city by the sea, Visakhapatnam. Even if you can't go by the sea, you can just stand on the balcony and look at the sea. I invite Dr. V. Ramya. She is the consultant endocrinologist at Apollo Hospital, Visakhapatnam. She's done her MBBS, MD and DM from Andhra Medical College, the resident medical institution from which most of us have graduated. She's got many accomplishments. She was awarded many awards and medals and has also presented on national platforms. She is going to speak on a subject which is fairly new in the new millennium, pioneering the upstream approach in diabetes management with oral GLP-1RA. When we were young and some years ago, when we were dealing with the drug to treat diabetes, we used to see if it was efficacious in lowering the glucose level. That's what we thought we have to look at. But it turned out that some of these, they can lower the glucose and they kill the patient with cardiovascular events. So the FDA said, no, it's not enough if you have to lower just the glucose. You should show that they do not increase other complications. So by and by, what some of the newer consultants would recall is, it should not just lower the glucose, but it should do more. It should be anti-diabetes plus. And I think Dr. Ramya is going to show evidence of how the new group of drugs are going to be, not just in improving the glycemic control, but doing something more. Over to Dr. Ramya.
Thank you, Dr. Sridhar, sir, for your kind introduction. I am Dr. Ramya. In the first place, I want to thank the organizing team and Novo team for giving me this opportunity. And it's a proud privilege to be talking on this platform in front of the renowned physicians. So coming to my topic proper, pioneering the upstream approach in diabetes management with oral semaglutide. And this is a topic overview. I'm going to speak for the next couple of minutes about the burden of weight in diabetes, addressing the sinister synergism with upstream approach, and place of oral semaglutide in managing weight in people living with diabetes, and ending with a case vignette. So coming to the word diabesity, which is a new word which are using recently for the past 1 decade. Diabesity is coexistence of both diabetes and obesity. It's a modern epidemic. And both are interrelated by multiple pathophysiological relations revolving around insulin resistance and hyperinsulinemia. So 1 in 10 individuals have diabetes in India, and 4 in 10 adults are obese. And 67% of the people with diabetes in India have obesity. And it's really surprising to know the mortality risk is increased by 7 times if a patient has a diabetes along with obesity compared to non-obese and non-diabetic. And there is an entity in Asian countries like thin fat Indians. Though these individuals have normal BMI, they have abdominal adiposity, which we generally talk as lipolytically active, which is responsible for most of the components of metabolic syndrome. So this slide typically shows the interrelation between adiposity and diabetes. And it shows the various diverse risk factors, which include physical environment and also social environment, leading to adiposity and thereby to diabetes. The physical environmental factors we all know. It's a poor dietary pattern, lack of physical activity, and social environment like income inequality coming from a low socioeconomic status, and mental health like sleep disorders. All this leads to adiposity. So adiposity itself at the level of liver and muscle and adipose tissue leading to insulin resistance and thereby beta cell decompensation leading to diabetes. In the other way around, diabetes, the medications, oral diabetic drugs causes weight gain, and long-standing diabetes leading to neuropathy and lack of physical activity, and recurrent hypoglycemias leading to increased food intake. All this leads to obesity. So both are interrelated in many ways. And now we all know the complications due to increased body weight, both cardiovascular and non-cardiovascular. And coming to the importance of upstream approach, the topic proper. So it was like we need a weight-centric intervention would definitely cause the diabetes individuals, type 2 diabetes, into remission and reverse the slow down the disease and thereby decrease the both micro and macrovascular complications. We always see many patients walking into our OPD with a new onset diabetes and asking a single question, is our diabetes reversible? Can we go off the medicines? So there are few landmark trials of diabetes prevention, which I'm going to show in the next couple of slides. It clearly shows significant weight loss leads to remission of diabetes, and thereby we can maintain without oral diabetic drugs. And this is one of the landmark diabetic prevention trial, diabetes prevention program study. So in this study, like people are in the borderline diabetes are characterized into, like randomized into two groups, one to a intensive lifestyle and another group to the metformin. At the end of the study, it's like the individuals with intervention lifestyle, significant intensive lifestyle, has a decrease in the incidence of diabetes by 58%, whereas it's only 38% in a metformin group. So in this study, it's clearly showed like change in weight from baseline. There is a correlation between significant decrease in the weight and decrease in the incidence or rate of people with the number of persons with diabetes. It's a direct relation. With a progressive decrease in the weight, there is a decrease in the incidence of diabetes with a reduction in the body weight. And this is also same, the Look Ahead trial, which is done to see the, between the intensive intervention lifestyle to prevent the onset of CV outcomes. And from this study, it clearly showed with decrease in the weight loss from more than 2% to 15%, there is also a direct relation. The more the weight loss, the more the decrease in the HbA1c, which is shown in the y-axis. It is the same thing. On the y-axis, it's the fasting plasma glucose, and the x-axis in the weight loss. So there is a direct relation. So even with a modest weight loss, there is a significant improvement in the glycemic parameters. So this is also another important diabetes prevention trial, diabetes remission clinical trial. So it clearly showed this light yellow orange bar is like at the end of 1 year, and this slightly dark color at the end of 2 years. So with a significant decrease in the weight from 5 kgs to 15 kgs, there is the bar which is shown here, there is 86% decrease in the incidence of diabetes. So at the end of this trial, and it is also maintained at the end of 2nd year. So 46% of the patients in the intervention achieved remission. So greater the weight loss, greater the remission, and more the weight loss is sustained, yes, we can prevent or delay the onset of diabetes. Coming to the evidence-based approach for weight management, one is the lifestyle modification, we all know, dietary therapy, physical activity and behavioral therapy, and pharmacotherapy, So Orlistat, this is in the market for the many years, and liraglutide and semaglutide injectable, and naltrexone and phentermine, which we generally use them at a lesser. So the weight loss with the surgery, laparoscopic adjusted gastric banding, and Rowen-Y, when we consider with a morbid obesity with a BMI more than 45. Coming to like the unmet needs in the weight loss therapy. So whatever the therapy we use, we need to consider the weight loss should be sustainable. And it should address mainly the decrease in the adiposity rather than muscle mass, and the concomitant effect of other anti-diabetic drugs. So we need to look for a molecule which can address the multiple effects, not only the weight. So we have GLP-1 analogs. We are using them for the past 10 years. But only after the results of the major landmark trials, leader trial, CV outcome, they became a game changer in the treatment of diabetes. There is a paradigm shift in the glucocentric approach to cardiocentric approach in individuals with diabetes. So this GLP-1 analog, besides like managing glycemic control, it has like a holistic approach. We have a CV benefits and promoting weight loss with less hypoglycemia, and the special thing is it is approved for a wide variety of patients, especially elderly due to less risk of hypoglycemia, and cardiovascular individuals with coronary artery disease, which clearly showed there is a decreased mortality and decrease in the progression of CKD in individuals with diabetes. The mechanism of the action, which is only shown at the level of hypothalamus, it acts directly at the area prostrema and parabrachial nucleus projections, and indirectly to area prostrema and NTS pathway, causing satiety. And coming to the important point I want to specify here is, it is the adipose tissue which is more lost with semaglutide, which is clearly shown. The decrease in the body weight is mainly due to fat mass. It's like more than 2.6, whereas the lean mass decreased by 1 kg. So by using oral semaglutide, there is a decrease in the adipose tissue, and the total decrease in the body weight is due to decreased intake, as the resting metabolic rate is less. And coming to the series of pioneers trials, which are done for the past couple of years to see the CV safety of oral semaglutide. And the pioneer one is comparing different doses of oral semaglutide with placebo, and at each and every dose, including the 3 mg, there is a significant good glycemic control. Most of the individuals are able to achieve the HbA1c less than 7%. But coming to the weight loss, there is no statistically significant weight loss with 3 mg, but with 7 mg and 14 mg, there is a significant weight loss of more than 5%. And the Pioneer trial 8, it's like comparing different groups of oral semaglutide with insulin. And this study is done for complete 1 year, and this clearly showed at the end of 26 weeks, and at the end of 52 weeks, there is a sustained weight loss. What we need is, it's not an acute weight loss, we need to have a sustained weight loss. So 1 out of 2 people achieved the weight loss of 5%, and the weight loss is even sustained. And the other thing is change in the body weight at the end of treatment. So across all Pioneer trials, when compared to empagliflozin in Pioneer 2 and compared to sitagliptin in Pioneer 3, and including liraglutide in Pioneer 4, there is a significant weight loss with oral semaglutide, which is more with oral sema rather than other drugs. So there is up to 5 kg weight loss seen in Pioneer series of trials. This is what we are discussing. The change in the body weight is sustained over time up to 1 to 2 years. And another thing is age is another important factor. In the series of trials, they divided the people into three groups based on the age, less than 45, more than 65, and between 45 to 65. Irrespective of age, there is a consistent weight loss in all age groups. That is shown in this series of trials. And the background medication, even if the patient is on other drugs like other metformin, sulfonylurea, or any other SGLT2, there is a consistent weight loss regardless of the background medication. And this blue bar is oral semaglutide. Across all trials, 3, 4, 5, and 6, there is a consistent weight loss irrespective of the background medication. There is a sustained weight loss. So the change in HbA1c across all the series is like up to 1.5%. So this is what our American Diabetic Association 2022. So there is a shift in the treatment from 2017 depending upon the comorbid conditions and also based on the weight. So this half, depending upon the CKD, CHF, and CAD, the drug of choice is always GLP-1 analog or SGLT2. And coming to the people with diabetes without any comorbidities, the second group is if weight. If weight is a concern, to minimize the weight gain or weight loss, after metformin and lifestyle management, GLP-1 analog is a first choice. Only if it is not tolerable, then SGLT2 be the other choice. Coming to the case here, so a 46-year-old gentleman who had like a sedentary job, who with a poor dietary pattern, eating lots of sugary snacks, and with a strong family history of diabetes and coronary artery disease. So he is currently on metformin and sulfonylurea. And his HbA1c was 8.1% with a grade 1 obesity and body weight of 88 kilograms with early hypertension and elevated cholesterol. But here the albumin creatinine ratio is normal. So coming to this patient, at diagnosis he was initiated on metformin and diet and exercise. Over years we know there is a progression of diabetes and there should be a multifactorial treatment to prevent the complications. So this patient at the end, like currently, he was on a regular lifestyle intervention, walking like 2 to 3 times a week on metformin 2 grams and glimepiride 4 milligrams. So in the past 3 years, he has a sedentary lifestyle. So the concern is, so he is initially maintained on metformin on lifestyle, later initiated on glimepiride with metformin. Over 3 years, he developed the symptoms of atherosclerosis mildly, like shortness of breath, fatigue, over the past 6 months, with progressive weight gain and hypoglycemic episodes. And mind you, there is a strong family history of coronary artery disease. So looking at this patient at 46 years and 49 years, there is no significant change in the HbA1c, but there is increase in the BMI and weight, and all the metabolic components like elevated blood pressure, elevated dyslipidemia, elevated cholesterol and LDL, and there is a progressive increase in the albumin creatinine ratio, which was initially less than 30. It is now 40, and there is a decrease in the EGFR. And so this is a profile of this patient. So he was initiated at diagnosis when his HbA1c was 8.1 on metformin, and at the end of 1 year, the HbA1c was at 7.8. Later, it progressively increased. So the treatment decision at this point, like 8.3, it's better for him to be on sulfonylurea and metformin or GLP-1 analog. So he was started on GLP-1 analog with statin therapy at the end of 3 years. So when the patient on GLP-1 receptor analogs for 3 years, there is a significant decrease in the HbA1c from 8.3 to 6.8, and the weight loss of around 12 kgs, and decrease in the BMI, and all the metabolic parameters also improved. So looking ahead, downstream approach, he was diagnosed with diabetes, initiated on metformin, and with the progression of disease, at the end of 3 years, he was initiated on oral semaglutide, and thereby preventing the further cardiovascular events and further complications. Looking back, if he was initiated on metformin with GLP-1 analogs at initiation itself, metformin and diet and exercise and oral semaglutide and statins 6 years ago, it's not at the end of 3 years after poorly managing with sulfonylureas and metformin. If he would be initiated with semaglutide at initiation itself, as considering with obese and high risk individual with underlying cardiac history, so we are able to prevent the mild coronary artery disease CAD in this individual and prevent further complications. So upstream approach, like if he is a suitable patient with a high cardiovascular risk and obese, it's better to initiate on oral sema instead of other drugs. Though the summary is there is an exponential rise in the incidence of diabetes, and along with diabetes there is an increase in the obesity, and adopting an upstream approach towards weight management can lead to multiple clinical benefits, preventing both the micro and macrovascular complications. And the strategies in current weight reduction are not sustainable. By using GLP-1 analogs, there are various benefits beyond HbA1c control in type 2 diabetes, and they have a valuable place in an upstream approach to diabetes. Thank you. Over to you.
Thank you, Dr. Rama, for that eloquent talk. And for lack of time, we cannot take questions. I'm sure many of them have doubts. Please hang on for a while so that you can sort out their doubts. Sure. Thank you very much. Now let's move on to the next session. I think that's going to be...
Yeah, thank you, sir.
Thank you. That's going to be an interesting session today because it's going to be about something which is surrounding us, and from morning we are trying to produce that noise levels above the required decibels, which the definition my good friend Dr. Ashish will tell us. Dr. Ashish Saxena, please. He's from Ludhiana. He's taken just half a day, that is about 12 hours, to reach here. We appreciate his efforts, and he's a MD FRCP, and he's fellow of various prestigious institutes. He's practicing in Ludhiana clinical research in the field of diabetes and cardiology phase 3 trials also. He's won the Governor Award for work of COVID, ACP Award by Chief Minister of Punjab 2008 for work in rural Punjab, and of course Best Diabetologist, Health Minister Punjab 2021. So he's still going strong, and Ashish is going to talk about the noise stress, an epidemic in progress. Are we really ready to take the challenge? Over to you, Ashish. Ashish, meanwhile, you can start producing the noise.
I think so, because of the noise, everybody got scared and he did not put the slide over here. Well, I'll just go in brief of how I came up to this concept of noise and stress concept. It so happened just about a few years back that I had a young 32-year-old male coming to me with stroke. And he had hypertension, his blood pressure was 160/90, and at the time of admission his blood pressure was somewhere around 180. And he had an infarct. Fortunately, he recovered very well. And it so happened that I continued treating him. He was very responsible, taking medications regularly, and I told him to take a break. I did not ask him his profession or anything because of the busy schedule or that day, the way we were working at that time. And it so happened that in one of our medical conferences, we had a program, and in that program, there was the most renowned DJ of our place, which was called in, and this person was the person who was actually operating the DJ. And he used to complain that whenever I used to come back from this musical night and other things, I have palpitations, I am restless, and another 2 days goes worst. So looking to the condition of this patient and how to do better, me and a few of my colleagues decided let us go through the clinical work which has been done, and it has turned out to be that there is a concept which has been established and we are aware of it, and some of people are not aware, and that is the noise stress concept. And this is my topic because there are certain needs for research also. The presentation I'll take care in these particular topics, where I'll be going on the background of noise in our country, the impact which happens because of the dose-response relationship for noise, the road traffic, the blood pressure, hypertension, the coronary artery disease and stroke, the risk evaluation process for this patient, and what are the solutions, and the needs for research and policy interventions for future prospects. So, looking to the permissible noise limits in our country, which has been laid down by the government, in the industrial area, the noise should be about 75 decibel during the daytime and 70 by night. Commercial areas around 10 decibel less, and residential areas around 45 in the night and 55 in the daytime. Ludhiana being an industrial city and a commercial hub, there has been lots and lots of noise with the autos, with the rickshaws, with the music parties and dances, and the bus, and apart from the dust and other pollution. So these things are increasing day by day. Now these are certain examples of decibels of how noise goes. That whispering is about 20 decibel, and a peaceful landscape which we enjoy during the hills is somewhere around 30, in a quiet living room about 40, and in the suburbs it is 50. So this is what it should be, between 40 to 50 and a normal conversation. We tend to happen to listen to music in our cars and the decibel goes up by 70 to 80. This is where we are actually increasing our own stress. The larger trucks, the jackhammer, the rock concert, this slowly it goes on, and the decibels for the aircraft takeoff and landing is somewhere around 120. Now, this turns out to be the city which has been reported as the maximum noise pollution globally. And this was the report which identifies 13 noise pollution cities in South Asia, and 5 of these, including Moradabad in Uttar Pradesh, which turned out to be having an alarming noise level apart from Kolkata, Asansol, Jaipur, and Delhi. So now let us look to the impact, what this long-term exposure of environmental noise is causing. The long-term exposure is actually causing 12,000 premature deaths. It is contributing to around 48,000 new cases of ischemic heart disease every year in the European territory, because research has been done there. About 22 million people suffer from chronic high annoyance. They are annoyed, restless. And 6.5 million people suffer from chronic high sleep disturbance. Now this is also one point which we see. A lot of our diabetic patients, they do not have a regular sleep, and because of not having a regular sleep, their sugars get fluctuated. Now looking to the cardiovascular effect of noise, the long-term or short-term environmental noise, it is causing a stress reaction or an annoyance reaction, disturbance of sleep. There is also emotional reactions, cognitive reactions occurring in a patient. This is affecting the sympathetic and the endocrine systems, elevating the catecholamines, the cortisones, and resulting in lipid immetabolism, glucose immetabolism, and blood pressure regulation, as well as this is leading to an increased risk of cardiovascular illness. Now this is the model which has been presented by the International Journal, where they say that the noise exposure has got a direct effect and an indirect effect. The direct effect is damaging toward the hearing organs and leading to sleep disorders. The indirect effect is like performance, sleep, annoyance, cognitive, emotional reactions, and leading to anger, annoyance, disturbances. And ultimately both leading to physiological stress reactions. The autonomic nervous system is activated, the sympathetic nervous system, the endocrine system, the adrenals. And coming to the risk factors of blood pressure, lipids, viscosity, blood coagulation, blood sugar, cardiac output, ultimately manifesting disorders like hypertension, CAD, heart failure, arrhythmia, and stroke. Now, there has been a dose-response relationship for the noise and cardiovascular disease. With every rise of 5 to 10 decibel, the increase of cardiovascular risk goes about 10 to 15%. And this is the cardiovascular effect of the nocturnal noise because it disturbs the functioning of the endothelium. So the endothelium dysfunction shown by the flow-mediated dilatation demonstrates more oxidative stress. And this is how things start deteriorating. Transport noise increases the maximum coronary risk. Exposure to both air pollution, transportation, this increases the MACE, and they are synergistically increasing the cardiovascular risk and metabolism and increasing the arterial inflammation. The inflammation is a disease for the diabetes, inflammation is a disease for hypertension, and inflammation of disease combined together causing coronary artery disease. Now, there was a meta-analysis which was done. 24 cross-sectional studies in relationship was studied, and it was seen like decreasing 10 decibel, or if you say a person has a constant exposure of more than 10 decibel of noise for 16 hours, he has a stronger affinity to develop more of hypertension and more of the complications of this. So there is no direct evidence linking noise and coronary artery disease, but many studies have said and shown that noise and coronary heart disease like hypertension, they show an indirect relationship. And the meta-analysis of the 4 cohort and 1 case control has shown this type of association. Now, noise and stroke. Exposure to residential noise traffic was associated with a higher risk of stroke, and this was found when there were lots and lots of aircrafts landing in UK. And so ultimately in Heathrow Airport, they made it that they will not have any landings in the night. So that was the reason, because lots and lots of population was getting disturbed because of this noise pollution. And several studies within the last 10 years demonstrated a higher prevalence of annoyance, cardiovascular disease, or medication intake to persons exposed to aircraft noise. So these were the things which was taken by the UK government. They studied intensively and ultimately came to this conclusion. Now coming to the evaluation, like how do we evaluate the risk? First of all, we need to identify the hazard, what is causing the noise pollution, what is it comprising. Then the exposure assessment and the dose response assessment, like how can we decrease the dose and the exposure, because working is also very important for a person. Looking to the risk characterization and then coming to the management. Now, this is a chart which actually tells us for each day task noise exposure, like if for every 1 hour we just add 5 decibels and the exposure from 79, which is the maximum limit, it starts going up. And as we add up the task, the total exposure keeps going up. And ultimately, if the exposure points or total exposure for the day turns out to be 280 points given a noise pollution exposure between 80 to 89 to 90 with just a slow or a small increase in the decibel size. So coming to the solutions. Solutions of noise reduction turns out to be by physically removing the hazard, that is the elimination, which is not possible in industries. Substitution, yes, that is possible, replacing the hazard. Engineering controls, isolate patients from those hazards, change the way people work, and protective equipment which has to be provided. So the actions to reduce noise in this workplace for occupational hazard turns out to be the safety of the professionals who are working there, to purchase certain equipments which are quiet. Now I'll just give you an example. In our lobbies or in our waiting areas, we have got certain fans. And when they are working, there are certain fans which are creating a lot of noise. And if you see, there is an arrogance coming out. And if you see, you also get disturbed by that constant noise. If you are sitting in a car, if you are sitting in an aircraft, if you are sitting somewhere and suddenly you start experiencing a noise which continuously keeps on going, the irritation bug starts happening. And this is what happens. You start feeling that tachycardia, and ultimately some of the other problem develops. When we are listening to some loud music or a DJ music, initially the dopamine receptors, they work very nice because you're enjoying it, but ultimately the adrenal and the corticosteroid receptors start working, and you start having tachycardia, and ultimately the next day you land up with either gastritis or palpitations or some sort of a dizziness in the mind. So we need to reduce the vibrations as and where possible, isolate the noise source in an isolated room and enclosure, and place a barrier. These are the things which has to be educated to our people who are having these factories. Isolate the employee from the source in a room or booth. These are the WHO guidelines which has been given for noise. In a school or in a playground outside, in a school it should be 30 decibels, in a playground 55, for a quiet living room should be 55, and in an industrial commercial area between 70 to 80. For certain ceremonies, festivals and entertainment events, not more than 100, and the exposure should not be more than 2 hours. And public addresses should be around 80 phones, and when we are using our headphones, we use it to a very higher level. So we need to reduce it because you need to control your problems. So these are the research needs which has been identified. The researchers did not attempt, where the study had taken to account for the demographic and socio-economic or other health risk factors in their analysis. And this is the point where we need to research more. The second step is that source of transportation noise, which has got a very great impact on the health. This has to be taken control because the vehicles are old, the roads are not very comfortable. There are so many things which are associated, and our poor drivers and their co-workers are having a problem. Policy intervention right from the small level, from the taluka level to the state level to the central level, has to come up to reduce individuals' exposure to transportation noise at home and even in urban areas, better enforcement of noise ordinances, infrastructure to block road noise, rules for air traffic, low noise tires for vehicles, and better insulation for buildings. These should be the policy interventions. So in summaries, many cities of our country have recorded higher levels of noise pollution apart from the air pollution which is visualized. Long-term exposure, almost 12,000 premature deaths, contributing almost 48,000 new cases of ischemic heart disease. Persistent and acute exposure to noise leading to development of cardiovascular risk factors. Mental, psychological stress, a stressful population which is aging very fast. Further research is needed to tear apart the effects of this pollution, which is alarming, which we are ignoring, and policy intervention to decrease and give us a safe environment. Thank you all for your patient listening.
Thank you. So we haven't thought of noise as a pollutant. I heard of a story where a city dweller, he was really fed up with all the noise. He said, let's go away from. So he went to a quiet village, booked bread and breakfast, and by the second day morning, there was a frantic call to his friend saying, please record some traffic noise and honking. The silence is killing me. So that way, thanks for bringing out that we need to reduce the noise, and it's not just getting upset about it, but it also has got adverse metabolic and cardiovascular effects. Thank you for the clarity with which you have presented.
Thank you, Dr. Ashish. Since you produced more than 45 decibels, questions are not allowed. Since want of time, we are moving on to the next session, and I would request Dr. Virmani sir, who is a senior consultant physician from Jamshedpur, to chair the session. Please, sir.
May we invite Professor Mujibur Rahman from Bangladesh. He is a senior consultant physician, and he would be speaking on advances in lupus nephritis treatment and his practical experience in Bangladesh.
Good evening to all of you. Dr. Mujibur Rahman is from Dhaka Medical College, University of Dhaka. He's got a number of fellowships, including the Bangladesh College of Physicians, He is Professor of Internal Medicine, Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh, and Counselor, Bangladesh College of Physicians and Surgeons. He's got a number of awards. Over to you, sir.
Thank you, Mr. Chairman, sirs. Dear audience, thank you very much, SCP India chapter, for inviting me to talk on this topic in this August gathering. Assalamu alaikum and very good afternoon to you all. This is the institute where I work. I will try to present something on the introduction of lupus nephritis, especially the management and how the evidences are generated. And I do not have any conflict of interest other than I received investigator's fee for phase 2 lupus nephritis trial. You all know that SLE is a chronic inflammatory disease. Any organ of the body it can affect, especially the major organ like kidney, and also it can affect the brain, and also it can affect the cardiovascular system, the myocardium. SLE is more prevalent, you all know, in women. Male to female ratio, especially on an average, is 9:1, but it varies from race and from epidemiological regions to regions. The prevalence of SLE and chances of developing lupus nephritis varies considerably in different regions of the world. Like in Bangladesh settings, here it is 40% of the lupus patients, they usually develop, but it varies from 30 to 70%, or in some areas it may be up to 80%. So these are the clinical manifestations of lupus nephritis. You all know the proteinuria, nephrotic range proteinuria, or nephritic proteinuria, microscopic hematuria, and all leads to the clinical development of edema and also the generalized the anasarca, and also hypertension, lipid abnormalities. These are some important clinical features. This is the histological classifications that has been proposed by Society of Nephrology, International Society of Nephrology, and Renal Pathology Society, and this is the gold standard of classification of lupus nephritis, starting from class 1 to class 6. But the important is class 3, 4, and 5. These three classes are very important and to be treated very aggressively. So in my presentation, I will be trying to concentrate on 3, 4, and 5 classes of this lupus nephritis. You all know treatment of lupus as a whole was a very gloomy during the last century. But with the advent of prednisolone, the potent anti-inflammatory drugs, it has shown some light after 1950s. So I'll be trying to say something on the anti-inflammatory treatment and immunosuppressive treatment. But the other treatments like immune, other than which is called non-immunosuppressive treatment, the aggressive antihypertensive treatment is needed in most of the patients. Antiproteinuria therapy is important, especially ACEI or ARBs, and lipid-lowering therapies. And above all, the base of treatment of lupus patient is hydroxychloroquine. Principles of immunosuppressive treatment: induction of remission and maintenance of therapy. The induction period is varies usually from 3 months to 6 months, but in some cases it may be extended. And maintenance treatment, I will be telling something on this later on my presentations. Indication, I have already told that only class 3, 4 or combination of class 3 plus 5, class 4 plus 5 or pure class 5, these classes are indicated in immunosuppressive and anti-inflammatory therapies. The goal is resolution of inflammation and also immunological activity with achievement of complete remission. Complete remission sometimes is not possible, sometimes partial remission is also satisfactory. So corticosteroid, I have already told that after 1950s, the invention of corticosteroid has put tremendous light on the management of lupus patient, especially lupus nephritis patient. The dilemma was low dose or the high dose, and again the pulse corticosteroids, the pulse therapy gave the tremendous benefit and renal protection, and it was published in 1976. Some are the historical development of corticosteroids. So pulse methylprednisolone has become the standard of treatment, initiation with 3 pulses, usually 500 milligram to 1 gram daily for 3 days, followed by reduction of treatment, oral prednisolone, that is 1 milligram per kg per day. But subsequently there are some literature, those being proposed that it should be 0.5 milligram per kg per day and gradually reducing to a maintenance dose. So next is immunosuppressive drugs. These are the immunosuppressive drugs, the intravenous cyclophosphamide, azathioprine, mycophenolate mofetil, some of the calcineurin inhibitors. There are 3 calcineurin inhibitors are nowadays using with some promise in lupus nephritis patients, and rituximab, the monoclonal antibody which is directed against B lymphocytes. So the history of treating this lupus nephritis patient, if we see, if we go back to, it was a study that is published in 1978. It has been shown that the only the prednisolone and the prednisolone plus cyclophosphamide gave a better result in the prevention of or the stable renal course of the disease. This is the NIH trial. There were a series of trials under the headline of NIH, National Institute of Health. It was sponsored by National Institute of Health of USA. And it has been shown that IV cyclophosphamide is very active and is very important in giving the induction of remission of lupus nephritis. There are so many trials, I am not going into the details. Again, this is also one of the NIH trial, the combination of cyclophosphamide and methylprednisolone given the best results. Now comes some of the important adverse events of cyclophosphamide, the IV high dose cyclophosphamide, especially the cell count reduction, the agranulocytosis, and also in case of young female in the reproductive age, the ovarian function failure. There is a tremendous debate on the use of these NIH doses of cyclophosphamide in young female patients. So the lower doses of cyclophosphamide, whether it acts, whether it can be as effective as higher doses. So the European lupus nephritis trial came up, and it has been shown that the higher doses and the lower doses are almost similar. So the lower doses nowadays is being practiced in most of the situations, not those of the NIH doses. Next, but still there are some side effects like alopecia, and also ovarian failures are still there. So mycophenolate mofetil came into play, whether it can be as a replacement of IV cyclophosphamide. Yes, it has shown some promising result in some of the trials, and among those, ARMS trial is the pioneer trial, which has shown that the efficacy is almost similar in the high dose group, and also the low, the mycophenolate mofetil and low dose intravenous cyclophosphamide. So both groups are similar. So mycophenolate mofetil came into play for the treatment of lupus nephritis. So choosing between these two drugs, sometimes it's very difficult how to choose, because in our setting, the patient has to buy the drugs from their out of pocket. So MMF is a very costly drug. On the other hand, cyclophosphamide is a very cheaper drug relative to the mycophenolate mofetil. But the other issue is ovarian failure. So we have to choose among these two drugs very carefully depending on the situation. At the same time, in 2018, the Cochrane meta-analysis showed that both the drugs are equally effective. So till 2018, they have, it's a very busy slide. I'm not requesting you to go, but you see the middle point. The terminal effect is not going to any of the sides, neither to the MMF side nor to the IV cyclophosphamide side. So both are equally effective. If we see its renal outcome is almost same. You see it is on the middle. And if we see the ovarian failure function of among this group, yes, it appears to be better with this ovarian failure is less with MMF, but this less is not statistically significant. So you can choose both of the drugs. So the initial preferred therapy is either glucocorticoid and pulse cyclophosphamide, IV cyclophosphamide, usually lower doses IV cyclophosphamide, or glucocorticoid plus MMF, that is mycophenolate mofetil. Either of these two can be chosen at any time for the treatment of lupus nephritis class 3, 4, and 5. Less preferred therapy, I will not going into the details. The calcineurin inhibitor such as tacrolimus, I have told the name. Tacrolimus, it has been tried for several times in a multi-targeted therapy. The multi-targeted therapy, that is is better than the IV cyclophosphamide. And very recently published tacrolimus, as initially it has been published 2 or 3 months back this year. It has been shown that the tacrolimus, it compares with IV cyclophosphamide, is almost similar. It appears to be the difference is more, but this is not statistically significant. So this is almost, it was published in JAMA Network very recently, about 2 or 3 months back. Lupus nephritis assessment with rituximab, the LUNAR study, this was a failure study because this rituximab was added to the usual treatment of MMF, but the differences in both the groups are not similar. So MMF, so the rituximab, there is no sufficient data to use as the initial therapy. But in some cases, rituximab is being used with other drugs as a resistant cases or treatment failure cases. I'm not going into the abatacept because it is not effective. Maintenance treatment. Up to 50% of patients with proliferative nephritis following reduction of the therapy, they went into the relapse. The relapse rates ranges from 5 to 15% per 100 patients a year, with the average of approximately 8 per 100 patients. Thus, once a patient has attained a complete or partial response, immunosuppression is continued to maintain and response and decrease the risk of developing end-stage renal disease. So continuation or maintenance treatment is very much needed. Glucocorticoid maintenance, there is about the duration and dose, there is much controversy. I'm not going into the details. These are some studies that has been shown that the continuation of maintenance dose is needed, definitely, and immunosuppressive maintenance, anti-inflammatory maintenance and immunosuppressive maintenance. You see which one, azathioprine or MMF? Yes, both is equally effective. In maintained trial, it has been shown both are equally effective in maintaining the remission of the disease. It is important that the maintenance should be continued with lower doses of prednisolone. It's very important. Again, is important, the IV cyclophosphamide. Once upon a time, IV cyclophosphamide were given every month for around 1.5 years to 2 years. So they compared this IV cyclophosphamide maintenance with this mycophenolate and azathioprine. So these are the better than IV cyclophosphamide maintenance treatment. But maintenance is very important. So maintained trial, the follow-up, it was continued for 5 years. Again, very recently published one article that leflunomide might be effective as a maintenance treatment and which is equally effective as azathioprine. How long the maintenance treatment should be given? There is no such consensus, but usually around 3 years. But all the trials, it has been shown that it's 12 months to 36 months. But in some cases, depending on the case merit and the experience of the individual treating physician, it may be for a longer duration of time. I am now going to have some Bangladesh experiences. We, in our team, we are maintaining a lupus clinic, and we are treating lupus nephritis very regularly. In our, this is the patterns of organ involvement and outcomes in SLE patients. It was just published in our local journal. In renal, the outcome were very good with the treatment according to the international guidelines. Voclosporin, a novel calcineurin inhibitor, a phase 2 lupus nephritis study. Our team was involved in this study, and it has been published in 2018 in a Journal of Kidney and Transplant. And this is AURA LV study, and ultimately there were phase 3 trial, and these voclosporin are approved by FDA for the treatment of lupus nephritis. In some cases, the resistant cases of lupus nephritis, it is the lower doses which is more effective than the higher doses. And we, the Bangladeshi team, provide around 45 patients to this study. Another is ongoing study. Just I am sharing these as a just on the middle of our study is cyclophosphamide versus, it's a retrospective study around just I'm going into the results, cyclophosphamide and mofetil. In our experience, the overall remission is equal in both mycophenolate mofetil and cyclophosphamide. There are no superiority to any group, and complete remission and partial remission, all are equally effective. There are 2 deaths, one in cyclophosphamide group and one in mycophenolate mofetil group. So this is my experience and our team's experience in Bangladesh. So, Mr. Chairman, sirs, in conclusion, I would like to say that for patients with class 3 or class 4, lupus nephritis, mycophenolate mofetil 2 to 3 gram or low dose intravenous cyclophosphamide 500 milligram every 2 weeks for a total of 6 doses with pulsed glucocorticoids. Combination of MMF with calcineurin inhibitor is an alternative, particularly in nephrotic range proteinuria. To reduce cumulative glucocorticoid dose, the use of intravenous pulses, methylprednisolone followed by oral prednisolone for up to 4 weeks tapered less than 0.7, 0.5 milligram for up to 6 months. So if improvement after initial treatment is achieved, subsequent immunosuppression is recommended with either MMF or with low-dose prednisolone or azathioprine with low-dose prednisolone. So, Mr. Chairman, sir, thank you very much. Thank you, dear audience, for your patience hearing.
Thank you, sir, for a wonderful talk. I have a question for you. After the results of DAPA-CKD and EMPA-Kidney, would you like to add SGLT2 inhibitors in this non-diabetic lupus nephritis?
Yes, because with the advent of this SGLT2 inhibitor, in the era of medicine, it has been used, started with diabetes, then heart failure, then kidney disorders. So I think it's being approved for the use of SGLT2 inhibitor without having diabetes. So if any patient has got some sorts of high serum creatinine level, like 1.5 to 2.5, then definitely it might help, because proteinuria is the mainstay of presentation of lupus nephritis. So there might have some effect. And definitely I do agree with you that it can be something, might be very beneficial, and I think there are some trials is also going on, and it will be coming up very soon with maybe good results. Thank you very much.
Because in the EMPA-Kidney trial, there were some patients with lupus nephritis
Yes.
whom they had given, and they saw very good results.
Yes, yes.
Thank you, sir, very much.
So thank you, dear audience. Thank you very much.
So the floor is to the organizers.
Thank you, chairpersons, for giving us your precious time. And it's time for high tea. So I would like to request you all, so go for high tea, and after that, we will meet for the next session. Thank you.
Good evening to all of you. So we are here together for the inaugural ceremony of this annual conference of ACP India chapter. I would request Dr. Srinivas Murthy first to please escort our immediate past governor, Dr. Muruganathan sir, to the dais. Dr. Srinivas Murthy, are you here? Or I would request then Dr. Narsingh Verma sir to please escort Dr. Muruganathan sir. Dr. Srinivas Murthy sir, please, we are calling you. He has come. He has come. Sir, now I would request again Dr. Narsingh Verma sir to please escort Dr. Khan Abul Kalam Azad sir to the dais. Now I would request Governor ACP India chapter, Dr. Anuj Maheshwari, to please escort the chief guest of the evening, Dr. Tiffany Leong, to the dais. Now, as a customary and Indian tradition, every event is to be started with the lamp lighting. So I would request our esteemed guest of today's evening to please proceed towards lamp lighting. Thank you all the guests of today's evening, and my salutations to Honorable ACP President Dr. Rian T. Meyer, Chair Dr. Sui Bonstein, Chair BOG Dr. Elisa Choi, ACP Ambassador Dr. Tiffany Leong, the chief guest of today's evening, the guest of honor Dr. Khan Abul Kalam Azad, our guide and mentor, past immediate governor, Dr. A. Muruganathan sir, the very dynamic with unmatched energy, Governor ACP India chapter, Dr. Anuj Maheshwari, and the very efficient secretary, Dr. Narsingh Verma sir, Dr. Srinivas Murthy, and all the esteemed guests of today's evening. The dream come has true that we are gathered here for the wonderful inaugural ceremony of annual conference of ACP India chapter. Now, I would request our ACP Governor, Dr. Anuj Maheshwari, to please deliver his welcome address.
Thank you, Dr. Divya. Honorable Chief Guest, Dr. Tiffany Leung, Honorable Guest of Honor, Dr. Khan Abul Kalam Azad, our immediate past Governor, Dr. A. Muruganathan, Dr. Narsingh Verma, our own Secretary of ACP India Chapter, and Dr. Srinivas Murthy, who has really worked very hard for making this conference success as an organizing secretary. Today I am having a great pleasure welcoming you all on this dais in 7th Annual Conference of American College of Physicians India Chapter. In my tenure, this is the second one. Although I am organizing the third conference, one conference I could get an opportunity to organize during the time of Dr. Muruganathan also. So in this 7th Congress of ACP India Chapter, I am seeing a lot of things are coming up and changing, and we are moving towards the goal of every person of India may get a good quality of medical care. It's not medical care, simply medical care. Our aim is the good quality medical care. We are also following the policy of inclusion of ACP. We are also trying to find out the groups which have been not included earlier in the good medical care, and we are also doing our best there also. In this endeavor, we have done a lot of work. We did good work for early career physician, for which we have been awarded with the John Tucker Evergreen Award by the ACP headquarters, that we have been given to our chapter in Chicago during the annual conference of the ACP. Followed by, for the first time, we have achieved the milestone of Gold Chapter Excellence Award. And now, yes, of course, you people should appreciate it. And now we are focusing on some other issues which has not been focused earlier or not seen to be focused. Like one is the women health and another is the medical students. Women health, we have started multiple things. Last year also we did a lot of projects for the women's health as well as cancer patients. Here in this year we started a very ambitious IRIS project with Rotary India, Rotary Foundation of India. And this project has done a lot of work, and you can see outside there is a collage in which in last 3-4 months, so many places we have done the women health screening camp as well as women awareness activities, school activities, as well as we have done the CMEs for the doctors. After that, we are also planning to make a early career physician council. We are also making a students council. A student council has already been made and it has already been announced. So it is my really great pleasure that today I can say that for the early career physician, for the students, we have made the separate councils. Then we have also prepared our own ACP India chapter website. Would like to show that website. You ready for that? Can I show, Sanchita? ACP website can be shown here? No. So, anyway. So, leave it. We can show some other time. So with these words, we are doing a lot of things. Everything cannot be explained here. I think some things would be told to you by our secretary also. So I welcome you all all the distinguished guests, all the delegates, all the faculties, those who have come from distant parts of the country as well as from the neighboring countries, as well as the people, those who have traveled a 18 hours journey from United States, Wendy, Dana, Dr. Tiffany. So I welcome them, everyone, whosoever is here. Thank you very much for being there.
Thank you, Dr. Anuj Maheshwari, for your always leading by example and for being a truly inspirational leader. Now I would request the very efficient and truly dedicated academician, Honorary Secretary, ACP India Chapter, Dr. Narsingh Verma, sir, for presenting Secretary's report for the year. Over to you, sir.
Dear friends, in the last 7-8 years, you have witnessed the growth of ACP India chapter. From specialties, and also, as Dr. Anuj was mentioning, reaching to students, general physicians, and even to the specialties, and holding more and more programs like women health, like he was talking about anemia, and similarly also nutrition. So most of the areas, starting from nutrition to special care, to elderly care, to even to the adolescent, every aspect has been covered, and we are trying to include more and more young physicians, residents, students, and also the caregivers who can be accommodated, and we can improve the healthcare system of my country. So we have been very active. Almost every week there was a program of ACP India chapter, and if I start naming all the programs, I think 1-2 hours will not be enough. So I'm not talking about what we have done in 1 year, but only mentioning that we have been very active. Almost every week we are having some virtual program and also physical programs in every big conferences of the India, including the RSSDI and other conferences. We are there, and most of the time ACP has its own presence, and ACP symposia has been organized in most of the conferences. So I was like just to mention here that we are very active and trying to make more and more friends, more members, and in the last 1 year, the membership drive and membership number has also increased enormously. Not only that, those who are members, they are retaining their membership, and if the society is doing something for them, then only they will retain their membership. So thank you very much. I will not take much time because I know that the inaugural ceremony has its own time, and I cannot talk and mention all the achievements of the ACP India chapter. Thank you very much.
Thank you, sir, for such an exhaustive report of excellent work done under the leadership of Dr. Anuj Maheshwari. Now, I would like to invite, and it's my proud privilege to invite none other than the President ACP, Dr. Ryan De Mayo. We are grateful to you, sir, for sparing your valuable time to join us virtually and to guide us. I would request the technical team to please play the recorded message of Dr. Ryan De Mayo.
Greetings. As president of the American College of Physicians, I would like to extend a warm welcome to each and every one of you as you embark upon your scientific chapter meeting for the India chapter. I would first like to thank the governor of the India chapter, Dr. Maheshwari, for your leadership. In addition, congratulations to the India chapter for 2022 being awarded the Chapter Excellence Award at the Gold Tier level, which is the highest level that a chapter can achieve. In addition to the Chapter Excellence, the India chapter has also been awarded the John Tooker Evergreen Award for its creative programming as it relates to targeting early career physicians. Dr. Maheshwari, you have created an environment of engagement and belonging within your chapter. The monthly webinars, the creative programming targeting early career physicians, topics that focus on women's health and wellness and belonging have been incredible to watch. I am very proud and pleased that I can share these thoughts and reflections with you today. Even for the learners and those in training, the India chapter has excelled in being awarded the Champions of the Doctor's Dilemma competition in 2021, and also sending representation to present in the abstract competition at the annual internal medicine meeting for ACP. I am honored to be able to share opening remarks for your meeting today. I wish I could be with you in person. As you can see, I have my stole that was bestowed upon me at the India reception at Internal Medicine Meeting 2022. And I have worn this with pride, and I wear it with pride today to show my gratitude for the hospitality that was bestowed upon me for attending that reception. I am honored to be your president, but more importantly, I am honored to represent our international members who have shown their value not only to the field of internal medicine, but to ACP. ACP is the professional home for internal medicine physicians across the world. We value each and every one of you. I extend my greetings and my sincere best wishes for a successful scientific meeting. Thank you.
Thank you, sir, for such encouraging and motivational words for us. Now, it's our honor to have Chair BOR, Dr. Sui Bornstein with us. I would request for his words of wisdom for all of us. Ma'am, excuse me, ma'am, please unmute yourself. She's unmuted. Technical team, please check. Can you please rectify the issue? What is the problem? We are really sorry, ma'am, for the technical glitch. Ma'am, please wait for a while. Ma'am, please, can you please speak a bit loudly? You are audible to us, but in a very low volume. she's not. Disconnected. No? Sanchita, what's the issue? Is there some issue with the connectivity or what? Okay. Connect her. Hello. Yeah, ma'am, you're not still audible to us. Sanchita, can you please, Sanchita? Meanwhile, can you check plus for Dr. Elisa? Meanwhile, Dr. Elisa. Check for Dr. Elisa.
We are getting voice here. Put it in the mouth.
Okay. Yeah.
You can talk now.
Hello. Hello.
Hello, good evening.
Ma'am?
Can you hear me?
Yeah. Am I audible to you, ma'am? Echo काफी है. Echo.
I can hear you. I also can hear you.
Okay. So I would request you, and it's again a great pleasure to have you with us, Dr. Elisa Choi. I would request you to please say your few words and request you to for your inaugural address. Over to you, Dr. Elisa.
Our global chapter are a key part of ACP's ability to connect our colleagues, not just nationally, but worldwide. And in that capacity, the ACP India chapter has really been leading the way. I wanted to close my comments by, again, congratulating you on a wonderful conference thus far. I will be speaking to you all shortly as well, but thank you for the opportunity to address you all. It is my deep honor and privilege to join you, albeit virtually, and I wanted to congratulate all of the program planners for this meeting. It looks absolutely spectacular and lots of learning to be involved. And with that, I thank you again for the opportunity to address you all and look forward to convening with you shortly later for my talk. Thank you.
Thank you, Dr. Elisa, for the kind words and for gracing the occasion. And I would again request Dr. Sui Bernstein to please say a few words, ma'am. We are really sorry again for the technical problem from our side.
Okay, so can you hear me now, though? Can you hear me now? Can you hear me?
Yes, ma'am, you are audible now.
Right.
Very well
okay,
audible.
Thank you for your patience. Well, greetings to the India chapter from me. I'm Sue Bornstein. I'm the chair of the ACP's Board of Regents this year. It is my honor to have been asked by Dr. Maheshwari to share some words of wisdom with you. So now more than ever before in history, the world is connected in ways that we did not even see possible a few years ago. Email, WhatsApp, Twitter, and other social media platforms allow us to share our lives and our work in real time. The college is greatly strengthened by learning from your chapter as well as our other international chapters. This is very much what we call a two-way street. As an example, I'll be talking with you later about the importance of vaccines, especially for women, as the foundation of the family unit. In preparing for that talk, I learned a great deal about the excellent work that's been done in India to eradicate polio and other communicable diseases, and to create, manufacture, and distribute life-saving vaccines in your country. So building and maintaining a public health infrastructure in your country, as vast as it is and as varied as it is something that we in the United States can learn from. And although our countries are thousands of miles and many time zones apart, we feel strongly connected to you in many ways, including seeing so many of you at ACP's annual internal medicine meeting every year. We are thrilled to be back in person for the internal medicine meeting and look forward to greeting many of you in San Diego in April. And even though our history and our cultures are quite distinct, it's clear that we have more in common than that which separates us. All of us want the ability to care for our patients with the knowledge, skill, and resources that they deserve. We want to be able to access diagnostic tools, medications, and medical consultants in a timely fashion. And when rules and regulations or lack of funding stand in the way of our caring for our patients, we must always advocate first and foremost for what our patients need. In this context, we can share each of our approaches to making sure that care is not delayed or denied. We look forward to continuing to work together with the India chapter members to fulfill the college's mission to enhance the quality and effectiveness of healthcare by fostering excellence and professionalism in the practice of medicine. In closing, thank you again for this opportunity, and I look forward to a wonderful meeting. Thanks very much.
Thank you, ma'am, for your encouraging words. And now is the time to invite the chief guest of today's evening, Honorable ACP Ambassador, Dr. Tiffany Lueng, for her pearls of wisdom. And I am overjoyed indeed that with unprecedented support and cooperation through professional guidance and encouragement, we all are here today to witness this vibrant and historical inaugural ceremony of ACP India Chapter Annual Conference. Over to you, ma'am, for your address.
So dear ACP India colleagues and friends, first of all, thank you very much for this honor, as well as your warm and generous welcome to your city. I'm honored to be invited to participate. Here? Yes? Okay, can you hear me better? All right, I'm honored to be invited to participate in this important annual meeting of the ACP India chapter, an event centered on learning, collegiality, and networking. I'm not sure what more I can add to Dr. Myers, Dr. Bornstein's, and Dr. Choi's wonderful remarks acknowledging the achievements of the ACP India chapter. Certainly, ACP India boasts an impressive membership and accomplishments already, from chapter awards to impactful programming, to staying ahead of the times in terms of contemporary issues in medical practice. Additionally, the focus on promoting diversity, equity, and inclusion is absolutely fantastic because it is indeed one of the strategic priorities of ACP. As an early career physician leader myself, I know how meaningful that these types of educational and professional development programming opportunities can have on one's career. When I was invited to join all of you here for this meeting, I was struck by the simplicity and the importance of the theme, Back to Basics. When faced with hardships, as we've experienced in these last years especially, there's nothing more reassuring than coming back to ground ourselves in what we know best. We are internal medicine physicians and specialists. We do surgery with our brains, as CEO and Executive Vice President Dr. Darylyn Moyer is often quoted as saying. To me, going back to basics also means seeking and nurturing connection, and that's with our patients, with their families, and not to be forgotten, with each other as well in our communities. In difficult times, we can and should have each other and our communities of practice to turn to for support, not only for the medical knowledge and skills that we can share with each other, but also for the emotional and psychological support of shared experiences. In going back to basics, as we learn from each other and we grow professionally and personally, I'm inspired by all of you here today. As a remark specifically for the trainees and early career physicians who also may be in the audience as well, I encourage you to make the most of this experience here during the annual meeting, networking, getting to know each other, and seeking out those meaningful mentorship and sponsorship relationships. Those connections can support your growth throughout your entire career. As the ACP campaign goes, I am proud to be here to join all of you on this special occasion. And so with gratitude, I thank Dr. Maheshwari, the conference organizers, and everyone who's here today and who's participating in this conference. You are the community of practice for internal medicine here in India. And I wish all of you a wonderful, inspirational, and energizing event, and look forward to joining you today as well as the next couple of days in celebration of all things internal medicine. Thank you very much.
Gratitude, ma'am, for your kind words. And now I would request the guest of honor of today's evening, Dr. Abul Kalam Azad, to say a few words of encouragement for all of us. Over to you, sir.
Good evening, Honorable Chief Guest of the session, and Honorable Your Excellency, Mr. President Governor, and immediate past Governor, and Mr. Organizing Secretary, and Secretary Scientific Committee of the session, and sitting in front, the faculty members, the speakers, teachers, and participants, and also representatives from the American College. My old friend, Dr. Wendy, and Dana, they are there. So, good evening, ladies and gentlemen. It's a matter of great honor and joy for me that I'm here among you in this 7th annual meeting IM SCP India 2022. I was fortunate for the last 3 years I could participate in the SCP India meeting, first in Calcutta and last year in hybrid meeting. And I was a speaker on the last session also. And I'd like to thank all the organizers of SCP India for inviting a big Bangladesh team at this meeting, and I'm very honored that because my past two governors, Professor Kazi Tariqul Islam and Professor H.M. Nazmul Hasan, they're also with us, and we have got other faculty members also. And we all are aware about the success of SCP India chapter after the inception of this chapter in India by the hands of Professor Muruganathan. He is a strong and capable enough leader, and he showed the way. And the same baton is being carried by Professor Anuj Maheshwari. I'd like to congratulate both of you for your strong leadership. And we know that we are together. The SAP is a global team. In America, and in India, in Bangladesh, or even in, suppose in Guatemala, Mexico, everywhere. It is a global team, and we put a great value on the development of physicians. That is our principal motto, through disseminating knowledge, and ultimately our goal is to serve humanity. I would like to show my gratitude to SAP for uniting us together and bringing the whole world under one umbrella, so that we are working together through sharing knowledge and values. SAP India chapter is acting as a role model for other chapters to accomplish the goals of SAP and setting newer milestones for us as time passes on. SAP India chapter has always been a friend to our chapter and extended their hand to support us in different activities and aspects. SAP Bangladesh chapter is grateful to you for your support and will be always there for you. This year the theme is Back to Basics. It is wonderful. As a clinical teacher, we understand what the meaning is, the basics, what basics are. And definitely we are the teachers. We follow William Osler, and our great teacher William Osler. He showed the way that yes, you have to go to the basics, not depending on this modern instrumental medical diagnosis. So also I listened to the theme lecture from Dr. Narasimha, who said beautifully about this theme. And this scientific program is really enriched by the young researchers. I found that so many articles are very interesting on many aspects. The recent development, the research work is going on in India. And it gave me an idea that yes, in every country of the world, there should be this type of research activities so that we can get some new information and we can implement in our future clinical services to the humanity, and also for doing better research in the coming years. So I believe that the topics are well chosen, and it will be effective for the future researchers to consider newer points from this type of your research activities in India. So finally, on behalf of Bangladesh chapter SCP, I like to say thank you very much SCP India, and I hope this will be a grand success. Thank you very much.
Thank you, sir. We are really overwhelmed and express our heartfelt thanks on behalf of the whole ACP India chapter for extending your valuable support for us and for your kind words of encouragement. Now, it's my proud privilege and honor to invite the person who has played a pivotal role in bringing ACP India chapter to this height, a truly inspiration leader, none other than Dr. Muruganathan, sir, the immediate past Governor, ACP India chapter. Over to you, sir.
The most lovable, affectionate brother, Governor Anuj Maheshwari, today's chief guest, Dr. Tiffany, guest of honor, Khan Abdul Kalam, organizing secretary, Srinivasa Murthy, scientific chairman, Narsingh Verma, my friends from ACP headquarters, Wendy Rivera, Dana, please stand up to be recognized. They have come all the way from ACP for ACP India chapter. And our friends from Bangladesh, Najmul Azan, Islam, please stand up to be recognized. They are all from Bangladesh. 15 of them have come. And our Sri Lankan friends, Srinivasan and Mageshwari, again, are they there? Sri Lanka. So what I'm trying to tell you, we have got international connections through ACP India chapter. We are showing the way. Anuj, I don't know why he asked me to bless the conference. He said 5 minutes to bless the conference. I'm really blessed to be asked by him to give the blessings to the ACP. So I'm really blessed. I invoke the blessings of the God. Why? I'm grateful to God for giving me so many friends, so many brothers and sisters. For so many people, everybody says I'm mentoring them. You know, they come and get my blessings. It's God's blessings for me. So I'm very lucky. So I walk in the space of gratitude where I get amazingly a very good family of medical fraternity, like my brother Anuj, my sisters Swati, then Anupa, then so many people are there, like Makkar, all my good friends, brothers, especially Nisha, a charming lady who is successful, who is behind the success of Anuj. So please, Nisha, please get up, you will be recognized also. So many people are there. So we form as a family. Now the family has extended. I know Elisa Chai, the Board of Governors chair, the Board of Regents chair. All of them are very good friends and really like our sisters. So we have combined everybody as a family in the ACP India chapter. So God has given that blessings for us. In everybody's life, there are 4 stages of life. One is called personal life, where you achieve your degree, your aims and your goals. The second one is called professional life. What do you do? What is your practice? You establish a hospital, you do a practice. That's professional life. The third one is called social life, where you do service. You do service to human beings and societies through so many other activities like Rotary, Lions, like, become the governor like ACP, then Srinivasa Murthy, like, chairman for, vice president for RSD. Like that, we become the leaders of various professionals. That we do social service, that's social life. The fourth one is called divine life. Successfully, I'm blessed. I have completed successfully all the 3 stages of life, and I've now become, I'm traveling in the divine life. That is why Anuj requested me to bless the conference. I think what Anuj said, I'm trying to justify why he has asked me to bless the conference. So I'm in the divine life. Friends, live truthfully. Show your love. Walk your talk. Dance and sing to your music. Take action to follow your dreams. Share your blessings. We are sitting in the Vizag. The rolling stones, the lasting tides, the rising sun, the shining stars, the whispering tunes, the joyous heart, the pleasing smiles, the divine blessings are all for you today and for every day. The God has given you gift of being the human beings, and also in ACP, that too in a successful ACP chapter, and that too in a place where we got so many good things, natural things are happening. And God is going to invoke blessings. I also invoke my blessings to Sweta and the Anuj Maheshwari team for getting Osles Cup again in this international conference. I think you must all give a good claps and bless this group to get the Osles Cup. We unfortunately lost T20 International Cricket Cup, but we will get Osles Cup compensating this wonderful ACP academic body. So I once again, really invoke the blessings of God and say, the God has given all of you a great grand gift. Accept it gratefully, and then love it and invest it wisely, creatively, and also enjoy it joyfully. Share the enthusiasm with everyone, and do all the good you can, to all the people you can, in all the ways you can, as long as you can. And God bless you, Godspeed, good luck. Thank you.
Thank you so much, sir, for such beautiful words. Now, I would request all the esteemed guests of today's evening to launch a book that is What Not to Miss in a Busy Medical OPD, written by Dr. Ashish Srivastava, who is a very active member of ACP India chapter, and he has 38 years of clinical experience. And I really tell you that this book is going to be helpful for all of us clinicians. So I would request all of you. Dr. Ashish, please come over the dais. Thank you, Dr. Ashish. Now, I would request Dr. Anuj Maheshwari, ACP India Chapter Governor, to felicitate the esteemed guest of today's evening, the chief guest and the guest of honor.
Before felicitation, one thing I would like to mention it here. Dr. Ashish is senior to me, much senior to me. In fact, he is senior to Professor Narsingh Verma also. And he has endeavored to write a book, in fact, for the basic things which we have forgotten. So I thought that our ACP member, who is doing such a good endeavor, for which we are choosing a theme of our conference, that back to basic, and he has written a book on that. So this must be released from ACP, and ACP should own this thing, what its members are doing. And probably this is the right way of encouraging our members to do some good work, to keep on doing this good work. A person who may not be known for writing a book, a person who may not be known for a very grand clinician, but he is doing such a good work. The ACP is recognizing that, is acknowledging that on its forum.
Dr. Anuj, please felicitate the guest of honor of today's evening, Dr. Abul Kalam. Thank you, Dr. Tiffany and Dr. Anuj. Now, I would request you to please felicitate the guest of honor, Dr. Abul Kalam. I again request Dr. Anuj to please felicitate immediate past Governor Dr. Muruganathan sir to please present a token of honor. I request Dr. Anuj again to felicitate Dr. Narsingh Verma sir. The very active honorary secretary of ACP India chapter. I request Dr. Anuj to please honor the very dynamic, very inspirational organizing secretary of ACP India Chapter Annual Conference, Dr. Srinivas Murthy. Now I would request Dr. Narsingh Verma sir to felicitate our Governor ACP India Chapter, the leader of leaders, Dr. Anuj Maheshwari. I would request all the guests to please stay for a moment for the launching of ACP India Chapter website. I would request our chief guest, Dr. Tiffany, to please launch the ACP India Chapter website at this moment. It's really a proud moment for all of us. Thank you, ma'am. Thank you so much. Now we have come to the end of this inaugural ceremony, and I would request the organizing secretary, Dr. Srinivas Murthy, to extend the formal vote of thanks for all of the guests of today's evening.
Thank you, Dr. Divya, for giving me this pleasant job of thanking everyone. I think I'll begin with our governor. Many of the international delegates do not know the meaning of Anuj is brother. Usually big brother we call Anuj, and he's literally been that to all of us. Most of us may not be in age, but with his advice and always keeping his hand and literally involved in everything. You know, he's jack of all and master of all. Literally, that is what I would say. And thanks for giving me the opportunity for second time being the organizing secretary in Goa. I think many people would have seen my hairstyle, and this time it is changed. Whatever was there, because of Anuj sir's drilling, I had to change my hairstyle on a lighter note. But that's what inspiration has been, and constantly at 12 o'clock, 5 o'clock, there's no timing to call or communicate. We've been doing a lot of things overnight for this conference, and we definitely feel overwhelmed for your support, people who have participated from across our neighboring countries, and that's something very, very pleasing. And we have about 1,300 online registrations, delegates who are watching us live from across the globe. I think that's something overwhelming. With over 450 registrations, physical registrations, I think that's something we have achieved, because that is what the delegates, I think you should give a big round of applause for all the delegates who have joined from Bangladesh and Sri Lanka. I think Bangladesh, we have been overwhelmed because they're literally our brothers and sisters, as in Muruganathan sir's language. So that is something we have been overwhelmed by their response and the way they have been supporting us from 2 days. I think that's something. Thank you, sir, for personal thanks from our end. And of course, all our delegates who have been there, apart from the destination. This is called the City of Destiny. I think that is what we had, all of us, to meet this post-COVID, because that's how people from US have come here. And we sincerely thank Dr. Tiffany, Wendy, and friends who have traveled all the way, because we had to travel to the other part because of the jet lag part, and still they are smiling and helping us to know about the ACP activities. And thank you, Dr. Tiffany, also taking time to travel all the way. I think this is the first physical conference they are attending, ACP chapter across the globe, and we are privileged to have them here. That's thanks again. I think you people can clap for them once more. Thank you. And of course, the faculty and the scientific session, what apart from the City of Destiny or the exotic destination, as many of us, our friends, colleagues have been telling that they're so impressed with the destination. I think it's the scientific content which is made 7 o'clock in the weekend to stay so many people. The hall is full, as you can see, for the inaugural ceremony. And that's something which is very, very pleasing. And all credit goes to Narsingh Verma sir, Anuba, and of course, Anuj sir, for putting up these great scientific sessions and involving all the Star Wars. We have stalwarts like Makkar sir, who is the president of RSSDI, Sanjay Agarwal sir, other members of RSSDI, and of course stalwarts including Kamlakar Tripathi sir, who is a Padma Shri, and of course Virmani sir, senior physicians, and of course young friends. We are council members also, and we sincerely thank the uninterrupted support from our council members. I would say unrestricted support, not uninterrupted. That gives a different meaning, I guess. Of course, they didn't trouble us much whenever we proposed something, and they've been taking care of various halls, and we sincerely thank for that, filling up in the gaps. And of course, delegates who have taken pain to travel. Some of our friends have traveled 12 hours to reach this destination because they don't have a connecting flight, and that's we sincerely appreciate. Of course, the AV, audiovisual, though we had initial itches, I think we sincerely thank them. The hotel, the Novotel, we've been very kind to accommodate us, and last minute changes they're accepting. And of course, the meals, the local Andhra flavor, what all of us are tasting from yesterday, and it will continue till Sunday. And of course, the concept who've been led by Ashish, Sanchita, Saurabh, others in the team, we sincerely thank for their efforts. And last but not the least, the pharma friends who've been supporting us, though in difficult times, with whatever the maximum support they could stretch, and that is how we are comfortably doing this. We sincerely acknowledge their support. And if I have forgotten anybody, my sincere apologies, it is nothing intentional. We definitely enjoy. Sir, anybody else? Anuj sir will interfere here also and tell that you have not taken their name. So I'm asking him in the open dais, sir, you tell me, don't scold me later. On a lighter note.
You have not taken my name.
No, sir, I used your adjective, brothers and sisters.
I'm just joking.
That was in the beginning only. I said Muruganathan sir's language, brothers and sisters from Bangladesh and Sri Lanka. So obviously, sir is always there, guiding force behind the whatever our efforts, and he's always there to give us advice. That's his greatness. We sincerely acknowledge, sir. Thank you for everything. And anybody else, if I've forgotten, it's not personal. Please don't take it personal. I apologize before I close, and please enjoy the next 1.5 days. We still have the sessions, still have the scientific sessions. Of course, the destination also you can explore, but please be present in the halls, enjoy the scientific updates, and as they say in the aircraft, sit back, relax, and enjoy your rest of journey for 1.5 days. Thank you very much again.
Dr. Alisa Choi and Bornstein is waiting for their scientific lecture. We are already 15 minutes late, so better we should complete our program, and we should come on the front so that we can listen both the speakers, those who are waiting there. So we'll request all of you to join me in here.
Thank you very much. She's very early in the morning. Officially, you can say to her that she should. No, it's very early in the morning. Thank you
so much, sir. I would request every one of you to please stand up for the national anthem. जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मागे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे जय
স্পিকারদের সম্বন্ধে বলার জন্য কিছু আছে? হ্যাঁ, না, কিন্তু তার সম্বন্ধে বলার কিছু আছে? ওনার সিভি সম্বন্ধে দু একটা লাইন বলার জন্য কিছু আছে? ইন্ট্রোডাক্টরি স্লাইড। Good evening, everybody. We are starting our next session. In this session, we will have two presentations. One is recent advances in the HIV management. This will be presented by Elijah Choi. He is Chair Board of Governors of ACP, and another is Women's Health and Vaccines. And I am now requesting Elijah Choi. Before that, I will say some lines, sentences on Elijah Choi. First, I will say I belong to his batch, that is BOG 2022. She graduated from Stanford University and Medical School, University of Medicine and Dentistry of New Jersey. And she did her residency from Boston, board certificate from American Board of Internal Medicine, and she also received fellowship from Boston, and she is a faculty of Harvard Medical School, Boston. May I now request Elijah Choi for her topic, Recent Advances in the HIV Management. Elijah Choi, please.
Thank you so much, Professor Hassan. And I am going to share my screen. And let me just... Please bear with me as I share my screen. All right. Well, thank you so much, everybody. Wonderful to see you on Zoom. And again, I so wish I could be there with you all in person, but I'm delighted to be able to share with you a topic on recent advances in HIV management. Before I start, I wanted to acknowledge that this is quite a large topic and quite a broad topic. And what I was hoping to do in my brief time talking about this with all of you is to hit on points that will be helpful for all of us who are internal medicine physicians, even if we are not HIV specialists or are not infectious disease specialists. And with that, I wanted to move on and indicate I have no financial relationships to disclose and no conflicts of interest related to this talk. And several of the learning objectives will be to have a better understanding of HIV and particularly the epidemiology as it relates to India, and also to discuss HIV prevention and diagnosis, as well as HIV treatment, again, with the anchoring of all of this towards what the general internal medicine physician may need to know. And ultimately, as currently HIV is in fact a chronic disease, how to manage HIV and patients who are living with HIV. So let me first start by giving a little bit of epidemiologic background. So India does in fact have quite a number of people who are living with HIV. And from this data that I accessed from an online resource, there's upwards of 2.4 million people in India who may be living with HIV. However, I wanted to put that in context. Although India is one of the most populated countries to have such a high burden of HIV disease, in terms of the actual prevalence of HIV relative to other countries, it's fairly low. And in fact, out of the top 140 countries or so that have high number of HIV. India is approximately 90th, and its prevalence of HIV is approximately 0.2%. So it's in a large country such as yourselves, it is still a large burden of HIV infection, but it is not as common as it might be in some countries where, for example, South Africa has a prevalence of greater than 17% of its population having HIV. One other point to mention is that there's still a substantial amount of new infections that are happening, and there's also, unfortunately, a significant number of deaths related to HIV. There is also, fortunately, and I'll talk about this in a little bit, a good number of people living with HIV on antiretrovirals, but not quite at the level that we would all like that to be. So here's some more information, and I put this in a pictorial representation to show that somewhere on order of 2.3 or 2.4 million people currently in India are living with HIV, and women make up a little less than half of that, with about 1 million. As you can see here, the numbers are a little different than the previous slide, but there's still a substantial number of new infections and, unfortunately, deaths still occurring. Now, what's interesting about the epidemiology of HIV in India is that out of the percentage of new infections, approximately 2/3 of those are occurring only in 10 different states, as outlined here on the left. And more than 3/4 of the people living with HIV in India also are limited to these 10 states here. So while there's a large number and a significant burden of HIV illness in India, it is concentrated in a smaller number of states. This epidemiologic graph also shows that the majority of the states in India are actually showing a decrease in HIV new infections over the past decade from 2010 to 2019, with the exception of several states here. Now, this particular graph is important to note that the vast majority of the route of transmission of HIV in India occurs through heterosexual transmission. There are other modes of transmission, but as you can see, those are much less proportionally important in terms of the route of transmission. There's some percentage of injection drug use, some percentage through blood and blood products, and other sexual transmission that is not heterosexual is noted, and also some perinatal transmission. But the vast majority of cases of HIV arising in India do occur through heterosexual transmission. Now, this particular graph I show to highlight what you see here in the green is the number of people with HIV who are on antiretroviral therapy. And at the very top is the graph, the line graph, showing how many people living with HIV. The numbers are a little blurred on the graph, but really the takeaway message is there is still a gap between what we would like to see, which is approximately 90 to 95% of the people who are living with HIV actually being placed on antiretroviral therapy. And in fact, the World Health Organization has a goal of 90-90-90, which is 90% of the people with HIV being diagnosed, 90% of those who are diagnosed with HIV getting antiretroviral therapy, and 90% of HIV being undetectable. So we have a little bit of a gap to go in India, although the really positive attribute here is that you see a steady, continued incline in the number of people living with HIV who are on antiretroviral therapy. Now, for those who are not HIV specialists, I don't want this very busy table to get you worried. I'm going to be speaking in broad strokes about what you need to know regarding HIV treatment. But before talking about treatment, I wanted to actually speak to you about HIV prevention. And in the red arrows here are 3 different drugs that currently in the United States and in the global HIV community are available for anti-HIV prevention, or otherwise known as pre-exposure prophylaxis. I will add from this table, this is pointing to carbotegravir, which is an integrase strand inhibitor, but it is the injectable form which is used for HIV prevention. And the other two medications that are currently utilized for HIV pre-exposure prophylaxis are Truvada and Descovy, as noted here. So let me talk a little bit about HIV prevention. And what we currently have are most typically oral medications, the Truvada as noted here, and also the Descovy as noted, which are utilized to prevent HIV infection. Due to time, I won't be going into very much detail about the studies that supported this, but suffice to say that both of these treatments are actually very effective in prevention of HIV. Particular related to Truvada, it is available to use most commonly in a daily medication regimen. There are less approved regimens such as on-demand HIV prevention, but by and large, the most common approach is for a daily pill to be taken to prevent HIV infection. One thing to note, though, is that although this medication is good at preventing HIV in sexual transmission and also in other forms of transmission, there is no effect in this medication in preventing other sexually transmitted infections. So that is something, as a general internal medicine physician, we need to be aware of, so that when we are counseling our patients, we also counsel them that while this may be preventing HIV, it has no effect on preventing other infections that often transmit along with HIV. Now, in terms of the next medication, which is Descovy, this is fairly similar to Truvada, with the note that the Descovy actually has a slightly different type of tenofovir formulation, this one being tenofovir alafenamide, and this tenofovir is much less toxic to the kidney and causes less in the way of longer-term bone toxicity. Similar to the previous HIV prevention medication, though, this is also similarly taken by mouth once a day and most typically on a daily basis. The other thing to note, though, what is different about this medication currently is while Truvada is accessible and available for both heterosexual and transmission from men who have sex with men, for Descovy, currently at this time, it is really only available for the latter, and the studies have not supported its broadened use for heterosexual vaginal sexual transmission. Now, this is a slide I wanted to put up, adapted from our ACP journal, Annals of Internal Medicine, to show that for those of us as internal medicine physicians, if we are going to be managing our patients to try and prevent HIV through the utilization of HIV pre-exposure prophylaxis, there is a cadence to which certain laboratories should be checked, and also a cadence to which we should be seeing our patients who are on these medications. I won't go through this in a lot of detail, but just to say that at the initial visit of seeing somebody who is on one of the oral pre-exposure prophylaxis medications, these laboratories should be obtained, and then at every 3 to 6 to 9 months, and on every 3-month basis, I should say, there are certain tests that should be checked. And what you see here is the categories of the risk factor for HIV transmission, which shows which tests should be utilized at those cadences. And so MSM, just to walk you through some of the abbreviations, is for patients who are HIV pre-exposure prophylaxis receiving, who are men who have sex with men. TGW are transgender women. And PWID are people who inject drugs. And you can see that currently the way we practice this, we see our patients every 3 months and we make sure that we are checking HIV and confirming negative results before we continue, because the Truvada or the Descovy alone would be insufficient for actual HIV treatment. Now, what about a new recent advance in pre-exposure prophylaxis? We do have now a longer acting carbotegravir, which is utilized in an injectable form as pre-exposure prophylaxis. And this was most effectively demonstrated in the study that is referenced here from the New England Journal of Medicine, which was fairly recently published. And based on largely the strength of this data, carbotegravir long-acting injectable is now also available for use as pre-exposure prophylaxis. A couple caveats there, though, is that it is limited to individuals of a certain weight. They need to weigh at least 35 kilograms, and it is available currently in at-risk adults and adolescents for use. Similar to the chart I adapted from Annals of Internal Medicine for oral pre-exposure prophylaxis, I wanted to indicate that there are similar labs that will also be obtained at a cadence that will be dictated by approximately every 2 to 3 months for the injectable pre-exposure prophylaxis. Now, I wanted to shift gears a little bit and talk about HIV testing. And this may be something that is familiar to many of you, but this is the time course of when certain tests will potentially turn positive with the onset of HIV infection. So what you see here at the bottom, though, in the legend is which type of testing would start to turn positive depending on the time frame from the onset of infection. And importantly, the earliest detection of HIV can be accomplished through nucleic acid amplification testing or viral load testing. Soon after, a combination antigen and antibody testing can then also help confirm a diagnosis. And further down and much less early in the time course, strictly antibody testing can confirm HIV testing and Western blot. Now, what I will add is that we typically don't use Western blot anymore. And here is, again, adapted from Annals, the current testing schema that we often use. And so initially, with a 4th generation HIV immunoassay, which is a combination of antigen and antibody, that is typically what we use. And just to go back and show you, that actually can detect HIV still fairly early within the first 1.5 to 2 weeks. So depending on whether that is non-reactive, if it's non-reactive, the testing stops there. If that initial test is reactive, then there's a differentiation immunoassay, which helps to differentiate whether it is HIV-1 or HIV-2. And then further, if it is either negative on this differentiation immunoassay or if it's indeterminate, at that point, then the next step that will be triggered for testing would be the direct viral load. So going back to this schema, emphasizing here that currently at this juncture, we don't use Western blot, and the typical scheme for HIV testing for diagnosis is in fact a 4th generation assay that utilizes the early peaking of the antigen in addition to testing for antibody. If there is suspicion that even that early window might be missed, then the best test to try and diagnose HIV is in fact a molecular test for a viral load, which can detect HIV as early as within about 1.5 weeks to 2 weeks. So back to treatment now. Again, I had reiterated that the focus of the talk today is not to have us know every single medication in detail, because truly there are so many of them. At this juncture, there is nearly 40 different antiretroviral HIV treating medications, but the general principles is what you want to keep in mind. I will add there are at least approximately 10 medications which are HIV medications, but we hardly ever use in practice anymore, largely due to some of the significant toxicities and newer agents that have better ease of administration and a much less toxic side effect profile. So one thing to take away, though, is with recent data, including a trial called the SMART trial, the goal is to start treating HIV as soon as possible and as early as possible. There was a lot of thinking in the past that maybe one can be observed with untreated HIV infection, particularly if the patient is asymptomatic and not having a significant decline in CD4 count, but we now have better understanding that there's little benefit to waiting, and there's much to be gained in preventing the decline of the immune system by starting antiretroviral treatment as early as possible. And the drugs that you see here are almost all oral medications. There are a couple injectable medications, including the carbotegravir that is co-formulated with rilpivirine, known as Carbinuva, which is an injectable medication, and also another medication that you see here. And I will add that Carbinuva in particular is becoming more commonly used in most of the initial or early regimens. So what about the general takeaways that we need to know as internal medicine physicians who are not HIV specialists? So first, I will add that before starting or contemplating starting any HIV medications, certain labs ought to be obtained in your patients, including some baseline safety labs, hemogram, kidney function, checking a urinalysis, also potentially checking other labs that are metabolic labs that we would screen for. But the goal, again, is start as early as you can. There are certain tests, though, one should definitely check depending on which antiretroviral treatment you decide to pursue. One test that ought to be checked is if you're contemplating abacavir as part of an HIV treatment regimen, to make sure that you check HLA B5701, because those who have that particular genetic conformation will have significant risk of hypersensitivity to abacavir. So back to this guidance, which is from the most up-to-date clinical guidelines for HIV treatment in adults. The main goal is, assuming that people who have HIV have not had HIV breakthrough on previous carbotegravir as pre-exposure prophylaxis, the current general guidelines are to consider an initial HIV regimen with the integrase inhibitor bictegravir co-formulated with a nucleotide analog, the tenofovir, along with a nucleoside analog, emtricitabine or FTC. Similarly, you could also use a different integrase inhibitor, dolutegravir, and you can use a different nucleoside, abacavir, along with 3TC. So general principle for an initial regimen on someone who is newly diagnosed with HIV after getting safety labs, one also should make sure to get genotype testing, and assuming the genotype testing does not show any sort of unusual resistance patterns, the goal is combination therapy always, and typically utilizing 2 nucleoside or nucleotide, as tenofovir is a nucleotide, along with a third agent that can be from one of these other classes of antiretrovirals, namely either integrase inhibitor or protease inhibitor or co-receptor inhibitors. So these are the specific regimens that are recommended currently based on that guiding principle. The one exception of using 3 treatment medications is a combination of dolutegravir and 3TC, which is potentially a recommended treatment with only 2 drugs unless the patient is newly diagnosed with very high viral load or has genotype resistance or has Hep B infection. And hepatitis B infection itself can have resistance develop. So in a fairly common scenario where HIV infected individuals are also co-infected with hepatitis B, one would want to make sure that there's at least 2 agents. So in this case, 3TC has hepatitis B activity, but that's not enough, and you would need combination therapy with this medication and at least one other. And one of those other medications could in fact be either the older version of tenofovir or the newer version of tenofovir. So in those more unusual circumstances where there might be breakthrough HIV infection in somebody who previously had been using pre-exposure prophylaxis with the long-acting carbotegravir, then there is an alternative regimen that is recommended. Again, 2 nucleosides, either FTC or 3TC, or a version of tenofovir. But in this case, the third medication would not, in fact, be the integrase inhibitor, and it would be a protease inhibitor. So those are some general principles of HIV treatment. What I will add, though, is certain situations you will want to actually refer your HIV-infected patients if you diagnose them as new infection in the case where they may have a very resistant genotype initial profile, or if they may present with HIV infection along with a co-infection, like, for example, tuberculosis, or if they have an opportunistic infection with which they present, or ultimately, if you feel because of comfort level, potential drug-drug interaction issues, or potentially side effect profile issues that you're not comfortable coming up with an initial regimen, by all means, then please do refer your patients to HIV specialists or infectious diseases specialists. So in my last portion of the talk, I wanted to talk about how you as an internal medicine physician, even if you are not an HIV specialist or an ID specialist, can help manage your chronically infected HIV patient. Because as I alluded to at the outset of my talk, we are really blessed at this juncture in our House of Medicine to have enough treatment options that with good adherence to these medications, our patients living with HIV can likely achieve undetectable viral loads and not succumb to opportunistic infection or to significant decline in immune function. I'm old enough to have been around and practiced taking care of HIV patients when that wasn't the case. And really at that point, 20 to 25 years ago, an HIV diagnosis almost was a death sentence. Fortunately, we have come a very long way. And now, in fact, HIV is viewed much like the management of chronic heart disease or diabetes or hypertension as a chronic illness that can be managed. So with that, our role as internal medicine physicians taking care of our chronically infected HIV patients largely follows the model of what we're all good at doing as internal medicine physicians, which is managing our chronic illnesses. So one aspect of that is recognizing certain vaccinations that should be administered to our patients who have chronic HIV infection. And I've spotlighted in this immunization chart in the red box, which are the vaccinations that really can be or should be administered to those with chronic HIV and ones that we should avoid. The key takeaway here is that the red colored vaccinations are those that are live attenuated vaccinations. And for most HIV infected patients, we would want to avoid those. Now, there are some special circumstances where if there was a significant need to vaccinate an HIV patient who is fairly or significantly immune reconstituted and has undetectable viral load, there may be the indication to vaccinate with some of these vaccinations, but certainly anybody who has advanced HIV or low CD4 count HIV, as evidenced in the second, or I should say the left-hand half of the box, those patients specifically would not even be eligible for things like MMR or varicella vaccination, and absolutely no indication for live attenuated influenza in anybody who has HIV infection, regardless of their immune status. Now, managing HIV infection in our chronically HIV infected individuals is almost its own talk in and of itself that could last an hour, but due to time, I will summarize very briefly here for what we as internal medicine physicians ought to be doing for our chronically HIV infected patients. One of which is we definitely want to be screening for various co-infections. Certain parts of Asia, and that is inclusive of India, there's a fairly high prevalence of tuberculosis. So for our HIV infected individuals, we absolutely want to be sure that we are screening for latent tuberculosis, and especially in parts of the world, such as in India, where there may be BCG vaccination, we specifically would want to be checking for latent TB through interferon gamma release assays, or IGRAs, such as TB T-spot or quantiferon. And hepatitis A infection is important to screen for because in certain populations of HIV infected individuals, particularly men who have sex with men, HIV and hepatitis A are often seen together. And it's also a vaccine preventable illness. So if the screening is negative, it can easily be prevented. Other screenings that should be undertaken in our HIV infected patients include testing for chronic hepatitis infections, particularly hepatitis B and C. And of note, hepatitis C now is curable with direct acting antiretroviral medications. Hepatitis B, unfortunately, is not curable, but there is a vaccine to prevent hepatitis B. So again, similar to Hep A, if it's checked for and discovered that the person is uninfected, they would want to be vaccinated. And remember that hepatitis B is also very prevalent in Asia and in Africa, and it is a cancer-causing virus. So vaccinating our uninfected patients who don't have hepatitis B will prevent hepatocellular carcinoma. Other infections that are sexually transmitted also need to be screened. And I will also add, for any of our patients for whom vaginal sexual transmission is the main mode of HIV infection, at initial outtake, trichomonas should be screened and then to be determined at some future cadence as needed. Now, there are some cancers that we want to screen for, cervical cancer certainly, and also breast, colon, prostate, and lung cancers, much like more standard ways to screen. But I will add, anal cancer is something that is particular to the domain of our chronically HIV infected patients. There in the US is not any one national standard for anal cancer screening, but various guidelines, including that from our Infectious Disease Society of America, do recommend in our HIV infected individuals who have exposure to receptive anal intercourse or genital warts or have dysplasia on cervical cancer testing should also be screened for anal cancer with anal pap screening. And then other chronic diseases, as I alluded to, HIV now, we get to the point where our patients are living with HIV and not dying from HIV. So other chronic conditions, as our HIV infected population ages, we'll start to see more more chronic conditions that are not HIV. So we would absolutely want to screen for diabetes, dyslipidemia, chronic kidney disease. And I will add, there is literature that suggests, and now guidance that recommends screening for diabetes, particularly in our HIV-infected patients who are on antiretrovirals, are best done by a fasting blood sugar, because there's literature to suggest that the hemoglobin A1C is not accurate, particularly in our patients who are on antiretroviral treatment. And I earlier had alluded to the importance of this particular HLA B5701 testing, particularly in thinking about whether to start abacavir as part of the initial regimen, and also consider screening for G6PD deficiency, especially if certain medications such as dapsone or sulfonamides are going to be used. The next two slides I'll mention really quickly related to chronic HIV and, of course, COVID-19, the current pandemic we are all facing. Now, one thing I will add is, at this juncture, there is no evidence to suggest that COVID-19 and HIV necessarily cause worsening COVID-19 infection. But it is important to note that even well-controlled HIV, those patients are technically immunocompromised. That being said, current guidance, at least in the US based on the CDC, suggests that our virally suppressed HIV patients who have immune reconstituted may not necessarily need an extra dose of primary COVID-19 vaccination, but they would have a need for that third or extra dose of COVID-19 mRNA primary vaccination if, in fact, they are less immune reconstituted or are immune suppressed due to HIV that is not well controlled and not virally suppressed. And then certainly in the US, as well as in other parts of the world, monkeypox had really been rearing its head and making a significant impact on patients. Those numbers have started to die down in the US, but I will add, for those who are HIV infected, there may be more severe presentations of monkeypox, and certainly those HIV infected individuals, if they have not been infected with monkeypox, would be eligible to get monkeypox vaccine, which is not that plentiful in the US currently, and would also have the potential for potentially more severe monkeypox if they are infected. So they would absolutely have an indication for receiving the monkeypox vaccine. So in closing, we have HIV is diagnosed, and we need that diagnosis before we can even manage HIV. In the US, it is considered a routine screening test. So adults up to age 64 should get a routine screen at least once in their lifetime. And those guidelines may not be quite as codified in India, but better understanding, particularly the epidemiology of HIV infection in India, will likely lead to the awareness that, particularly in certain states in India or in certain patients who may have higher risk of transmission, absolutely checking HIV and thinking about it will be important, and particularly in those with higher risk. Preventing HIV is incredibly important right now, and HIV pre-exposure prophylaxis, as well as other older tried and true measures, barrier protection, condoms, as well as other measures that will prevent the transmission of HIV will be continuing to be important. Due to time, I didn't speak a lot about post-exposure prophylaxis, but a drug regimen for those who may have either occupational or non-occupational HIV exposure is also a way to prevent HIV infection. The takeaway for all of you for treating HIV, we start early as we can. There is no need to wait and watch and monitor someone for untreated HIV. And for any special situations or complex drug management, please feel free to refer your patient with HIV to an HIV specialist. And finally, recognizing HIV is a chronic treatable condition. And so that is what we do. We are internal medicine physicians, ACP members, and we know how to manage chronic disease. So we can tap into those skills to flex our ability to manage our chronically HIV infected patients with all of our usual expertise, not just in HIV itself in terms of its management and follow-up, but also in managing its other comorbid conditions that we see in our HIV infected patients. And with that, I'm going to conclude and just say a word of thank you and just a throwback to April in Chicago when I had the absolute privilege to see Dr. Muruganathan and Dr. Maheshwari at the wonderful India chapter reception. And with that, thank you so much. I appreciate your attention.
Thank you, Dr. Elijah Choi, for your excellent presentation on a very vast disease. It is difficult to wrap up this disease within this limited time frame. We can have one or two questions on this topic.
I'll also be happy to answer questions afterwards if people want to get back in touch.
Dr. Elijah, I want to ask one question. What is the difference between the current management of HIV infection in USA and in countries like India or Bangladesh? Is there any difference? There should be any difference. But we have a national guideline in Bangladesh. I think India there should be a national guideline. We have a lot of challenges in the management of diseases like HIV infection. What is your opinion?
Yeah, thank you so much, Dr. Ashan. So many of the same guiding principles in that combination antiretroviral therapy is the name of the game. There's really no place at all, regardless of where the HIV infection is being treated, for anything other than combination therapy. And similar backbone is typically the name of the game. There may be nuances to which treatments are prioritized because of availability of antiretroviral therapy, but there should be, at minimum, 2 to 3 medications, more typically 3. And if desired, I can certainly circulate to Dr. Maheshwari the national guidelines for HIV treatment for ACP India that are available in India, and I can certainly look that up for Bangladesh. But in looking through the guidelines for India, there wasn't a lot more changes other than perhaps because of availability, certain initial regimens may be more more prioritized. But I will say what has been really wonderful about India, and congratulations to the India government for doing this, is that there is a national program in India that provides antiretroviral therapy for free to patients. And that has had some supply issues, but that is a tremendous asset to patients who have HIV infection. I happen to live in a state in the United States, in Massachusetts, that also provides HIV drug assistance. So nobody who has HIV will have to struggle with the cost, but the cost is often prohibitive for many of our patients. So for India, you have really done a wonderful job in the infrastructure in having a national program that actually supplies HIV antiretrovirals. And that was shown in the graph I showed earlier, that showed that really steep incline in the number of patients living with HIV who are on antiretroviral therapy in India. So congratulations to India and the infrastructure for that. But ultimately, though, Professor, it is less about significant differences. Much of the management is the same, including the antiretrovirals. It's really which ones, but the framework of how to choose is still the same, in that it is combination therapy, usually with 3 drugs. Thank you for the question.
Thank you, Dr. Meenakshi Bhattacharya. I came to know that you have a lot of experiences in the management of HIV in India. Do you have any comment on the difference in the management of HIV infection in India and USA? Madam, please.
Yeah, it was an excellent and exhaustive, elaborative speech, Dr. Eliza. Thank you so much for that, and thanks a lot for praising NACO, that is National AIDS Control Organization. I am a part of that organization by conducting our antiretroviral center. So whatever guidelines you just described, actually we all are following that, and I don't think there is much difference in management of HIV in US and India. Only thing is that the huge population what we cater, there are some restrictions for providing that medication to the huge number of population from India. So that is the major difference. Thanks a lot. Thank you so much.
Thank you for that comment. Very much appreciated.
Thank you. Thank you, Dr. Eliza Choi, for joining us with a far distance. I guess it is late night or early morning, and you must be sleepy at this time. So we now want to move to the next topic. Next topic is women's health and vaccine. I giving thanks now.
Thank you. Thank you, Dr. Elizabeth ma'am, for that excellent talk. And we move on to the next lecture. Here I would like to take the opportunity to thank our charismatic governor in India chapter, Dr. Anuj Maheshwari, and our secretary, beloved secretary, Dr. Narsingh Vermaji, for giving me this opportunity. And it's their way of elevating ordinary mortals. So we move on to the next topic, the next lecture. Yeah, we'll be talking on, the next talk is by Dr. Ms. Sue Bornstein, and ma'am will be talking on women's health and vaccines.
Thank you. Thank you so much. Can you hear me? Can you all hear me? Okay, I'm going to start. Well, greetings from the ACP again. And as chair of the ACP Board of Regents, it is my honor to have been asked to participate in the India ACP chapter meeting. I am indebted to your governor, Dr. Maheshwari, for the kind invitation. All of us at ACP appreciate the engagement of the India chapter and its excellent leadership. We especially appreciate how many of your members make the long journey to ACP's internal medicine meeting every year. And special thanks to Dr. Muruganathan for his commitment to this chapter and to ACP. And we look forward to seeing many of you in San Diego in April. And when I spoke with Dr. Maheshwari about the topic for this session, he suggested that I speak about the importance of immunization for women's health. I really loved that idea, especially when he told me that the theme of this year's conference is Back to Basics. And he stressed that women's health is pivotal for the whole family's health. And I would add, women's health is pivotal to the entire community. And I want to share a quote with you that I think will help frame our discussion. The impact of vaccination on the health of the world's peoples is hard to exaggerate. And with the exception of safe water, no other modality has had such a major effect on mortality reduction and population growth. And we at ACP are so proud of the India ACP chapter for its efforts to increase immunization through Project IRIS. So in my remarks, I'll briefly address the history of immunizations in India and then build the case for the importance of vaccination for all Indians with special emphasis on girls and women. So many of you probably know the history I'm about to share, but it really helped me understand better the scope of the work in India. So the process of inoculation or variolation with smallpox virus was widely practiced in India even in the 1700s. The first dose of smallpox vaccine in India arrived in May of 1802. And until the 1850s, the vaccine was imported from Great Britain, which certainly posed significant logistical challenges. Smallpox vaccine was successfully created in Chennai in 1880. And in 1892, the Compulsory Vaccine Act was passed. Cholera and plague vaccines began to be made in India, and in the late 1940s, the first of many BCG laboratories was created in Chennai as well. And in 1977, India was declared smallpox-free. So I highlight this story to show that India has a long history of vaccine and vaccine manufacture. So more recently, the World Health Organization launched the expanded program on immunization, which was launched in 1974, which India joined in 1978. It was renamed the Universal Immunization Program when it was expanded beyond urban areas, and in 1992 became part of the National Reproductive and Child Health Program. UIP is one of India's largest public health programs, targeting close to 26 million newborns and 29 million pregnant women annually. Those are amazing numbers. It's highly cost-effective, and it's largely responsible for the reduction in mortality rate in children under 5 years of age. And finally, two major milestones of UIP in India have been the elimination of polio in 2014 and maternal and neonatal tetanus in 2015. India has also launched the intensified mission Indradhanush 4.0 in phases in 2022 to achieve its goal of providing full immunization coverage of 90%, which is an amazing goal, and beyond to boost the reach of the universal immunization program. So now I'm going to turn to examine some of the benefits of vaccination. There are very obvious benefits to vaccination, but some may not be as obvious. So I'll start with the obvious ones first. The most significant impact of vaccines has been to prevent morbidity and mortality from serious infections that disproportionately affect children. Vaccines are estimated to prevent almost 6 million deaths per year and to save 386 million life years globally. So now we'll look at specific populations of women and immunization recommendations. This is not an exhaustive overview, but hopefully I'm highlighting some major important ones. So we all know that immunizations are an essential part of prenatal care. And in our country, in my country, the Centers for Disease Control and Prevention recommend that women who are pregnant receive an inactivated influenza and tetanus, diphtheria, acellular pertussis vaccine in every pregnancy. In the US, among women of reproductive age, pregnant women account for more than a quarter of flu-associated hospitalizations each season. So influenza can be a devastating disease for pregnant women because of the increased risk of fetal demise, preterm labor, and preterm birth. So influenza vaccination plays an important role in protecting pregnant women from serious illness. In addition, flu vaccination during pregnancy transfers antibodies to the fetus, helping to protect babies against flu before they're eligible for the vaccination at 6 months of age. And pertussis, as you know, can be a deadly infection for infants and children. In most cases, occur in infants less than 2 months old. Babies in this group account for 69% of pertussis deaths each year. But infants are not eligible for the first dose the pertussis-containing vaccine until they're 2 months of age. So as a result, newborns are best protected if their mothers receive a Tdap vaccine during pregnancy. Pregnant women should receive the pertussis vaccine during each pregnancy, as I've already said, and ideally between 27 and 36 weeks of gestation. And when a woman receives the vaccine, again, maternal antibodies are passed to the fetus, giving them a boost of protection at birth. And it's important to note that spouses, family members, and other folks in the household should also receive the Tdap vaccine if they haven't been vaccinated before. Pregnant and recently postpartum women are more likely to have severe COVID infection. A recent study from the National Institutes of Health in our country that looked at nearly 2,400 pregnant women who were infected with SARS-CoV-2, and they found that all those with moderate to severe infection were more likely to have a cesarean delivery, to deliver preterm, to die around the time of birth, or to experience illness from hypertensive disorders of pregnancy, postpartum hemorrhage, or from infection other than SARS-CoV-2. They were also more likely to lose the pregnancy or to have an infant die during the newborn period. Mild or asymptomatic infection was not associated with increased pregnancy loss. Therefore, the American College of Obstetrics and Gynecology and the ACP recommend that all pregnant women receive COVID-19 vaccination. It has been demonstrated over and over again that the vaccines are safe in pregnancy and can be administered at the same time as influenza and pertussis. Now, infection with rubella and measles virus can cause severe damage, especially in the first 12 weeks of gestation. So infection early in pregnancy is really associated with bad outcomes. However, rubella and measles vaccine is contraindicated in pregnancy because it's a live virus. So women planning pregnancy should be immunized prior to becoming pregnant, if at all possible. India has adopted the National Strategic Plan for Achieving and Sustaining Measles and Rubella Elimination in India. It's vaccinated over 324 million children. It's amazing. Between 2017 and 2020 through the MR vaccination campaign. And despite the challenges caused by the COVID pandemic, India has made remarkable progress in the elimination of measles and rubella. In addition, fever and rash surveillance were extended to all parts of the country, while MR laboratories network further expanded to include 27 laboratories. Other actions, including the strengthening of routine immunization during the pandemic, which is no small feat, again, including the vaccination of around 1 million children during IMI 3.0. So polio. Polio was eradicated in India in 2014. And the last case of wild-type polio was reported in January 2011. The routine immunizations and things like the National Immunization Days work to ensure that all children under 5 are vaccinated against polio. India simultaneously conducts acute flaccid paralysis surveillance to look for any signs of polio, as well as environmental surveillance. And in Kolkata, in April of this year, you probably are aware that one vaccine-related polio sample was recovered from sewage. And this set in motion an extensive evaluation, and fortunately, no other samples were found. Now, I want to contrast this with the situation in the United States. So the last case of polio in the US was reported in 1979. However, in June of this year, 2022, a case of paralytic polio occurred in an unvaccinated man in New York State. And genetic analysis showed that it was, in fact, vaccine-derived, so it was not wild type. And only then was wastewater surveillance launched, and 82 genetically related samples were identified. This episode confirms that the vigilance shown in India in your fight against polio and other deadly infectious diseases can serve and does serve as a model for other countries. And Dr. Choi talked about human papillomavirus, especially in HIV-positive people, but I have to tell you that I was so happy to read very recently that an Indian-made HPV vaccine called Cervavac has recently been released. This can be a game changer. Cervical cancer is the second most common cancer among Indian women, with 1.2 million women in India diagnosed every year, with 67,000 deaths from this disease. And since we know that human papillomavirus causes up to 90% of cervical and anal cancer, the availability of a low-cost vaccine, and this is estimated between 200 and 400 rupees, has great potential to reduce the burden of cervical cancer and other cancers associated with HPV. Cervavac will be administered in 2 doses among girls aged 9 to 14 and 3 doses for women and girls ages 15 to 26. Now, I might mention that in the United States, it is also recommended for boys. And so now I'm going to turn a little bit and talk about other benefits of vaccination. So in addition to preventing serious illness, disability, and death from infectious diseases, there are a number of other benefits to vaccination. Herd immunity. In herd immunity, there's indirect protection from an infectious disease that happens when a population is immune through vaccination or previous infection. Now, herd immunity for measles requires 93 to 95% of a population to be vaccinated with 2 doses to interrupt transmission of the measles virus. And for high-risk individuals, those who are immunocompromised, who have underlying serious medical conditions, who are unable to be vaccinated, herd immunity really can be a life-saving measure. Now you look, contrast, herd immunity for polio requires about 80% of the population to have immunity. We've also seen herd immunity against some GI viruses or GI illnesses, including cholera and rotavirus. We do not yet know the level of herd immunity required to protect a community against COVID-19. Dr. Choi talked a little bit about cancers associated with infectious diseases, and I touched on the benefit of HPV vaccine, but I want to also talk about hepatitis B vaccine. It can prevent chronic hep B infection, which can lead, as we know, to cirrhosis, hepatocellular carcinoma, and importantly, 70 to 90% of babies born to mothers who are hep B surface antigen and hep B core positive will become infected without prophylaxis. Hep B vaccine and immunoglobulins can be used to minimize vertical transmission. Now I'm going to talk a little bit about reduction in secondary infections that can complicate vaccine-preventable diseases. Vaccines can prevent diseases beyond the specific infection that they're designed to target. Infections with pathogens, in particular viruses, can predispose to the acquisition of other bacterial infections. For example, influenza virus vaccine, both seasonal and pandemic, is frequently complicated by bacterial pneumonia and acute otitis media, infrequently aspergillus pneumonia and pneumonitis. It is believed that during the influenza pandemic of 1918 and 19, secondary bacterial bronchopneumonia was strep pneumo, strep pyogenes, H. flu, and Staph aureus, identified at autopsy, really was likely the culprit for the excess mortality that was observed among healthy children and adults. And as we mentioned before, influenza vaccines can be beneficial in preventing these complications and also morbidity, including acute otitis media in children. There is increasing evidence supporting the use of influenza vaccine for the secondary prevention of myocardial infarction. Also, people who develop shingles are about 30% higher risk for stroke. So the use of herpes zoster vaccine has another benefit. And finally, it's been suggested that vaccination with pneumococcal vaccines is associated with a 50% decrease in the risk of myocardial infarction 2 years after vaccination. Another associated benefit of vaccination is preventing antibiotic resistance. As we are all aware, the rise in antimicrobial resistance is a universal threat. And the development of antimicrobial resistance in bacteria is a cumulative process, frequent repeated exposures to broad spectrum antibiotics as a major cause. Children and the elderly who are at particular risk of infection can and do benefit from vaccines against common primary and secondary infections such as pneumonia, otitis media, and cellulitis, secondary to varicella zoster, and typhoid fever. Vaccines alleviates the need for antibiotics being prescribed or bought. I'm going to turn now to talk about some of the economic benefits of vaccination. And vaccines are highly beneficial on a population level as well as an individual level. Also, they're very cost effective in comparison with other public health interventions. The reduction in morbidity and mortality associated with successful vaccine programs through a combination of direct and indirect protection has led to reduced incidence of diseases and associated treatments and healthcare costs. This potentially leads to economic growth with less money spent owing to the costs averted through fewer medical tests, procedures, treatments, and time off work by patients and parents as well. It's estimated that the net economic impact of eradication of disease has been estimated both for smallpox and polio. For smallpox, the eradication costs were over $100 million US, but there are cost savings of $1.35 billion US dollars annually. And the elimination of polio was estimated to save $1.5 billion US dollars annually. Extensive vaccinations in populations can and do reduce pressure on healthcare facilities, especially at the hospital level. And I can tell you that right now, as we're speaking in the United States, we're seeing our hospitals overwhelmed with children with respiratory syncytial virus, influenza, and still seeing some COVID. And unfortunately, there are currently no vaccines available in the US for RSV, but I understand that one is close to being released. So a healthy population contributes to and enhances the economy. Economic impact of vaccines really should be considered more broadly than just the avoided healthcare cost from prevented illness episodes. Healthy children demonstrate increased educational attainment through better attention and cognitive performance. And as a result of vaccinations, healthy and economically successful families have lower fertility and smaller families. Again, the economic impact of adult illness is evident from the loss of productivity and pay, at least for the duration of the illness and the recovery period. And unfortunately, the impact of childhood illness falls primarily on their adult caregivers, generally parents, since when a child is unwell with childhood illnesses, which may or may not require admission to the hospital, parent will invariably have to forego their paid employment to care for the child. The loss of productivity in the parental workforce tends to disproportionately affect women, but loss of either parental attendance at work has an effect of reducing overall income, productivity, and in the short term is rarely able to be replaced. Now I'm going to talk a bit about the social benefits of immunization. So we talk a lot about health equity, and health equity, we believe, is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Health inequities are reflected in differences in length of life, quality of life, rates of disease, disability and death, severity of disease, and access to treatment. And the impact of vaccines on the inequity of those living in poverty is significant. And modeling of the impact of the rotavirus vaccine in India across all social classes suggests that the vaccine program provides the poor with both health and financial benefits. It's really important to include such equity impacts in the health economic modeling of vaccines. And it will help better policy decisions to be made, which will target the most vulnerable in society. Finally, I do want to talk about the empowerment of women under a vaccine program. So the empowerment of women is a driver, and it's also an effective vaccination programs. And in a study in Bihar State in rural India involving an empowerment program where participating women were educated about health and hygiene, there was a higher rate of pertussis, measles, and BCG vaccines in their children compared to non-participants in the villages running the program. A separate public health initiative in Haryana, India, conducted between 2005 and 2012 to reduce maternal and child health inequalities involving increasing access and provision of health resources to rural areas, the poor in society, women and children. One significant outcome of this initiative was the equitable provision of immunizations to girls and boys. And I know that this is part of a project IRIS, really to focus on girls and women. And so by improving infant and childhood mortality from infection, more children will survive to adulthood with the potential to have productive and healthy lives. And this will and has led to healthy and economically secure women having fewer children and less peripartum morbidity and mortality. Thus, women are able to spend more time with children and on their development, as well as their own education and contribution to the workforce. So the strategy of maternal vaccination has demonstrated great success at preventing diseases that afflict infants too young to be vaccinated against pertussis, influenza, and tetanus. Not surprisingly, though, factors influencing uptake of maternal vaccination include what was the woman's previous experience with healthcare and vaccines. It's crucial to provide the access and support required to enable them to make informed choices during their pregnancies. So I hope that my comments serve to reinforce the far-reaching effects that vaccinations can have, especially on the health and welfare of the women and children in society. India has shown that it has the will and the dedication to eradicate communicable diseases and thus improve the status of all its citizens. I believe that you will continue to find successes despite the many challenges of delivering vaccinations in this vast country. So once again, congratulations on Project IRIS and all the work that you do, and thank you very much for this opportunity. Thank you.
Thank you, Dr. Su, ma'am, for an exhaustive. It was a delight listening to you. And,
Thank you.
Yeah, and it was an elaborate discussion on women's health and the vaccines, and you have touched upon all the important details. And if there are any questions, we are already delaying our honorable guest speakers. Are there any questions? Thank you. Thank you so much.
Thank you. It was my pleasure. Thanks again for asking me. Thank you.
thank you so much to the speakers and the chairperson for the session. And now I would invite the chairpersons of next session, Dr. Narsingh Verma sir and Dr. Khan Abul Kalam Azad, to invite the speakers for the next session. And the governor's address we are postponing for tomorrow. So this is Dr. Anuj Maheshwari's call.
Okay. Thank you, ladies and gentlemen. Good evening. Again, we had been waiting long for a wonderful speech, and it's none other than we'll have a great talk about cultivating well-being in the workplace. So that will be by Dr. Tiffany Leung. She is the Clinical Associate Professor, Department of Internal Medicine, Southern Illinois, and University School of Medicine, Internal Medicine Monthly Newsletter, AJM Forum, co-chair of the Women in American Medical Informatics Association, AMIA Steering Committee past chair of the American College of Physicians Council of Early Career Physicians. She is also co-executive producer of a podcast to promote diversity, equity, and inclusion in medicine called the DEI Shift. So if I can continue for the introduction of Dr. Tiffany Leung, but I think that it's already late in the evening. So I'll be requesting Dr. Tiffany Leung to start the process of talking on cultivating well-being in the workplace. Thank you.
Great, thank you so much. So just want to make some disclosures initially as we get started. Just to clarify, I am an adjunct clinical associate professor with SIU School of Medicine, although my primary affiliation actually is as a scientific editorial director for JMIR Publications. That being said, my affiliations today, the views and opinions that I express today in my presentation are my own and not representative of any of the affiliations or organizations that I am affiliated with. Thank you. Some of the slides today I'll also present are from materials that I helped to collect for the American College of Physicians with respect to promoting well-being and professional satisfaction. So what is resilience? When I hear resilience, it reminds me of the days when I studied biomedical engineering and material sciences. Some of you may be familiar with this concept already, but the idea that there is this sort of stress-strain curve on materials, but in this case we're actually talking about people, right? But that there are external stressors, external factors that contribute to or affect our well-being. We adapt to those strains, and then we keep going. But then what happens after that when the stresses become too much? So this is a nice summary of what happens at the end of that curve, of the stress-strain curve that I showed on the previous slide. The tragedy of adaptability is that people are the most adaptable element in any complex system. And healthcare systems are, of course, complex systems that we function within. And that adaptability is essential in making things work oftentimes, right? When we're working in our day-to-day practice, we often encounter scenarios that were unexpected or additional complications have arisen. But in both the ordinary and extraordinary circumstances, it's important to be adaptable. But that isn't always visible to outsiders. Additionally, that adaptability is finite, as we've experienced again during the COVID-19 pandemic. It often leads to workarounds that may lead to unforeseen risks of their own and often can't be sustained for prolonged periods of time. So what happens at the end of that stress-strain curve? You sort of saw it go up. There's the adaptability, the change, and then there's a certain point where it sort of tips down again. There's this sense that there's this perceived chain reaction between experiencing burnout, becoming clinically depressed, and then leading to worst case scenarios such as suicidal ideations and even suicide deaths. Here are numbers from US resident physicians. This is obviously, like I said, it's not a causative chain, but it's often one that we worry about a lot. And actually, I do look forward to the presentation tomorrow as well with regards to the study that has been done in this chapter, in the ACP India chapter around well-being, for partly this reason. Of course, this doesn't discount the fact that burnout rates are high among US residents. I imagine they may be the same here as well. Depression screens among residents also can be positive at a high rate. And yet, as you go on and further to suicidal ideations and suicide deaths, they become much more rare events. But each one is a tragedy. So what is resilience? I like this definition from Dr. Mukta Panda, who is our ACP Global Engagement Committee Chair. She is also a professor of medicine at University of Tennessee College of Medicine and an assistant dean for well-being and medical student education. She defines resilience as the ability to recharge, recover, to rise above, and to thrive in spite of all obstacles. And so part of this, I think, is the mindset that we sort of go into in the things that we encounter in our day-to-day, and then just over the course of our longitudinal career. What are the things that are within our control? That's sort of what you see here in the orange circle. What are the things you definitely cannot control, which is totally outside of the circles? And what are the things in the gray area? Those are the things that you can't control as of the current moment, but maybe you can influence. And I think a lot of this resiliency factor has to do with being able to identify that gray area of things where you know you can have an influence on either a division or department or clinic policy, or how resources are apportioned, or those sorts of things. Those can be incredibly valuable opportunities for you to have that empowerment and agency as an individual to identify and bring those things into that sphere of influence. So when I come back to this stress-strain curve that I showed earlier, obviously people are not materials, but the idea is there that people can adjust and adapt, and the idea is to do it in a healthy way. The other part too is then the interaction between the individual and the system that they function in. So for example, that I showed in the last one with the spheres of control, and that sort of gray area where this overlap is between the individual and the system. The system itself also has an aspect of resilience that can be designed into it, which I'm going to shift over to talking about a little bit more. Obviously, the idea is that individual well-being is important, and you can do things for yourself. Everybody has their different ways to be able to maintain their well-being. I'm not going to focus on that so much today because I think there are resources for that are available out there, and also on the ACP websites that you can reference for that too. So what is system resilience? So system can be resilient if it can adjust its functioning prior to, during, or following events. So those events can be changes, disturbances, or opportunities. And then sustain required operations under both the expected and unexpected conditions. And as you can imagine, there are different ways to think about how that influences the various levels of interaction. So you have society, community, organizational, and you're getting down into interpersonal interactions with each other in our communities of practice, and then also individual with each other individually, but also with our individual patients. So it's a little bit theoretical, but there's this balance when you're thinking about system resilience and the design of that resilience into the system. And when I say system, it can be, again, sort of department, it can be a whole healthcare system. But the idea is there's a balance between job demands and job resources. So the demands are the things that I think we all know very well in our day-to-day practice as internists. Those are the things like physiologic and psychological costs. There's also workload, time pressures. Maybe the responsibilities in your role, they can vary, or maybe sometimes they're not very clear. That can lead to conflict or ambiguity in the role that you're in. But what are the job resources that can balance those out? Those resources can include things about the job itself, about working as a physician, but also the workflows that you work with, the systems like the electronic health records or other things that are available to you in your day-to-day work, your tools. There's also an aspect of social support. So that can be support from others who are in your immediate environment, or support from others in settings like this, where you're meeting with people who are from other clinics and hospitals or regions of the country. So the idea here is that we want to balance those out and maybe make sure that those resources are properly matching the demands that you're experiencing in the setting that you work in or that you may be a leader of. The reason is that at the bottom there, you can see that when there are increased job demands with inadequate resources, that can drive burnout. But if you can bolster those resources and increase the control that one can have in the job space and the workplace, including especially the social supports, that can mitigate the effect of the high job demands and the driver of burnout. So what else can fall into that aspect of job resources and providing support in the workplace? That can include things like workplace safety. So I think the first one is pretty self-evident. Physical safety is an important one that we experienced certainly during the COVID-19 pandemic. Physical safety when it comes to occupational exposures to infectious disease, having proper personal protective equipment and other things. And then also physical safety, not only from environmental hazards because of the nature of the job, but also from other people. It's quite under-recognized, certainly in the United States, that workplace safety and workplace violence can be a major issue. And when I say workplace violence, that can mean violence from patients, family, and caregivers towards physicians and other healthcare professionals. But it can also include violence from peers and others who are also healthcare professionals towards us as well. So all of these factors are things that contribute to a sense of safety within the workplace. And lastly, there's psychological safety. I'm not going to go into a lot of detail about it, but it is important to be aware that psychological safety is also important. So what is it exactly? It's a climate in which people are comfortable expressing and being themselves. More specifically, when people have psychological safety in their work, they can feel comfortable sharing concerns and mistakes without a fear of embarrassment or retribution. And then they're confident that they can speak up, they won't feel humiliated, ignored, or blamed. And then they can ask questions, especially when they're unsure about something. You can imagine that having psychological safety also has its positive consequences, where that can contribute also to better patient care and outcomes and better quality of care. Another aspect of having that psychological safety is the hidden curriculum. The ACP actually has a position paper about this, which if you're interested in learning more about this, I encourage you to read it. It's particularly relevant if you are a medical educator as well. So what is the hidden curriculum? It's the positive and the negative lessons that are embedded into an organizational structure and culture. And they're often conveyed in medical schools, residency programs, hospitals, and clinics. So there can be positive and negative. What does that mean? So positive role models reinforce the character and the values that our profession as internists seeks to cultivate. But the negative ones are the ones we want to mitigate and reduce. So those are the ones that directly contradict classroom lessons and expectations of patient, society, and medical educators. So what else can we do other than being positive role models and ensure that we're passing on a positive hidden curriculum? Well, I mentioned before about the interpersonal aspect of having workplace safety in our own environments with each other. And part of that means both being self-aware about your own well-being, but potentially being aware of warning signs or signs of distress that you observe in your peers. That can be incredibly important and helpful to provide that extra social support and job resource to your colleagues who are in your workspace. So what are some of the signs of distress that you can see? Some of these are listed here. And I also include the suicide warning signs. This is from the American Foundation for Suicide Prevention because I think they're often underestimated and overlooked. It's very easy to skip over it, let's say if you're in a busy hospital ward day or that sort of thing. But it can be incredibly helpful and important to be able to acknowledge when your peer is in distress and to be supportive of them when you observe signs that you're concerned about. And so what can you do when a peer is in distress? These are also from the American Foundation of Suicide Prevention. What can you do is to be able to find the time to talk to a colleague in a quiet setting and to be able to listen actively and without judgment. It is always important in such settings in interacting with colleagues And I say colleagues, but it also includes, for example, students or residents who you may mentor. It's important to also reserve making solutions. So as internists, our day-to-day involves treating patients, so diagnosing them, complex puzzles, coming up with solutions and treatments for them. In these cases, reserving the solution is actually very important to be able to hear and validate what the experience is of a peer who may be in distress. And then encourage them to seek treatment. So that is also an important part of the process, where if you are concerned, to address directly if you are concerned about them, for example, having suicidal ideation or being in an acute mental health crisis, and then facilitating them to reach the help that they may need. So everything I've sort of said went from the individual level of resilience to sort of system level resilience, and then sort of what you can do within the workplace yourself immediately to pay attention to. Naturally, we work in teams. We don't work in isolation in providing care to the patients that we see from day to day. So when we think about successful teams, some of what I already discussed already contributes to that. Successful teams, they have a clear and compelling purpose or goal. They have an enabling social structure and the job resources, as I mentioned, that facilitate teamwork. And the teamwork and respect for colleagues must both be taught and demonstrated. So again, going back to hidden curriculum aspect, we want to promote that positive hidden curriculum. Well, ideally it would be more explicit than that, but a positive influence on the curriculum to encourage our learners to be able to adopt this sort of teamwork mindset. And lastly, the learning environment should be psychologically safe. It should foster respect, inquiry, and honesty, and empower people to be able to raise concerns that they see. So to cultivate well-being in the workplace, so in summary, resilience is not only a characteristic of an individual physician, clinician, or learner, and personal strategies for growth and self and situational awareness can be a good foundation, but we cannot rely on the individual adaptability of individual physicians and learners. We must be able to implement and design institutional strategies like supporting the job resources, as I mentioned. Additionally, we can expand our job resources beyond our own immediate work and learning environments. So again, coming back to spaces like this, where you're assembling from a variety of different locations, specialties, and workplaces, this also, coming here to this annual meeting, is and can be a place to be able to expand your resources. And then sometimes going back to basics, as is the theme of this meeting, is that may just mean being present for someone else, a peer or a colleague, when they're in distress or crisis. So I just want to leave for those who are sort of on the early career, more trainee side, a few suggestions for how to proceed in advancing your career and professional growth. Some of this may also be very helpful for anyone who's mid-career or advanced stage career, as just a reminder. To be able to build those networks and resources, getting connected, growing your networks, gaining perspective, generating new ideas, and giving back are all ways to contribute to this community of practice that we have here in this chapter, but also throughout the ACP network and beyond. What does that mean? Getting connected, finding mentors and sponsors. So mentors can give you the guidance in the work that you do in sort of your career direction. Sponsors are the ones who advocate for their sponsees or proteges and sort of bring them up with them by being influential leaders. Growing your networks, like again here in a professional society that can expand your resource pool, and having it be your professional home is a place to be able to make those connections, as in the slide just preceding. Gaining perspective and knowledge. I am learning already today as I'm here about, for example, the lamp lighting ritual, which was wonderful to participate in during the inaugural ceremony. But being able to expand your perspective and your knowledge across the world and about what else is going on in the world of internal medicine is incredibly valuable, enriching, and just very gratifying to experience. Generating new ideas. The new ideas can come from grassroots. Oftentimes, I think that trainees and residents, they have a lot to contribute to our societies and our activities. And being able to actively participate in those committees, councils, and other initiatives that can be a very important part of career growth and development. The QR code is just a resource there for the IM Power ACP resources for residents. And the link is also at the bottom as well. And then lastly, give back. So a lot of you here today are already doing that by being leaders in the spaces where you are, by teaching, by mentoring, and maybe even already sponsoring some of your trainees as well. So I'm gonna stop it there and hopefully get us just a teeny tiny bit back on track in terms of time, but I'm happy to talk about any of these aspects in a little more detail or take any questions. Thank you so much for your attention.
Thank you. Thank you, Dr. Tiffany, for giving this wonderful idea. And I think this is unique about ACP. And I know it because I have been well-being champion once. So I know that how ACP is serious about this well-being campaign. So you have beautifully told everything what we can do about our peers. But definitely, every situation needs some different approach. Any questions from the audience? Those who are interested to know more about well-being? If there is no question, I think everybody is satisfied what you have delivered. Thank you. Thank you very much.
Thank you very much.
So next talk will be by about three-dimensional healthcare. Three-dimensional healthcare. And this will be taken by Professor Amod Kumar Sachan. Professor Amod Kumar Sachan is Professor Head, Department of Pharmacology at King George Medical University. And sir can talk very well about this three-dimensional healthcare because I have seen his journey from a clinic to a nursing home to 2 medical colleges and rather 3 medical colleges. So he is owning 2 medical colleges. He is working in Medical University, 110-year-old medical college, and he knows what is the healthcare and how the healthcare in India can change. And he will be talking about this three-dimensional healthcare. Welcome, Professor Amod Kumar Sachan. I can introduce him for half an hour, 1 hour, but I think he will, by delivering his lecture, you will know more about it.
Thank you, Dr. Narsingh. Today, I will go to a special journey, which in due course of time, with the development in all spheres, we have forgotten. On this earth, we got, after this birth, such a wonderful body. And this wonderful body works through its software. The best computer ever evolved is this human body. And the best software is the human mind. Whenever we purchase any gadget, we always see that what all is there in that gadget, what all those apps are there, we try to download them, try to find out each and everything, and then ultimately we try to use it optimally. But such a wonderful gift given by the God to us, we have forgotten everything, and we have started searching things here and there. Today, I am trying to show you those things which really will help you in understanding these things. The current scenario is that it is a single dimensional. What does this mean? Currently, more emphasis is on treating the symptoms or the removing the effect of the disease. For example, if somebody is suffering with hypertension, we'll be treating with the antihypertensive drugs. If there is a diabetes, we'll be treating with the diabetes. If there is an infection, then we'll be treating with the antibiotics or antivirals. For that matter, whatever is the outcome, we try to treat that outcome. The three-dimensional healthcare, we have to understand that it is defined as the treatment that not only includes the body, but also it includes the mind and the soul. And what is all about it? Actually, this soul is nothing but the energy flowing inside our body. And this energy flowing inside our body in each and every organ at a cellular level. This is the life-sustaining force that is maintaining the homeostasis in our body. We're talking about these things. What is the definition of health? We have to understand first. The WHO has defined that health is a state of complete physical, mental, and social well-being. Just now we are listening the other speaker. That was the social well-being she was talking about all the time. It is not merely absence of disease or infirmity. And when we talk about disease only, this is one dimension. The physical health means the proper functioning of all the external and the internal parts and organs of the person's body, which allows the person to perform their daily tasks normally without any limitation. Mental health can manage the general life stresses, to be able to participate in society and to be able to work effectively. And social health, how the person interacts with the friends, family, and the society. Recently, the WHO is trying to include the emotional coefficient and the spiritual coefficient also, considering to include the emotional and the spiritual well-being to the definition. And I personally feel, unless these two things are considered in totality, we cannot cure the disease. Now, what happens in the development of disease? How disease appears? Initially, there is exposure. The stage of susceptibility, when the patient is okay, there is an infection or any other thing comes, and then a stage of subclinical disease, and the pathological changes appear inside the body, and then on the onset of the symptom, then the role of the doctor comes, and they at the stage of the clinical disease, and we treat like as we have already discussed, and then ultimately either patient improves or the patient succumbs. That is the usual story. And how this happens? Human behavior plays an important role in the spread of the infectious disease and understanding the influence of the behavior on the spread of disease. Human behavior is based on the attitudes, belief systems, opinions, and awareness of the disease. An individual behavior, when directed by mindfulness, meditation, and rational thought, can alter the course of the pandemic and reduce the morbidity which we have seen in the pandemic, in this epidemic, COVID-19 pandemic. In the COVID-19, we have seen, if suppose there are 100 patients who got infected through COVID-19, out of them, 90% patients, they improved without anything, even by knowing that they have ever got the infection. But the 10% patients, they developed symptoms. Out of them, the 5% patients, they improved with a little bit of medications or without medication. And the 5%, they became serious. Out of them, 4% they recovered, and 1% they succumbed and died. So this is the story. And the most important thing, I have treated personally thousands of patients. I know most of the important thing aspect beside the infectivity and other things, the immunity of the patient and its mental status. That in the second wave, the people were coming just by RT-PCR positive report, and they were thinking that they have received a death certificate. Death warrant has come, and I'm going to succumb. And that reduces the immunity altogether, and the patient never improves. I've seen many young people have died. This, to understand three-dimensional approach, we have to see that how our body parts, they work. You know, primarily, I don't have to explain it, there's a parasympathetic system and there's a sympathetic system. And both of these systems, they work. The sympathetic system works for emergency, and the parasympathetic works for the normal behavior. How a disease is produced? The sympathetic overactivity releases the stress hormones, which is cycle of the mental and physical disease, and it weakens the inner strength. Before understanding more, we have to understand, who am I? This is a very important question. We have never talked about it. I am, this body is not I am. This body, if you remove a hand, if you remove a leg, we don't die. We are energy. The human body is composed of billions of cells that use chemical and electromagnetic energy to maintain the homeostasis. Each and every cell of the body gets these two things, and electromagnetic waves, they flow throughout the body up to cellular level through nervous system. And all these things can be recorded as a EEG, ECG, EMG, and which we do every day. Body is just the functionality of the body is just the effect of this energy. When this energy goes away, the body is dead. A person comes walking or on a stretcher alive, and as soon as that energy flows away, we call it dead body. And the person is handed over, and we declare, now there is nothing. Now, therefore, we have to focus mainly on mental, emotional, and spiritual well-being. There is a general adaptation syndrome that initially there is a stress. The person can sustain it, and subsequently in phase 2 there is a resistance, and the person is able to cope with it. And third stage is a stage of exhaustion, when the patient is not able to cope physically as well as mentally and develop full frank disease. It may be treated or the patient may die. What is stress? We all the time talk about stress, stress, stress. In fact, we have become stressful by talking the stress. It is a mental state in which internal and external pressures exceed the inner strength. That is the coping mechanism. Then the stress appears. The vicious cycle of mental disease. The mental disease and the physical disease, that means the deviation from the ease, is the stress, is produces stress. That leads to germination of the negative team, and it actually originates from the negative team. I'll be talking about this team. The pathogenesis is the imbalance between the inner strength and the external stress. Negative team is the which causes this thing, and the extrinsic and intrinsic stress, it increases. The activation of the psychological factors, that is depression, hostility, isolation, type A behavior, personality, anxiety, all these behavior, they are developed due to the negative thoughts. The thought is the genesis of everything. We don't give that much importance to the thought. This whole body functions as per our thoughts. We have decided to organize this ACP workshop, ACP conference here. It is a thought. We are here sitting. We decided to become a doctor. We prepare for the exams, appear there, become a doctor. Everything is a thought. And thought, if it goes on a longer space, then it becomes emotions. If you continuously repeat the same thought again and again, again and again, then it becomes emotions. And ultimately, when it becomes fixed, then it becomes the attitude of the person. And this attitude is stored as a memory. There are two types of thoughts. One are the positive thoughts, another negative thoughts. Most of us are living in the negative thoughts. What are negative thoughts and what are positive thoughts? We have to understand that. And what they do, negative thoughts. Negative thoughts is jealousy, hatred, anger, ego. All those bad feelings which we create inside our body, that is the negative thoughts. And the positive thoughts is the lovefulness, blissfulness, happiness, peacefulness, good wishes for everybody. That is the positive thoughts. And it acts in the hypothalamus. They release the stress hormone when there is a negative thoughts, and then activation of neuroendocrine axis, sympathetic overdrive, and 3F response of the body system. That means whenever we are in a negative thought, we are all the time in emergency state. And what does this emergency state do? I'll again tell you that later on. And the positive team is again the same thing. But they are lovefulness, blissfulness, happiness, good feelings for everybody. Now these thoughts, they result into action. But you will be surprised to know there are certain things very specific for the mind which we really don't understand and don't follow. That's why we create these negative thoughts. The thought, single thought coming in the mind itself is so important that it multiplies very fast. Word and action are not that much important as the thought inside our mind, and it multiplies one neuron from one end to another end. It is transmitted, the electrical current is transmitted in 1 by 10,000 seconds. Try to understand. And then it stimulates the another neuron, and when it stimulates the other neuron, it doesn't stimulate a single neuron. It stimulates 10,000 neurons in 1 by 10,000 seconds. Speed is so fast, meaning thereby within a second time that thought which we have created spreads in the whole of the mind, whether it is positive or negative. If it is negative, then that electromagnetic current goes downwards. It stimulates the sympathetic system, sympathetic system, and it releases the neurotransmitters which are excitatory, and also all the hormones are released upside down. Now this is the thing which I have already explained to you. There is one more interesting fact we have discussed it so many times. Whenever there are negative thoughts, for example, jealousy, hatred, anger, fight, quarrel, there are so many things happening every day, comparison, competition. And when we are in normal harmony, then normal time, the free radicals, the reactive organism species, 60,000 free radicals are released in 1 second. And the mitochondria of a cell can metabolize this much. But it is when we are in harmony, when we are in peace, when we are in happiness. But most of the time, we are not in that stage, and we release whatever extra is released. When we are fighting and quarreling, it reaches up to 2 lakhs. And that can never be metabolized. That remains inside the cell. And every cell is in mitosis. Continuously it is dividing again and again. And when these cells divide, at that time certain cells are divided at a faster speed, and they becomes the cancer cells. When these oxidative free radicals are in this concentration, the immune cells, they are decreased. And what is the role of immune cells? Immune cells, they phagocytose the cancer cell, any foreign material, any bacteria, any virus, they phagocytose and they kill that thing. But when we are doing this type of behavior, the immune cell itself is in a too much shortage. So they cannot phagocytose, they cannot do this scavenger activity. That's why then the disease starts appearing. That is the reason that 90% people survived without any symptom even. And 10% people, they are succumbed. Nowadays, we were not made for the diseases. Our body was made by the Almighty to enjoy this world. But today, each and everybody is suffering on an average 2 diseases. This I've already explained. Metabolic syndrome is a classical disease which can be understood by this mechanism. I will not talk about detail in this metabolic diseases. I will talk about the telomeres. This has I've already mentioned the references, various references from where these data has been taken away. Telomeres are the caps at the end of the chromosomes. Short telomeres are the biomarkers for worsening the health and early death. The research has shown that meditation-based intervention may prevent the telomeres attrition or increase telomeres length, leading to longer lifespan. This is approved. We can change gene expression also by modifying eating habits and also by this type of behavior, which the parasympathetic behavior, and that's how we can upregulate the genes and we can and prevent the disease. And if we have a negative thought process, we upregulate the genes and it downregulates the gene and causes the disease. Everybody who has developed hypertension at the age of 40 years, diabetes at the age of 40 years, 45 years or 35 years, was he diabetic when he was born? Yes, he was diabetic since birth. But it was not expressed. The gene expression took place at the age of 35 or 40 years, meaning thereby that by that time his behavior was such pattern that all those genes who were responsible for diabetes or hypertension, they have expressed at this stage. And we can change it also. We can change by down-regulating these genes. We can change these things, and diseases can be prevented or stopped and can be cured also if we know how to change it. This is another very interesting story which has really changed my life. I will quote it here so that you can also change your life. This is a study conducted by the multi-centric trial, one at Maulana Azad Medical College, Delhi, and BJ Medical College, Ahmedabad, and Mount Abu Open Heart Study. It was done by Dr. Satish Gupta under the influence of Dr. APJ Abdul Kalam, the former president of India. At that time, he was the president of DRDO, director DRDO. And this study was sponsored by Ministry of Health and Family Welfare, in that study, what they did, the results were wonderful. Registration of those patients were done from April 2000 to 2001 to determine the contribution of the stress management through Raj Yoga, the meditation. The same diet, exercise schedule were prescribed to both the groups. 275 moderate to severe CAD patients were randomized, the healthy lifestyles and control group. I will not go into detail. I will just tell you the findings ultimate, what happened. The healthy lifestyle intervention led to modification of disease causing factors, leading to decreased anxiety, depression, anger, grief, particularly beneficial to the patients with a type A personality. Healthy behavior reflected in daily routine, like cessation of smoking, adherence to diet and exercise, and all achieved with success through meditation. The 93% patients who were registered in this, who went into this program, were improved, who were having triple vessel disease, coronary artery disease. They improved without any surgical intervention, without any angioplasty, without any CABG. And that was the wonderful results. I have met those patients also who were cured. I have met more than 24 patients who were cured by this disease, by this method, and they are all very happy. One thing we have also forgotten about the chronomedicine. This chronomedicine is coined by Franz Halbert, and this is the most important thing. It is said that he has coined the term, but actually in 1958, but actually this was known to since very Vedic time. The fact was known to our Indian scientists which were known at that time, rishis and munis from Vedic Kal, which instructed one to rise early in the morning and meditate between 3:30 to 4 o'clock in order to calm one's mind. This adds in the balanced hormonal release and prevents metabolic diseases. Circadian rhythm, I don't think I should go in detail because you know all these mechanisms. Sleep pattern. This is another important aspect which we have forgotten. In the morning, most of us are sleeping at up to 6 o'clock, 7 o'clock. The sleep during early morning between 4 to 8 a.m. is REM sleep. And the characteristic of this REM sleep is that it is associated with nightmares. Nightmares means you are sleeping, but your sympathetic system is activated. When sympathetic system is activated, everything will be upside down. Therefore, just asking people to get up early in the morning, it will cure him 50%. And we all know that insulin is released maximally in the morning time, cortisol is also released in the morning time, and therefore we must get up early in the morning. Healthy food is very important. This I don't think it is required at this time. One thing I would like to mention here, this is very important. We like non-vegetarian food for taste purpose also and for healthy purpose also we say. But very, very important thing we have forgotten, that whenever anybody, any individual, any animal is killed, at that time what happens? He is in agony, he is in fear. All those agony and fear and sadness is there. Even the mind of that animal is not that grown, not well developed, but even then it is there in their mind. And all those vibrations, they remain with that material, with that meat, whatever is there. And those definitely causes those things which we don't want. Now there's one more important thing. Initially, when we have studied the medicines, we were taught that we have to write RX before the prescription. Now I have rarely seen any prescription where this RX is written. We have started writing advised. Now advised is done by us. The RX is the Greek word which means take thou. I am writing this prescription on your name. When we give this responsibility to Almighty, then the things happens like miracles. Now this is something very important to understand. We have understood clearly that we should be happy, we should be peaceful, we should be blissful, we should be loving. We should do all those positive things. But whenever the time comes, when the situation comes, the old behavior comes immediately. Why? For that reason, we have to understand this. There are three parts of the consciousness. One is the conscious memories, third is subconscious memories, and third is the unconscious memories. These are the memories which we have lived throughout this life. Maybe in the past lives, we don't know, but this life we have lived, and those things, memories, goes deeper into the consciousness. And the conscious memory, which has learned just now that we should be blissful, happy, peaceful, this is only the 5% of the brain. The 95% majority, it inhibits. And automatically the frequency, the fastness of the afferent and efferent neuron system is so fast, 1 upon 10,000. Remember this figure, that 1 upon 10,000 of a second, it goes like this. Somebody has come here with some fearful mind and something wrong words in his mouth. And as soon as he comes, you become angry and you slap him. It takes fraction of a second. By the time you are able to understand that I should not do it, by the time things happens and you develop all that negativity, and ultimately it results into disease. How meditation helps in the managing the stress? In this what we do, our mind thinks as per our past experience. There are three parts of the mind. One is mind, there's the intellect, and third is the memories. The mind works 24 hours, 365 days. Intellect guides the mind what to do, what not to do. And intellect is guided by the memories which you have recorded. And all the memories are negative. Therefore, those all memories, they guide the mind and you do the wrong things. And the result is there, which we cannot prevent. In meditation, what we do, because we have understood that we cannot control it. Our mind is such a manner that we cannot control our thoughts. We have to do something extra so that we can control our thoughts and we do correct things and we can make ourselves healthy. The only thing is this, we have to write, meditation is to write the correct, we write the memories willingly, willfully in the right direction. That is really meditation, and that's how the disease-causing genes are turned off. There's a better oxygen consumption, there's a clarity of mind, thoughts big questions, and heart rate it slows down, parasympathetic system are regulated, and adrenal glands produces less cortisol. There's a deeper breathing, and that stimulates the parasympathetic nervous system for relaxation and better immune system functioning, and that's how the patient becomes better. Meditation, where we focus intensely on our breathing pattern, mindful breathing and concentration on positive thoughts, that is the basic concern of this. The take-home message is revitalize the practice of writing RX. Remember the God every moment whenever you see the patient. It does the miracles. Change your sleep pattern, go early to the bed, get up early in the morning, and diet, pure Suddha Sattvic diet, and lifestyle. We write every time lifestyle modification. Without knowing what is life, we write lifestyle modification, meaning thereby walking, yoga, this exercise, that exercise. That is not lifestyle modification. Life is a change of thought process. Until unless we change the thought process, we cannot change the life. So that lifestyle modification, we have to start writing this thing, that this side, you have to change the thought process, and thought process can be changed only by one method, that is meditation. Meditation also prevents bacterial and viral infection by activating immune system. Meditation prevents and cures the metabolic syndrome. Mahatma Gandhi has said it is the health that is real wealth, not the pieces of gold and silver. Therefore, we have to prevent the disease before it appears on the surface. And that's how we will become rich. When the diet is wrong, medicine is of no use. When the diet is wrong, medicine is of no use. And when the diet is correct, the medicine is of need. Medicine is of no need. There is no need of medicine. So the end message is, last message is that we should lead our lifestyle as a meditative lifestyle. That is known as, all the time, meditation is not sitting at what time and doing meditation. That you can do, that is a good thing. But throughout the day, just remembering the God all the time, you will think correctly. There is one special thing about the mind, which you have never noticed. There are two things I will tell you about the mind, then I'll close my subject. One is, mind is most fertile more than soil. Soil gives the same fruits, whatever you sow, but the mind multiplies million times immediately without knowing you. Second thing, that mind can think only one thing at a time. This is the better part. The mind cannot think the two thoughts at a time. So whenever we engage the mind, willingly, willfully, that you have to think this, then it cannot think negative. And when it cannot think negative, then it has to think positive. And when you think positive, the whole system becomes positive. And this is my confidence. I have experienced not only whatever I have talked, I have practiced also in my department, where I became the head of the department 3 years back. I emphasized the same things. At that time, one of my professors was having at least half a dozen diseases with metabolic syndrome and 130 kg. The other professor is having all the three syndromes, diabetes, hypertension, ischemic heart disease, leading to angioplasty and everything. And there were half a dozen court cases. There were many FIRs. There were this and that. Everything was going on there. I joined as a head. I said, what all this going on? This is not life. This is not life. You can't do anything. You can't achieve anything. You will remain sick physically as well as mentally. You have to change your attitude. And to your surprise, my whole department is changed today. Dr. Narsingh Verma is evidence of that. There is nothing, whole department moves alike. In 1 year time, because 2 years we have lost for the COVID, we developed so much work in the department, which was sleeping for last nearly 40 years, that we have developed Center of Excellence for the Pharmacovigilance. We are doing the prescription audit of the whole of the university. We have increased the seats, which were 4 for MD medicine, now to 26 per year. That means there are 78 students, MD students in my department, and we have established clinical pharmacology department with 4 seats of DM clinical pharmacology. Now, whole department is working like this. It is all because of this positive energy. I think we should develop this positive energy in ourselves, and we can do miracles. Thank you very much for patience.
Thank you. Thank you so much, sir. Professor Amod Kumar Sacha. Being a successful teacher, teaching pharmacology and therapeutics throughout your life, it means you teach the students about the pharmacological agents, their pharmacodynamics, kinetics, and so many other things. But being a teacher of pharmacology, you also taught us the other aspect, behind the mirror, what we don't see. So that part, why a disease occurs, how a disease occurs, and how to prevent the disease. Your lecture embodied those parts, starting from the genetic aspects, and you describe about the telomere, and you went to 3 components, the body, mind, and the soul. So we know from our little knowledge that a doctor who is a real doctor, he treats a patient physically with not only by his brain, but a real touch of the heart should be there. Without a touch from the heart, a doctor is never a doctor. So similarly, a patient who suffers, he has got also 3 components, what you have shown. That is body, mind, and soul. So the disease will not be there if we can practice a healthy lifestyle. What you have mentioned, eating appropriately and sleeping appropriately, thinking appropriately, all these components should come together. So for this reason, I like to say, well, these were practiced in the past. We also on occasion, some of the components are advised to our patient, but in a combination, starting from the Vedic part, the Ayurvedic part, and the most, your scientific part, you have described a lot. Thank you very much for your wonderful lecture.
Thank you very much. Thank you very much.
Thank you, sir. Please stay with us. Now I request organizers to bring that shawl for felicitation of Professor Amod Kumar Sachan. I invite Dr. Azad and Professor Maheshwari, our governor, to join for the felicitation of Professor Amod Kumar Sachan. I request our governor and Dr. Azad to Dr. Azad, it is your turn. Yeah, madam. उनको नहीं देगा, sir.
Bangladesh and India is very similar in one more thing. Both the countries has national anthem written by a
Single man, single man.
Rabindranath Tagore has written our national anthem. The third one is Sri Lanka. Yes, yes. I was just remembering who is the third one.
Thank you, thank you, thank you.
After this excellent lecture, we are moving towards the last but not the least session of the first day of this wonderful conference, that is ACP India Chapter Oration by Dr. Sanjay Agrawal. And for the session, I would like to invite Dr. Anuj Maheshwari and Dr. Tiffany Leong to please chair the session.
So this is a very important session and last but not the least of the day. So this is the most important one which we are going to keep in the end of the day. This is the ACP India oration. Dr. Sanjay Agrawal is being conferred this prestigious oration. Last 3-4 years, I think many of us must have witnessed that a lot of things has been done in the field of diabetes in India. When whole of the India was fighting with COVID and many people were sitting in their home being idle, it was the Research Society for Study of Diabetes in India was active one. And it was so much active that it was doing a lot of activities, and I felt from my core of the heart that this was the society who kept most of the doctors out of fear, out of anxiety, just keeping them busy. So obviously the 2-3 important persons were there, whom I can name that. Obviously Dr. Bansi Sabu is one of them, Dr. Vasant Kumar is one of them. But there was third person, very few people thought about him. So I thought that ACP should honor this person, and this person should be given this oration of the ACP India. So that's why we thought and we all decided to give this oration, confer this oration for Dr. Sanjay Agrawal. Dr. Sanjay Agrawal is the Fellow of American College of Endocrinology, Fellow of American College of Physicians. He is Honorary Secretary of the Governing Council of National RSSDI, and he is Invited Fellow of American College of Physicians. Member, Editorial Board, BMJ Open Diabetes Research and Care Journal. Associate Editor, International Journal of Diabetes for Developing Countries. He is member of Writing Committees for RSSDI Guidelines on Inpatient Management of Hyperglycemia, Consensus on Glucose Monitoring in Type 1 and Type 2 Diabetes, RSSDI ESI Clinical Practice Recommendations of Type 2 Diabetes, Guidelines on Management of the Diabetes and Heart Failure, Guidelines on Management of Diabetes and Oral Health, Guidelines Management of Diabetes and Thyroid Disease. He is author of the book which is known as Clinical Atlas in Diabetes, Chief Editor of RSSDI's Insulin Monograph, contributed chapter in various books, actively involved as principal investigator in landmark international research trial, faculty at various national and international meetings, mentor for the postgraduate program. So I think many more things can be added in this list. Without wasting much time, like to listen Dr. Sanjay Agrawal on wonderful topic, what he has chosen for himself, elderly care, managing glucose care in elderly and terminally ill patient. And that is very much important, especially for the ACP members, because many a times we come across this kind of the situation. Over to Dr. Sanjay Agrawal.
Thank you very much, Anuj, for this wonderful introduction. I'm very humbled. And I would also like to thank ACP for giving me this honor of giving the oration for this year. I would like to compliment the entire organizing committee for this wonderful scientific meeting that you have, and the witnesses, of course, the number of people that you see at the last lecture present here. It just speaks volume of the scientific content of the meeting. So great job done, and compliments to the entire team. I chose this topic for my oration because I think this is one of the most important topics that we don't talk too much about. And we keep concentrating on various aspects of diabetes, but today we do recognize that diabetes in the elderly has special challenges, and we need to approach it differently than what we do in our conventional patients. We are seeing that, we know that, diabetes is shifting more leftward, and we are seeing diabetes in the Indian population, more and more younger population in second and third decade. But our longevity is also increasing, and we are seeing a lot of these patients reaching adulthood and, going beyond 60s and 70s. And a lot of people do get diagnosed even at a later point of life. So obviously our approach to such patients who come to us in later part of their life has to be something different than what we do in our early years of, on the entire spectrum of lifestyle. Let me quote this paper to you, which is a National Sample Survey organization, and they looked at the period from 2004 to 2014. And this is from various parts of the country. And you can clearly see here, in the last 10 years, there has been a rise in the number of people who have presented beyond 60 years of age with diabetes. And this is not sort of a certain section of the country that you're looking the data from. You're looking from north, south, east, west, as well as in central. But what is more alarming is the fact, if you look at this paper further, is they've broken it down to rural as well as urban. And they've looked at from the period 2004 to 2014. And here you're looking at three subsets of population: patients who presented with diabetes only, patients who presented with diabetes and one comorbidity, and patients who presented with diabetes plus 2 or more comorbidities. Now, if you look at the shaded diagram, you can see here that over the last 10 years, ending 2014, more and more people in the elderly group has presented with diabetes and comorbidities. And the bracket of people who have presented with only diabetes has really become much less. So obviously, when you look at the elderly population, you're not only looking at glycemic control, but you're looking at obviously more beyond that. You have to address various comorbidities that come with diabetes with the patient. Now, what makes a diabetes in an elderly patient stand apart? We know that they have a heterogeneous health status, and this heterogeneity comes from function, comorbidity, as well as from longevity. And older individuals possess varied healthcare values. There is burdensome in some, so not everybody has got an approach which is, okay, I have it, let me just deal with it. Some of it regarded like a burden, and they find it very difficult to cope, and they have very difficult coping mechanisms. And obviously, the priorities of care are greatly affected by the comorbid conditions that they carry with them. Now, let me illustrate two cases to you, which will drive home this point. The first case is a 75-year-old lady, has diabetes for 10 years, has associated hypertension, dyslipidemia, and has had a previous myocardial infarction on medical treatment. She's widowed, lives alone, and manages the activities of daily living and IADLs, has pension benefits, has severe osteoarthritis, and walks with support. And currently, the patient is on glimepiride 4 milligram daily, metformin 2 grams, and pioglitazone 15 milligram. The patient hasn't undergone any evaluation for monetary reasons and has lack of support to take care of her. Occasional documented hypos have been presented. Now, examination-wise, she has systolic hypertension, severe arteriosclerosis of the radial arteries, has pallor, edema. Labs are very distinguished. The fasting BSL is 98, post-meal is 120, A1C is 6.3, creatinine of 1.78 with a calculated EGFR of 28, and has dyslipidemia. And ECG just shows old anterior wall MI. The question that we need to ask ourselves, what should be her target goals? And clearly you can see in this patient that she's overcorrected. She's getting probably asymptomatic hypos and carries a lot of risk. And remember that every hypoglycemia in the elderly only worsens their cognitive functions. And we have to try and avoid hypoglycemia in all patients. So if I were to choose, I would probably electively, with all these comorbid conditions, keep their target goals higher than what has been achieved. So clearly, it's not that these goals are good for an elderly population. The second is, of course, what are the scope of interventions to improve the quality of life that you see in this patient. So it's not just presence of diabetes that we should be really looking at, but also how can a person with so many comorbidities, factor and lead probably a better quality of life. And we have seen just last 2 lectures by Dr. Stephanie and by Dr. Sachin that, they have talked about the mind and the body and how important that is in terms of functionality. Now let me give you another case. She's a Mrs. B, 78-year-old patient, excellent control for the last 14 years, managed on oral agents. She's been a primary caregiver for her husband, who was recently institutionalized for dementia. Now she starts complaining of a lot of fatigue, consulted a physician who found that there was a certain deterioration in her blood glucose values. During a conversation with the doctor, he noticed that there was a change in her behavior because he's been monitoring her for a long period of time. And while testing for depression, the patient became tearful during the questioning. She mentioned that she stopped watching her diet, skips meals, hates to cook for herself, does not exercise, and avoids getting out of the house. So clearly you've got another set of patient who you can see here has different challenges. And these are mental challenges, and loss of one spouse clearly puts a burden on another one, and coping with that stress becomes very difficult. And this clearly sort of, they let go of themselves, get uncontrolled, and obviously we should have a different sort of an approach for such a sort of patient. There was a study which looked at that what is the functional impairment in the elderly with diabetes when they come to you. And you can see here that almost about half the people in all the, in the population tend to have hearing impairments, vision impairment, recent falls history, fearful of falls, and of course have challenges with ADL and IADLs. So what is different? Again, I ask the same question in older adults. Remember that 50% of our older adults remain undiagnosed. And very often the early signs of metabolic abnormalities are missed out, because if you look at the conventional guidelines, we talk about HbA1c and fasting plasma glucose estimations for diagnosis. Clearly, in an elderly population, you don't see a rise in the fasting. You see a postprandial glucose elevation much more than fasting. So if you're not monitoring the postprandial glucose values, very likely you're going to miss out the diagnosis of diabetes in the elderly population. Often, the onset is very gradual, and the features of presentation may be mistaken for the aging process. They may have dexterity and coordination issues, and as well as mobility and physical activity, which may result in reduced aerobic capacity, decrease in the lean body mass, and increase in the fat mass. And this may all sort of bring down that they may not be very functional, put on weight, increase the insulin resistance, and probably tend to develop a worse off blood glucose values than what you would expect them to be if they were active. So the pathogenesis of hyperglycemia in the elderly is, of course, reduced insulin secretion, increased adiposity, decreased physical activity,